in the time of COVID. So at 2020, boundary of the Bardhaman or the South Bengal or the whole West Bengal, it is now Indian. Even someone from any country outside India, he can click the link and he can see, he can hear, he can ask questions regarding all our academic endeavors in proper manner. So that is one achievement after COVID we have. So with these few words, what I tried to imply, that without the endeavor of ours, not only the 8 or 9 members academic committee, but with few members present here, as well as many members of our ABCD, which actually in Burdwan crosses 140 plus, and I am sure many of them will come again with Abcdcon, and without their physical or moral support, we could not be successful. So with that, and with thanks to everyone, including the pharma houses who worked with us relentlessly, I will give the thanksgiving at the end of the session, but right now I am thanking each one of them, and I am sure that all of you will encourage us in future to conduct this conference, which is now global actually without geographical boundary, to conduct more and more in future years. Thank you. Dr. Banerjee.
Yes, we are ready for the next session. Dr. Ashok Kumar Porida has arrived.
Okay.
And for technical need, we need a few minutes, 2 or 3 minutes, and we will be on with the next session. For this, by this time, I request my youngster colleague, Dr. D.K. Gupta, who's to give a few words about this conference.
Thank you, Arnabda. I would like to thank my president and all the members of ABCD and also the pharma industry for supporting us for this extravaganza program. And as lot has already been said, I don't want to add anything. I offer my heartiest welcome to all the delegates, and I would ask each and everyone to join us either physically or through virtual, so that we can make this academic extravaganza a great success. Thank you.
Good morning again. We are ready for the next session. For this next session, we have a very respected speaker and cardiologist from Durgapur, Dr. Ashok Kumar Parida, who will be speaking about the newer approaches in heart failure patient. To chair this session, I invite Dr. Subrata Bhattacharya and Dr. T.N. Banerjee in the dais.
Good morning again. And this topic is a very interesting topic, heart failure. You know, India is the diabetic capital and also a hypertensive hub. And both these things contributes to this heart failure. And with the advancement of this science, we are able to live longer. And this aging process is also contributing to the incidence of heart failure. And though if you look at the history, when we were student, when we were doing these PGs, we used to have only few drugs in our hand. And the only thing is that you have to use Lanoxin and all this diuretics, not much in our hand. With the advancement of science, we have seen how the management of heart failure have progressed. And I don't take much time because we have got a master speaker with us, and he is going to deliver this subject. And may I request Dr. Subrata Bhattacharya to introduce Dr. Parida, please.
Again, good morning. Today, we know there is advancement of medical science. It is not dead subjects. So today we'll discuss about the progress of treatment of heart failure. Before it was classified differently, but after the advancement of the echocardiogram, we classify the heart failure with reduced ejection fraction and with preserved ejection fraction. And the new approaches are RNA and SGLT2I are very much we used. In this aspect, I request Dr. Ashok Kumar Parida, who is the MD, DNB, MNMS, FSCC, and Senior Interventional Cardiologist and Vice Chairman, the Health World Hospital. He is not only known to in West Bengal, Kolkata, Durgapur, but also well known to the in the cardiology as a cardiologist in the Indian picture. So I request Dr. Paridha to speak something about the ARNI in reduced ejection fraction heart failure.
Good morning. Really, I am grateful for inviting me to this August gathering. So, I think first time I am coming to this conference. And Dr. Ganguly sir is with me. He was my mentor from my college days, and he told me to participate for the good gathering of all the physicians here. So I have prepared few slides. I think it will be an interactive session if possible, if the time permits. And today my topic is ARNI in heart failure with reduced ejection fraction. Before going to ARNI, let me tell you, congestive heart failure is the most important risk factors nowadays for in-hospital morbidity, mortality. And nowadays, as the life expectancy is increasing and our approach to coronary disease is getting intervention based, so congestive heart failure patient admission number also increasing. And these AC inhibitors and ARBs we are using in heart failure patient, in spite of AC inhibitors, ARBs, beta blockers, still congestive heart failure patients are having mortality and morbidity is much higher than any other population. Now the more focus is switched over to natriuretic peptide family group, because we have already tackled RAS and RAS group. So what is this natriuretic peptide? The natriuretic peptide group is having three components. One is ANP, another is BNP, and another is CNP. We have to try to understand this mechanism of action, then we can understand how ARNI is helping us. Unless we understand this one, then just we can't think how we can modify this drug in the treatment guideline. ANP is localized in the atria. BNP is localized in the ventricle. They act systematically in the systemic circulation. And another is CNP. CNP is locally, they are available in the myocyte. They act only locally, they can't act in a systemic way. How they help? This ANP and BNP, they inhibit the remodeling. That means they have cardioprotective effect. They cause vasodilation. They cause natriuresis and diuresis through kidney. They act on the endothelium, which causes vasodilatation, causes decrease in blood pressure, and they act on smooth muscles, so which prevents fibrosis and will decrease peripheral resistance. And this natriuretic family, they have dual action. They inhibit the side effects of RAS activation. In congestive heart failure, what happens? There is activation both renin-angiotensin system and sympathetic nervous system. So if we can inhibit the side effects of the renin-angiotensin system and sympathetic nervous system, then we achieve some goal. In spite of that, but we are not achieving the full target of decreasing morbidity and mortality. So this natriuretic family, they act themselves, even they act on the RAS system and the sympathetic nervous system. How they act? These natriuretic peptides, what they do? They cause vasodilatation. But the problem is that they got easily digested by endopeptidase. They get breakdown by endopeptidase. If we can prevent this breakdown of ANP and BNP, then they can act by having their positive effects. This neprilysin is the endopeptide, where the ANP and BNP get attached and they get breakdown. But the neprilysin has also another effect. They cause breakdown of angiotensin II. Angiotensin II having side effects of RAS system. So if you are inhibiting this molecule, then we are having the side effects of angiotensin II, which will increase. Though BNP and ANP will increase, having positive effect, simultaneously, angiotensin II level also increase. Am I clear? Because angiotensin II also getting degraded by the neprilysin receptor. So once you will block this receptor, it will have positive effect, like ANP, BNP will increase. Simultaneously, angiotensin II level also increase. So that's why, if we will block this receptor along with 81 or 81 receptor, then only we will get the desired effect. And this ANP and, because angiotensin II, if they will get accumulated, they will act through the 81 receptor, which will cause vasoconstriction, cardiac fibrosis and hypertrophy, and leading to sodium and water retention by increasing aldosterone secretion. And the same way, ANP and BNP, if they will get accumulated, they will cause vasodilatation, they will cause cardiac fibrosis, decrease cardiac fibrosis and hypertrophy, and increase natriuresis and diuresis. So the trials have started with candacetalate, which inhibits only neprilysin. But that trial was a failure trial, because after inhibiting neprilysin, they have increased angiotensin II also. So in that trial, that drug didn't cause blockage of 81 receptor. So we got all the side effects of 81 receptor. And another, then came the molecule omapetrelate. So omapetrelate trial was done with SE inhibitor. Even desired effect we didn't get, because side effects of omapetrelate. What is the side effects of omapetrelate? That cause increase in angioedema in comparison to SE inhibitor. So the trial was a failure. Because why there is increase in angioedema? Because of increase in bradykinin. Okay. So why bradykinin is increased in comparison to SE inhibitors? Because bradykinin also get degraded by SE. Bradykinin get deactivated by two more, by neprilysin receptor and by the SE inhibitors, SE. So if we are blocking SE, then bradykinin will be accumulated, because omapetrelate was blocking SE and was not blocking 81 receptor. Okay, so that's why angioedema was much higher. So this type of omapetrelate is a neprilysin inhibitor, but it was not accepted. So then came the ARNI. What is ARNI? ARNI is angiotensin receptor and neprilysin inhibitor. So that means it will inhibit neprilysin, simultaneously it will block 81 receptor. This is the slide. It is showing it will inhibit 81 receptor and it will block neprilysin also. This is a combination of LCZ696 molecule, which has two things. One is combination of valsartan and pro molecule, that is sacubitril. So sacubitril acts on neprilysin and valsartan acts on 81 receptor. So that's why it will have the desired effect what we want in case of congestive heart failure patients. So this is a very good slide. It is showing it is inhibiting angiotensin II receptor blockers. By inhibiting angiotensin II receptor, we are decreasing blood pressure, we are decreasing sympathetic tone, we are decreasing aldosterone level, we are decreasing cardiac fibrosis and hypertrophy. By inhibiting nitripeptide degradation, we are decreasing blood pressure, decreasing sympathetic tone, decreasing aldosterone level, and decreasing cardiac fibrosis. By increasing bradykinin, we are decreasing blood pressure, increasing nitric oxide, and increasing natriuresis. So it enhances vasodilatation, it enhances of lower blood pressure, it enhances reduced sympathetic tone and reduced aldosterone level and natriuresis and diuresis. It inhibits vasoconstriction, inhibits elevated blood pressure, inhibits aldosterone elevation, and inhibit fibrosis. So all this helps in reduce wall stress, decrease LV end diastolic pressure, decrease vascular resistance, which is required in case of treatment of all congestive heart failure patients. So came the molecule, and it was tried in Paradigm HF trial, but this molecule was not come as a comet from the sky. It was after 10 decades of research we have reached in this molecule. So you can see from this graph that renin was discovered in 1900, and SE was isolated in 1970, and first ACD was introduced in 1978, and first ARB was introduced around 1980, and omdapetrolate was tried in 2000. Then came the Paradigm trial in 2010, which was the landmark trial, which changed the paradigm of treatment of heart failure. And in this trial, the patients included were more than 18 years, and all patients having either class 2, 3, or 4 symptoms, ejection fraction less than 35%. The NT-proBNP level should be more than 600, or it should be more than 400 if there is a history of heart failure in last 12 months. And what patients were excluded? Patients were excluded with history of angioedema with ACE inhibitors, with ejection fraction less than 30 ml, if serum potassium level more than 5, if systolic blood pressure less than 100, and acute decompensated heart failure and patients with pulmonary disease were excluded from this trial. And what was the primary endpoint? The primary endpoint was time to first occurrence of either cardiovascular mortality or heart failure of hospitalization. There are other secondary endpoints and key exploratory endpoints. So the primary endpoint is to heart failure mortality and hospitalization. And what we achieved in Paradigm trial? There was in both arms, there are almost 4,500 patients in both the ACE inhibitor arm and the ARNI arm. So the primary outcome was there is 20% reduction in cardiovascular death and heart failure hospitalization. There is 20% reduction in cardiovascular mortality. There is 20% reduction in heart failure hospitalization. And in secondary outcomes, there are almost 16% reduction in all-cause mortality. And the safety results, in safety results also, the ARNI does better in comparison to enalapril. So what is the indication from this trial? The ARNI is indicated to reduce the risk of cardiovascular death and hospitalization for heart failure in patients with chronic heart failure and reduced ejection fraction. In this trial also, the patients, those who are requiring hospitalization, the requirement of vasopressors was drastically reduced in comparison to ACE inhibitor arm. And in follow-up also, it has shown patients requiring device like CRTP and CRTD was drastically reduced in comparison to ACE inhibitor arm. So it has all favorable effect with ARNI arm. Dose and administration, what the dose was trial. Though in the practice we are not able to achieve this dose, but we should try to give the dose which was used in the trial, then only we can get a beneficial effect in our patients. The target dose of ARNI was 200 milligram twice daily. And the recommended starting dose of ARNI was 100 milligram twice daily. A starting dose of 50 milligram twice daily is recommended for patients not currently taking ACE inhibitors. Suppose patient was taking SE inhibitors, we have to wait for 2 to 4, at least 36 hours as a washout period. And after washout period, you can use ARNI. After using ARNI, if you want to escalate, at least you have to wait for 2 to 4 weeks to go to the higher dose. So ARNI is available in 50 milligram, 100 milligram, 200 milligram tablets. And what is the contraindications of using this molecule? The contraindication is hypersensitivity to active substance like sacubitril, valsartan, and concomitant use of SE inhibitor is contraindicated because it will increase serum potassium level, and known history of angioedema either with SE inhibitors and ARBs, this molecule should not be used, and concomitant use with aliskiren in patient type 2 diabetes and mellitus, though you are not using. And another is pregnancy. Pregnancy is contraindicated of use of this drug. So what is we get from this ARNI? That is reduction in ventricular wall stress or improvement in ventricular function. This cause reduction in occurrence of electromechanical dissociation. In the ARNI arm, there is decrease in atrial fibrillation and ventricular tachycardia in comparison to SE inhibitor arm. And there is reduction in myocardial fibrosis, reduction in ventricular hypertrophy, attenuation of progressive ventricular remodeling, leading to modification of substrate for fatal ventricular arrhythmias. That lead to decrease in device therapy in ARNI arm in comparison to SE inhibitor arm. Anti-atherosclerotic, anti-thrombotic effects of enhanced natriuretic peptide expression, there is improvement in regional myocardial perfusion. So hospitalization decreases. This is one of the reasons also why hospitalization decreases. Even at stress thallium also they have shown myocardial oxygen requirement is reduced in case of ARNI arm. And there is lower levels of N-terminal pro-BNP in ARNI in comparison to SE inhibitors. Once patients getting treatment in OPD, if you do serial anti-pro-BNP, then with patients getting treated with ARNI, the anti-pro-BNP is drastically reduces and always in the lower level than in the SE inhibitor group. So ARNI having incremental benefit due to neprilysin inhibition. So once you use lower dose, slowly and slowly you should try to achieve at least 200 milligram. I have never seen a prescription you are using 200 milligram. Maybe the trial was done in the Eastern Europe and American subcontinent, and here the body mass built, I don't know. That might be one of the reasons our patients don't tolerate more than 100 milligram. Either they will have hypertension or they will have hyperkalemia, they don't tolerate more than 100 milligram. There will be symptomatic postural hypertension symptoms in patients more than 100 milligram. But in the trial they have used up to 400 milligram, 200 milligram twice daily dose. So what is the key takeaways? So it is a novel drug, a dual inhibitor of angiotensin II receptor and neprilysin inhibitor can change the management of heart failure. And the results seen with paradigm heart failure apply to a broad spectrum of patients with heart failure. So after this trial, we should always try to use ARNI where patient can afford and patient tolerates, because affordability is also a question because it is a costly medicine. At this present maybe because of patency rule. So at least we should try to use as much as possible. Thank you.
This nice deliberation. I'm inviting 2 or 3 questions from the audience. They may ask the questions directly to the Dr. Parida.
Hello. Thank you very much for your well deliberation and your pharmacokinetics and dynamics. You just very easily demonstrated the thing. My question is that when the patient is admitted with heart failure in your patient and patient is not taking ARNI, at that time what is the protocol to start your ARNI if the patient in the ICU, and when you start the ARNI? It is my
Sir, in patients with acute heart failure, usually avoid this ARNI.
Yes.
Before discharge, we always add ARNI, because after using diuretic,
Yes.
then patient stabilizes, then go with ARNI. Before discharge, patient should be on ARNI.
Usually, a patient on admitted, there is a patient on hypotension actually. Patient is not at.
Yes.
We are to give that.
So in
what
acute
will
heart
be-
failure-
what will be the starting dose? Because we are very cautious regarding the hypotension also. So at that moment, it is 100 milligram BD or 200 milligram BD as the protocol is there, because study is started with 200
Yes, sir.
milligram
As I've
BD.
told, shown one slide, I've
Yes.
shown we should start with 50 milligram twice daily. It
Yes.
should be a twice daily dose.
Yes.
So it should be at least we should start with 50 milligram twice daily.
Yes.
But practically speaking, in my OPD, when the patient comes
Yeah.
or before discharge, we usually start 50 milligram half tablet twice daily. How the patient responds, we don't know.
Yes,
And
that is
most
the
of
thing
our
is that.
patients, the body mass index is very less.
Yes.
So they develop postural hypertension very frequently in
yes.
comparison to Western world. So
yes.
our trial is with the Western world, not with the Indian subcontinent. So
Obviously.
better we should use as per our requirement.
Thank you very much.
Yeah. And while using ARNI, we should try to reduce the dose of diuretics. If patient not in heart failure maintaining saturation more than 95%, always try to reduce the dose of diuretics.
As patient coming on follow-up.
Yes, sir.
On the follow-up, because
Follow-up, you
it-
should try to
already
reduce the
it
dose of-
already it has a
Yeah.
diuretic effect, so you have to.
And in
reduce
this trial, there was 60% in both arms. Patients were using beta blockers.
Yes.
60% patients on a beta blocker. So all the patients should try to keep in beta blockers along with ARNI.
And another thing is that when the patient is coming, usually heart failure, their oxygen consumption is reduced. So in that, you giving nitrates in that patients in case of heart failure.
Yes, it is also having positive vasodilatation activity.
Yes.
So it will help much, I don't know. Dr. Ganguly sir, any
Oxygen consumption, actually demand is there, so you can give the nitrates or not. Yes.
See, you can have three cocktails: reducing preload and reducing afterload. That is the objective. Patient comes to you with an acute heart failure and hypotension is for two reasons. One, increasing preload afterload, and two, increasing in myocardial oxygen demand, which reduces the contractility. So very clearly the initial part is diuretics and diuretics and diuretics. Do not start beta blockers, do not start ARNI at that point of time. It is only in the stable part, okay? Nitroglycerin, if blood pressure permits, you can use it as a vein offloader. It reduces the preload in the ICU if the patient is hypertensive. But if the patient is normotensive or less than that, in that situation nitroglycerin will cause more of hypotension. So this was a time when we used to combine hydrolyzin and nitroglycerin as afterload and preload reducers, because at that time there was no ACE, there was no ARB, there was no ARNI. Still today it is the second line therapy, but not the first line. When there was no ARNI, no ACE inhibitors, we used to start nitroglycerin in ICU, followed up with nitroglycerin also in discharge. But right now, no. Right now, no. In acute heart failure, you manage with diuretics, send them home on diuretics and ACE inhibitors. We usually have started using valsartan because keeping in mind ARNI will have to be used. ACE inhibitors, ARBs and diuretics, you send the patient home. Patient comes on fast follow-up, try low-dose beta blockers, try low-dose ARNI. That it is a dosage which we have found, half tablet, more than that people cannot tolerate. That is why this ARNI का वो एक ही tablet है, जिसको स्कोट tablet है, हम वही use करते हैं. We use that one because that gives you the division of dosage. After that, you build it up whatever you like. That should be the principle.
Dr. Paida, one more question. Nowadays, we use frequently ARNI and SGL2I. Okay? may we use both simultaneously or
Yes.
one by one? If one by one, which should be the first of your choice?
ARNI should be the first choice, followed by SGLT2 inhibitor.
But in a setup, you have to use this DAPA, this SGLT2 inhibitor. Then you subsequently use this ARNI. In acute setup,
In my setup.
acute setup, in acute LVF.
Acute setup, you can use SGLT2 inhibitor followed by ARNI in the follow-up.
As because both they complement each other, they are not this competitor.
No, they are not competing, they are competing each other.
They can be simultaneously as well.
Yes.
Actually, sir, if we combine the SGL2 as well as ARNI, in your experience, just I ask you, there is no study till that. There is better benefited patient get the better benefited if you use both combination is going on.
Many of my patients,
ARNI with SGL2.
many of my patients are getting combination of both the medicines, and I have seen after using this ARNI, many patients for last 2 to 3 years, their frequency of hospitalization is drastically reduced. Those who are able to afford ARNI, their hospitalization is drastically reduced in clinical practice.
And if the patient is on SGL2 also, so there is a better benefited patient get it better benefited.
And that I have not seen.
You have any study?
I have not.
Three wonder molecules of last 3 decades. Resurgence of anecdote, SGLT2 inhibitors and ARNI. These are the 3 molecules which have changed the face of cardiology in last 20 years.
Aldosterone is fixed and you may use this.
Regarding this HEPA, HEPA is also very common, just 50%. They are HEPA. Why it's not working in this molecule is not working in HEPA?
Sir, heartfully with preserved ejection fraction, because of the paradigmatic trial has shown that is secondary endpoint, it is helping.
Not that
Paragon trial. It is the primary endpoint, there is p-value was not significant, but the secondary endpoint, there was beneficial effect to the ARNI.
So you would recommend this
Yeah.
molecule in this HEPA as well?
Yes, sir.
So, no more question?
No.
Thank you. Thank you so much.
Thank you so much.
We welcome Dr. Ashok Kumar Parida again to hand over a memento on our behalf, and I would request Dr. Subrata Bhattacharya, our president, to please hand over the memento to Dr. Ashok Kumar Parida. Thank you, sir, once again for your excellent lecture. A big hand to Dr. Parida. So, once again, we are ready for the next session, and for the next session, we have a different offbeat topic. Actually, we have decided we should go with multiple facets of medical science. So, we have a topic of OSA, that is obstructive sleep apnea, with particular reference to diabetes. For this, we again have a very bright young speaker, Dr. Arup Haldar. To chair this session, I would request our senior chest physician, Dr. Mongolmoy Ganguly, and once again our bright youngster chest physician from Bardhaman, Dr. Arnab Maji. Chairperson, sir, please come over the stage.
Thank you, the ABCD organizing committee for giving me the chance to chair this session. Obstructive sleep apnea is an unrecognized and underdiagnosed problem, not only in India, but also all over the world. And it has associated with some hidden comorbidities like cardio-diabetic comorbidities especially. It can be associated with diabetes in near future, and the management of OSA can also lead to dysregulated glucose metabolism in the process. And it can even also give rise to sudden cardiac death in near future in a patient diagnosed with OSA. So it is very important for us to diagnose a case of OSA in a patient and to manage it properly. To discuss all these issues, we have with us today Dr. Arup Haldar, who is an consultant pulmonologist attached to Woodlands Hospital, Kolkata. He is also in charge of Institute of Sleep Sciences, Kolkata, and Sleep Vision, Kolkata. He has 18 publications in national and international journal. He is a content writer in World Sleep Academy USA and member of World Sleep Society. He is a regular blogger and has more than 2,000 readers across the globe. He is a mentor of Clean Air Medical Student Ambassador Program by Switch On Foundation. So I welcome Dr. Arup Haldar to deliver his speech on this topic. Thank you.
Thank you, Association of Bardhaman Cardiologists and Diabetologists, and special thanks to Dr. T.N. Banerjee and Dr. Arnab Banerjee for this invitation. It's an immense pleasure to be present in front of such esteemed audience. And today I'm going to discuss on a topic which is very relevant nowadays, and this is called obstructive sleep apnea with particular reference to diabetes. So obstructive sleep apnea, as you all know, is a disease of the upper airway, and diabetes is a disease of insulin dysfunction. So how these two diseases are related? Actually, these are all chronic conditions, and any ripple in stagnant water, these are the actually ripples of chronic inflammation in the stagnant water, and when two ripples merge together, they produce a different wave. So in my presentation, I will show what are the connections between obstructive sleep apnea and diabetes. But before to start, I will start with obstructive sleep apnea first, few slides. These two pictures actually show what we previously were. We are the hunter-gatherers, and what we are now. We used to be very much active physically, but nowadays, after the Industrial Revolution, there is a change of the environment, there is a change of the behavioral habit, and there is a change in the diet. So all these caused a tremendous revolutionary pressure or evolutionary pressure inside us, and thus made various metabolic disease very much common. Oh. I'm sorry, I've looked at the screen. Okay. This is coming here in the screen. Should I continue? I will catch up with the slides. Okay. So previously we are the hunter-gatherers, and now I will show you what we have become actually. We have become more lazy, more obese, and we are spending much more time on social medias, no more exercises, and that caused a lot of metabolic disease nowadays. So to define sleep, this is very difficult to define sleep actually. Sleep actually evolved from the light and dark cycle. Because of the evolution of the rotation of the earth, we have light and dark cycle, and the primitive organism that has evolved into the rest and activity cycle, and we have the circadian rhythm from that, and in higher animals this rest and activity cycle has been transformed into sleep and wake cycle. So sleep is seen from any organism which have a complex ganglia, but before that it is the rest and activity cycle. So sleep is defined as a self-organizing property of any group of viable interconnected neuron which has a complex ganglia, and it provides a synaptic stabilization of our central nervous system. We are all aware what happens if we do not sleep for one night. We become groggy, we cannot concentrate on any issues. So sleep is required for memory, sleep is required for physiological function. And for higher animals, we have mainly two stages of sleep. One is called the non-rapid eye movement sleep. This is the 80% of the sleep, and followed by the rapid eye movement sleep, which is often called the dream stages of sleep. So actually, our awareness or existence has three stages. Either we are awake, or we are in the NREM sleep, or we are in the REM sleep, or that means the dream stages of sleep. And the EEG changes according to the depth of sleep. In NREM sleep, we have a low amplitude, high frequency activity, and that activity actually diminishes, and it becomes a high amplitude or low frequency activity as we progress deep down in the sleep. And in REM sleep, we have muscle atonia, we have dream, so that we cannot react out of the dream. So that nature has made our muscle atonic, so we can't react in our dream. And this happens in OSA. During sleep, we are in a disadvantageous position from the respiratory point of view because the diaphragm shifts caudally, so there is decreased functional residual capacity of the lung, and it decreases the tracheal pull. Actually, when the diaphragm is going downwards, it pulls the trachea and it makes the upper airway open. But when you are sleeping, then the diaphragm goes upwards. There is decreased FRC and decreased pull on the trachea, and there is a chance of upper airway collapse. And upper airway is defined by different anatomical positions. So upper airway starts from the nose, then we have nasopharynx, then we have oropharynx, then we have hypopharynx, and then larynx. The upper airway is called the Starling register. In between the rigid portions, there is a collapsible portion, that is the pharynx, and the upper airway collapses either in the retropalatal or the retroglossal region during sleep. And if this collapse is partial, it produces the laminar flow of air to become a turbulent flow, and that causes vibration in the wall, and we have snoring. But if there is a complete obstruction, air cannot go into the lung or carbon dioxide cannot go outside. That causes a change in the pH of the blood. That causes the brain to wake up repeatedly, and this is the electrophysiological arousal. And because of the arousal, we are not going into the deep phases of the sleep, and we feel sleepy next day. And with each arousal, there is a sympathetic discharge, and the repair of the body, which occurs during sleep, is jeopardized in obstructive sleep apnea because of the poor sleep quality. But it is not only the obstruction. Obstruction is the prerequisite to develop obstructive sleep apnea. But apart from obstruction, we have various other phenotypes which are important to develop sleep OSA. Because we have all noticed that some nights we snore, some nights we do not. We have the obstruction, but we do not have other physiological features that night, so that we are not snoring that night. So apart from obstruction, a lower arousal threshold higher loop gain or ventilatory instability or lower muscle responsiveness, especially the upper airway dilator muscle responsiveness, which keeps the upper airway open during sleep. These are the other causes which can cause obstructive sleep apnea even with trivial obstruction in the upper airway. So based on that, we have formulated the PALM scoring, and PALM scoring tells us if the PALM scoring is 1 or 2A, we have more of anatomical obstruction, but if it's PALM scoring 2B or PALM scoring 3, we have more of the physiological variety of obstruction. This is a typical epoch of polysomnography, which is usually done to diagnose obstructive sleep apnea. There are various types of polysomnography. In lab, polysomnography is called the type 1 polysomnography, but it can be done at home also. That is called a level 3 polysomnography or type 3 polysomnography. And this is a typical epoch of a polysomnography, and it measures several channels, like it measures the electroocculogram, the EEG, the flow channels, the effort channels, ECG, oxygen saturation, leg movement, body position, etc. Different, at least 7 channels should be there to measure the different physiological parameters in obstructive sleep apnea. And this is a typical report of a PSG. It contains multiple parameters. But what we usually see, the apnea hypopnea index, but I will urge you not to go for the only index or only apnea hypopnea index. We should see the what is the total sleep time, what is the desaturation index, and what is the body position in which the OS has occurred. And this is called a hypnogram, which is a panoramic view of the whole sleep. And this particular hypnogram is showing severe desaturation and severe obstructive apneas and hypoapneas during the sleep. This is another hypnogram, which is also showing some obstruction and obstructive apneas and hypopneas, but it is not as busy as the previous slide. And this is how we score it. This is typical obstructive event. You can see there is no airflow, but there is effort, and you can see the saturation. It was initially 93%, but during the obstructive event, it has come down to the 77%, and there is an arousal. So each of these arousal is a sympathetic discharge, and this sympathetic discharge increases the BP, increases the heart rate, and that causes a degradation of the physiological system of the body. Now the prevalence of OSA is increasing day by day, and you can see the prevalence is going sharply upward for both male and female, and this is a widely prevalent condition. It is estimated that around 17% of the male having obstructive sleep apnea all over the world, and 9 to 10% of the female having obstructive sleep apnea. And if you just take the snoring only, the snoring is one of the clinical features of obstructive sleep apnea, but snoring per se is not obstructive sleep apnea. You have to have snoring along with daytime sleepiness and fatigue. If you just calculate the snoring, 50% of the world population is probably having a snoring and some features of early obstructive sleep apnea. And this is what is the relative risk of incident diabetes from the prospective cohort studies in patients with obstructive sleep apnea. That has shown the relative risk of diabetes increases more than 1.5-fold in patients with obstructive sleep apnea in various studies. And what is the OSA prevalence in studies with patients with type 2 diabetes? Just you can see from this, these are all patients of of diabetes. This red portion is the percentage of obstructive sleep apnea. So in some studies, it reached 90% prevalence. In your diabetic patient, if the patient is obese, he has a 90% chance of having an obstructive sleep apnea. And obstructive sleep apnea, apart from diabetes or the metabolic disease, are associated with other cardiovascular disorder. If you have a drug-resistant hypertension patient, and if he is male, 80% chance of having obstructive sleep apnea in that patient. In congestive heart failure patients, central sleep apnea and obstructive sleep apnea constitute 80% of the patient. In type 2 diabetes with obesity, 72% of the patient having obstructive sleep apnea. And apart from that, atrial fibrillation, all hypertension, coronary artery disease, and angina, all these cardiovascular disorders are very common in obstructive sleep apnea. So we say the cardiologist has the largest chunk of obstructive sleep apnea patients in them. Now, one of the common confounder of obstructive sleep apnea and various metabolic and cardiovascular disease is obesity. So, by obesity, there is decreased physical activity, exercise performance, positive energy balance, and decreased motivation that leads to further obesity and accumulation of fat in the upper airway or in the abdomen, and that cause obstructive sleep apnea, and that increases obesity further. And these are the various studies which have shown the various mechanisms involved in the obesity obstructive sleep apnea combo. Now, 70% with OSA are obese, and prevalence of OSA in obese men and women is around 40%. So this is very much common problem in obese patient. And the visceral fat accumulation. If there is central fat accumulation in the nose or in the abdomen, that predisposes to various inflammatory conditions and obstructive sleep apnea, not the parietal fat accumulation. So the apple-shaped obesity in males are having obstructive sleep apnea more than the pear-shaped female obese pattern. So this metabolic syndrome, we all know about metabolic syndrome, which is a forerunner of diabetes and cardiovascular disorder, and obesity are the causative agent for the diabetes and the cardiac disease, and this is due to the low-grade systemic inflammation and adipose tissue inflammation related to the cardiometabolic dysfunction. So all it starts from the increased free fatty acids. If there is increased free fatty acids, the cascade starts there and it produces insulin resistance, as I will show you in my next slides. So this is the most important thing, to have a positive energy balance and more of the free fatty acids. Now it is said that it is not only the weight which causes obstructive sleep apnea in obese patient, the obese physiology itself is a very deranged physiology, and this obese physiology, there is increased chance of leptin resistance, there is increased chance of insulin resistance, and that causes hyperglycemia. So even not a morbidly obese patient may have a deranged obese physiology, and this obese deranged physiology can cause obstructive sleep apnea, obesity, and insulin resistance, and followed by diabetes. So what is the exact mechanism? So what happens in obstructive sleep apnea? In obstructive sleep apnea, there is obstruction. This obstruction causes hypoxia. So there is intermittent hypoxia. That means that increases the oxidative stress. And there is sleep fragmentation. This sleep fragmentation, as I've already said, this is an sympathetic discharge. This is arousal, and this arousal causes insulin resistance. So there are not only a beta cell dysfunction, there is insulin resistance at the receptor level, and that predisposed first to metabolic syndrome, followed by obstructive sleep, followed by overt diabetes in OSA patients, and that leads to the various microvascular and macrovascular cardiological complications. So the chronic intermittent hypoxia is the main runner of this ischemia reperfusion injury, oxidative stress, and inflammation, a chronic inflammation. And this chronic intermittent hypoxia actually stimulates two paths, the NF-kappa beta factor, which is called the master transcriptional factor, pro-inflammatory transcriptional factor. And this master transcriptional pro-inflammatory factor induces TNF-alpha, in interleukin-6, CRP. But if the obstructive sleep apnea of some duration, in addition to the NF-kappa beta, it also stimulates hypoxia-inducible factor 1. So the pathology becomes more severe in that case. Rodent studies have demonstrated that the beta cell dysfunction or the beta cell death after exposure to intermittent hypoxia, but the problem is that the cessation of hypoxia only partially reverses glucose homeostasis in a rodent model, suggesting that some metabolic derangements such as beta cell dysfunction may be permanent. So we have to identify these patients before they develop the beta cell dysfunction, or they are in the metabolic syndrome phase, because once they develop overt diabetes, that is very difficult to control that metabolic derangements or reverse the natural history. And we have, as already mentioned, we have two phases of sleep, NREM sleep and the REM sleep. If our patient is having obstructive sleep apnea features, we have to see what is the AHI or the apnea hypopnea index in the REM sleep, because that is a physiological marker that this patient may have insulin resistance in future and he may develop diabetes in future. Sympathetic overactivity, my previous speaker has already mentioned what is the importance of severe sympathetic activity in heart failure patients. In diabetic patients also, the incretins, that means the peptidogenic factors originating from the intestine that augment the insulin response induced by nutrients, but secretion of these incretin hormones is intimately related to autonomic nervous system activity. The sympathetic hyperactivity of any cause and parasympathetic withdrawal associated with obstructive sleep apnea are the mediators of the adverse effect of the glucose tolerance. In our recent paper published in Indian Journal of Sleep Medicine, we have also shown that the renin and angiotensin-aldosterone system, the oxidative stress of the individual, the endothelial dysfunction, and the immune response, all of these pathways are chronically in the deranged state in obstructive sleep apnea. And in COVID-19 also, these are acutely deranged, so any patients of COVID-19 having obstructive sleep apnea have more symptoms than not having obstructive sleep apnea. But obstructive sleep apnea is not necessary or the prerequisite to develop insulin resistance. Any cause of sleep deprivation, be it a sleep deprivation of shift worker or be it a deliberate sleep deprivation, that can increase the insulin resistance and the abdominal obesity. So any kind of sleep deprivation can bring about this insulin resistance and the diabetes in future. And these are the various studies. Sleep restriction from any cause that decreases the insulin sensitivity from 24% to 16% in various studies, and sleep fragmentation by any cause, be it your mobile or be it your any cause, that cause can cause decrease in insulin sensitivity from 25% to 20%, and hypoxia decreases insulin sensitivity like -17%. And this is a favorite GAMI diagram, which has shown that there is a multiple loops are playing, multiple interplay are there between this chronic disorder, heart failure, pulmonary hypertension, OSA, diabetes, and there is overlapping feature, and this is a very complex relationship between them. Now, because of that, in 2008, the International Diabetes Federation Task Force on Epidemiology and Prevention strongly recommended that health professionals caring for patients with either type 2 diabetes or sleep disordered breathing should consider screening a patient presenting with one condition for the other. If somebody, getting a patient who is having feature of obstructive sleep apnea, that means snoring, and if there is excessive daytime sleepiness, that is a phenotypic marker of insulin resistance in that patient. So you should screen obstructive sleep apnea in them. Now, what is the treatment of obstructive sleep apnea? We know that we treat the obstructive sleep apnea patient with continuous positive airway pressure or automatic positive airway pressure, that is called APAP or CPAP, and that actually increases airway dimension in the lateral walls, and that causes airway opening, and that prevents the airway collapse during sleep. And there are several important parameters that can be improved in OSA, like it improves the blood pressure, it attenuates the heart failure, improves the cardiac function. But in regard to diabetes, we have a dichotomous result. If the patient has already having overt diabetes, the result may not be that good, apart from only some control of insulin resistance or blood glucose control. But if you are getting a patient who have not developed diabetes, who is still in the metabolic syndrome phase, having insulin resistance, then CPAP will be a lot of help for them. And this is a paper which has shown that continuous positive airway pressure improves insulin resistance in patients with sleep apnea without diabetes. But once over diabetic, the effect becomes much less or much more diluted. So to summarize, type 1 diabetic patient, they have a loss of insulin production. Still they can develop obstructive sleep apnea because of the autonomic neuropathy, but bulk of the patient having type 2 diabetes, the main pathological feature is insulin resistance. That lead to actually beta cell dysfunction, and obesity, obstructive sleep apnea, diabetes, and metabolic syndrome are the chronic inflammatory state which leads to insulin resistance, and insulin resistance leads to this condition, and there is a bidirectional relationship between them. So OSA and diabetes have a common confounder, that is obesity, but can influence each other even in absence of obesity. Both conditions are increasing in prevalence. Chronic intermittent hypoxia and sleep fragmentations are mainly responsible for the adverse metabolic outcome. Leptin resistance and insulin resistance are common in both conditions. Thank you. Thank you for hearing.
Thank you, Dr. Aldar, for vividly explaining your topic. Any question from the audience?
Are there any clinical or biological markers of endothelial dysfunction?
Nitric oxide is one of the markers, but that cannot be measured clinically. Still not. In the experimental model, we have nitric oxide synthase, but it is still not available clinically as a marker. Okay.
If you can demonstrate, then you must think of.
Okay, maybe I am not aware.
Just one comment that few days ago we lost one of our great composer, Mr. Bapi Opores Lahiri, due to this particular syndrome, the complex syndrome, OSA with diabetes. So this problem is so common with us. And another one, the question to you, these patients sometimes develop the pulmonary hypertension. What type of drug we prefer for this OSA with pulmonary hypertension?
So the treatment is usually the treatment of the underlying condition, that means the OSA. Usually we do not treat pulmonary hypertension separately for this patient. So if we treat the OSA properly with CPAP and other features, then we can treat the pulmonary hypertension. Apart from that, few patients are candidate for oxygen even after CPAP. So we have to select those patients after giving them adequate trial of CPAP.
First of all, congratulations for this kind of oration. It's really very wonderful. We have learned a lot. And my question is that we sometimes come across OSA in thin individual.
Yes.
What is your experience on that?
So as I have shown in one of my slides, OSA is obstruction is the prerequisite, but obstruction is not the only feature. If that thin individual have other problem like a lower arousal threshold, a ventilatory instability in form of the loop gain, or there is poor muscle responsiveness, then that patient can develop obstructive sleep apnea. But a little amount of obstruction is the prerequisite. The obstruction may be in the form of skeletal obstruction, that means retrognathia, or a small maxilla or mandible. So these are the skeletal obstruction, or large tonsils. And in Indian patients, we have seen that more of the Indian patients is having obstructive sleep apnea, not being obese also. Because it is said that for the same height and age and sex, for European counterpart, we have a lower airway cross-section. Like we have the lower coronary cross-section, so we have a lower airway cross-section also. So any non-obese person can also develop obstructive sleep apnea.
How much helpful to this kind of patient, this lean individual, thin individual, this management regarding this management of OSA, the use of this CPAP or APAP?
Yes. If there
is this same
no.
with obese or?
So that's why you have to do the palm scoring. If the anatomical obstruction is predominant, we can go for a CPAP or sometimes a surgery. Surgery means if the patient younger patients are also having obstructive sleep apnea, even the kids or the children. The main cause of obstructive sleep apnea in them is adenotonsillar hypertrophy. So if you remove the adenoids and the tonsils, then obstructive sleep apnea is cured. We do not give CPAP to them. So if there is prominent skeletal obstruction which can be corrected surgically, we go for surgery. But for most of the patient, the gold standard is CPAP, and this is absolutely can be controlled with the CPAP.
Should we encourage them to go for surgery? Just suppose with some patients, this phenotype is that like that, this obesity, but the ENT have said that some features of obstruction is there. So patients ask us, should we go for this surgery first, then for?
No. First, always if the patient is elderly and having a severe obstructive sleep apnea or obstructive sleep apnea with daytime sleepiness, you should go for CPAP. But for some younger patients, we prefer surgery first if there is a skeletal obstruction which can be surgically correctable. For that, we first do a surgical sleep-induced endoscopy. We call it a DICE, drug-induced sleep endoscopy, to see the level of obstruction in that patient. And usually it is a multiple level obstruction, and all those level has to be addressed. So surgery is much more complex in older patients. But for younger patients, if they have adenotonsillar hypertrophy, we can go for them. But mind it, DNS is not the prerequisite or the cause of obstructive sleep apnea. DNA may increase the chance of having severe obstructive sleep apnea, but correction of deviated nasal septum doesn't cure obstructive sleep apnea at all.
Is there any marker such that we can define that this patient will benefit from surgery? Suppose AHI is more than 30 or 40 or 50.
There is no marker. The standard protocol is that for elderly patient, we first try with the CPAP. If the patient is CPAP intolerant because of some reason, then we go for a drug-induced sleep endoscopy to see the level of obstruction and if it is surgically correctable. If it is favorable in that features, then we only go for surgery.
Sir, I have a question. Does every patient diagnosed with OSA needs ENT evaluation or upper airway examination?
Ideally, it should be done because we have seen that if the nasal resistance is very high, all ENT patients are not measuring the nasal resistance, but that can be measured by nasal manometry. If the nasal resistance is very high, that patient is not going to tolerate CPAP very well. So those gives us some idea which patient is going to tolerate CPAP very well or not. So if you have ENT people oriented to sleep, you can go for ENT evaluation for all your OSA patient. Yes.
In Bardhaman, we don't have any sleep, what we call sleep study. Do you recommend in these places, Bardhaman, not this sleep, how this, we have to take these patients for, take these patients to the Kolkata, then we will come back. And we often recommend that these patients should come for this home study. Is it recommended or?
So I think you should have. Bardhaman is a big medical hub. You are missing a lot of patients because I have shown you 80% of the cardiovascular disorder patients is having obstructive sleep apnea, or your diabetic patients having obstructive sleep apnea. So you should have a sleep facility here. You can go for home study, but for home study the dictum is that the likelihood of having obstructive sleep apnea should be very high. For those having a low likelihood of obstructive sleep apnea, home sleep apnea testing cannot pick up those patients. And patients should not have that much of cardiovascular or pulmonary dysfunction, because if the patient is hypoxic at room air, that can falsely pick up apneas or hypopneas as false positive. So you can go for obstructive sleep apnea patient for or home sleep apnea testing for patients having severe symptoms of obstructive sleep apnea, and you should have. We are missing a big chunk of patients.
Thank you so much. Thank you very much.
Thank you. Thank you.
Thank you. Special thank you to Dr. Arup Haldar to please come over here and deliver his excellent speech. We are enriched. Now it's time for giving mementos. I would request our senior chest physician, Dr. Mongolmoy Ganguly, to present the memento to Dr. Arup Haldar. Next, I would request our youngster, Dr. Shivaditya Chakraborty, to deliver the memento to another youngster, Dr. Arnab Majhi. A special thank to Dr. Arnab Majhi for chairing this session. We are proud of you, sir. Once again, now I would request Dr. S.P. Mukherjee to deliver the memento to our senior chest physician, Dr. Mongolmoy Ganguly. Again, a special and sincere thanks to Dr. Mongolmoy Ganguly. Please come year after year. So it's time for the next topic. And once again, we are ready with a very famous personality in cardiology, in not only in West Bengal, but also in India, Dr. Shubhanan Rai, who will be speaking live after CABG. To chair the session of Dr. Shubhanan Rai, I would request Dr. Vikas Waika, HOD Medicine, Bardhaman Medical College, to please come over the stage. And once again, I would request Dr. Ashish Mukherjee, our very favorite senior, as well as to Dr. Shubhanan Rai, to come over the stage to greet Dr. Shubhanan Rai.
সুবর্ণ রায় সেটা বলতে না তো আছে নাকি প্রোগ্রামের মধ্যে বলতে বললে ও আছে সিভি বলার তো ব্যবস্থা নেই কিছু লেখা আসছে ও বলে দিচ্ছি তুমি এমনি জানতে চাও কি না এখন না বলতে বলবে পরে এই অর্ণব বিকাশ জিজ্ঞেস করছে সুবর্ণ রায়ের সঙ্গে ইন্ট্রোডাকশন দিতে হবে কি পড়বো এইটা পড়ে দেবো
So basically, it is a get-together rather than a conference. Yeah. After a long time, at least we are alive to meet each other physically. There's a great sense of well-being, and this is a thing for which we are indebted to the Almighty for giving us a chance to meet here after 3 years, perhaps. Basically, here I am not fomenting any debate. Whenever some cardiologist talks about CABG, people think that there would be a debate and where I'll be pushing PCI as because I'm an interventional cardiology and say something bad about CABG. It's not like that. It's not like, Barbaro na Kone Baro, it's not like that. We know that both the procedures like CABG and PCI has come a long way down the line with loads of studies for and against, and we particularly know what is an indication of CABG, what is an indication of PCI, and this is like an aviation rule. If you flout the rule, you will be in disaster. We know that. But the problem is, what is after the procedures? We know that we cardiologists, when we do an angioplasty, we know that the patient should be followed up regularly. What are the drugs we should see? What are the parameters we should look at? And how we should monitor those parameters and how the life will be if the patients are defaulters. If somebody stops the antiplatelets, we know what can happen, and we press the patients that you should not do this, otherwise you will be in trouble. But I don't know, here we are all physicians. I do not know any of the CABG patient coming to a doctor regularly for follow-up. I have never seen in my life. So, people think there is a huge misconception which was created almost like a sermon or like a business model that CABG is permanent and PCI is temporary, which is such a disaster. Both the procedures are palliative. They do not do anything to the disease. Only we just do a palliation. But the major problem of the disease is elsewhere, which needs lifestyle modification, drugs, and regular follow-up. So with that, can I have my first slide?
Yes, please.
Oh, that is like, huh? So with that in mind, I would rather go for certain incidences and prevalences which will show that after a CABG, there's something natural, some natural events occur. Now, why CABG? How CABG is done? In CABG, just like, basically, like a layman, we can say that in CABG, they create an abnormal pathway, which is a bypass, which is, saphenous vein grafts are not meant for bypassing aorta to the coronary arteries. They are never meant for that. Veins, if you know the structure of the vein, they do not have a huge media. It is only adventitia and followed by endothelium. So they do not have media. So they cannot withstand pressures, arterial pressures for a long time. Similarly, if you put the arterial grafts to some of the arteries, if they face a competition, some normal flow going down the artery and another flow coming down to the artery, one of the tracks will be closed. There's no doubt in it. But as PCI moved in, we knew that physiology is important. We need to know the physiology, whether there is ischemia, whether there is reduced blood supply and to the different muscles by doing FFR, by doing a lot of studies. We put a stent across after that. And if we do not do that, we know that yes, there might be problems. But peculiarly enough, there is a study called FAME3 where cardiologists did angioplasty, CABG surgeons did CABG, but the cardiologist took the help of physiology to revascularize the blood vessel, whereas CABG surgeon put grafts where they could find, and ultimately, after 3 years, it is found CABG is better results, showing better results. Why? Because the circulation in CABG goes in the opposite direction. Now, if we see that in a left main artery, the blood supply goes from the aorta to the distant muscles to the two branches, which is LAD and LCX. But see, if the LAD is blocked, what happens? If you put a graft in from the aorta to the LAD, distal part, the blood will move not only distally, it will go proximally to the branches and supply the muscles there. So there is a retrograde flow which is probably less pressure and probably a different phenomenon. It happens only during diastole, we know that, coronary physiology. Here the blood supply goes during systole. So there are a lot of differences between the two physiologies. But one thing is sure, that if we do not look after the patients, once the CABG is done, something happens. How it happens? If we go at the literature, I am amazed to see that in literature, the highest number of the CABG follow-ups, they showed in Emory Hospital data, they showed about 40% of the venous grafts closed by 1 year. This is remarkable. Now, why then the patient survive? We see that most of the arteries which is put in LAD, say Lima to LAD, if that becomes active, almost whole of the blood supply of the heart is maintained and the patient survives despite of the other grafts being closed. Similarly, if you look at the 1 year data of the Emory Hospital, and you will be astonished to see that 9% of the Lima graft, which is the lifeline of CABG, is lost within 1 year. So how you get into it? So the patients of the CABG needs definite follow-up. So how follow-up helps? In the beginning, I could not show you the pictures, and that is the problem. Is it ready? So if you look at the pictures, you will see that basically after, that's it, it has come. So, yes, go to the next slide. Yeah? So this is the, I was talking about some, is not coming here. Yes. So, and as I told you that about 40% of the venous grafts attrition rate is 40%, and 1 to 2% of the venous grafts annually closes, and after 10 years you can see that 50% of the vein grafts are occluded and 50% are diseased. And as I told you that about 9% of the lima grafts close by 1 year. So early ischemia of the CABG should be, after CABG should be picked up. Now if the patient comes in the follow-up, I have seen one patient, this is my personal experience, that the patient came after CABG after 1.5 months, and the patient was complaining of chest pain. The surgeons thought that it is probably due to the scar in the in the middle, and patient was moving from one center to another center. Ultimately, nobody did anything to to the patient. But when he came to me, she came to me, and she was a lady. She came to me. I saw that the pain was very typical. So I went for an angiography. So after a lot of coaxing, I could make the patient ready for angiography, and I found all the grafts are lost. So basically, if you see that within 1 month, one patient comes to you with typical angina, ask the patient to go for an angiography, because there only a PCI can help the patient out, otherwise it is a disaster. So with that, so this is a lady and which I was talking about. I don't know whether it will move or not. This is the problem, all through. Yeah. So this is the lady who had a bypass for a left main disease, having 2 grafts. One is a lima graft and another is a vein graft, the LAD and LCX. It was an osteal LAD disease, and all that I could do, I did the angiogram and I saw that all the grafts were lost. And I put a stent in the left main, and this is the final result. And this lady had a follow-up after 1 year. This is still working well. And this after 4 years, this is working well. So I could detect that the patient is having angina even after 1.5 months. I could do an angiogram, and so the patient is saved. So basically, she needs what she needed a good follow-up. So after CABG or after any procedure, follow-up is most important, and then that follow-up should be done regularly in a clinic which we call post-CABG clinic. We must have a clinic now for the procedure patients. We know that the PCI patients have been followed up by the cardiologists because they take care of them. But the CABG, after the, I am sorry to say that after CABG, most of the patients do not see their patients. So another patient, I could not, this video cannot be shown. All the videos are gone. I don't know why. This is another patient who was, he had a very bad disease, multivessel disease, came to us. I sent him to surgeon, and he got a lima Y. And then again, CABG done in 2016 March, presented again with severe angina and effort after 7 months. So initially, he didn't come to me, he went to the surgeon, then he came back to me, and I saw that the lima stenting, the lima was attached to the circumflex and lima was attached to the LAD. The circumflex lima was lost, and there was a severe anastomotic defect at the lima to LAD, which was, I put a stent there, and again I could not show you the result. This is another patient. You see that again, this patient came to us, 50-year female, had CABG for severe LMC osteal stenosis with two RSVGs, to LAD and LCX. She was admitted again after 3 months with severe chest pain and cardiogenic shock. There, she came into our emergency, and we saw that all the grafts were lost. Again, we put a stent, and she was saved anyway. So my experience is anatomical complexity in form of CTO, long lesion, multiple stents in presence of a patient with diabetes and female are more benefited by CABG, we all know. But again, the difference between the CABG and PCI is repeat revascularization, not death. Another untold story is the continuation of GAPT, which must after PCI and even after CABG. This is what I want to impress. Now, because we know that after angioplasty, we put them on dual antiplatelet drugs. But in CABG, nobody cares whether the patient is taking aspirin and clopidogrel, aspirin only as aspirin, or stopping all the drugs altogether. I have seen those patients who early come to the doctors for angina, they do not have even a single antiplatelet. They have stopped it. Either they are taking one drug, clopidogrel only, and not aspirin only. I don't know the study about clopidogrel in CABG, I have not seen, but aspirin in CABG is a definite antiplatelet which should be given in all patients, otherwise the patient will have graft failure. I have seen that surgeons give calcium channel blockers, but they do not even give an aspirin. They give clopidogrel sometimes, they give ticagrelor, but they do not give aspirin. So in CABG, whether in PCI you after 1 month, 2 months, 3 months you can stop DAPT and go with any clopidogrel or ticagrelor, there are a lot of studies. But after CABG, perhaps there is no study showing the patient is doing better without an aspirin. So I think in CABG patients, aspirin is a must. And if it comes to a regular follow-up, a physician can fix up what drugs he should be taken, and at least an aspirin should be given in all cases. And if the patient comes between 1 to 3 years, in first 1 year, it is either an operative failure or drug failure, or the patient is too fragile, having a lot of comorbidities which has not been addressed. These three are the main reasons why a CABG patient will come to you. But if the CABG patient comes to you between 1 to 3 years after CABG, it is usually new stenosis in the graft conduits. As I told you, that saphenous brain never thought that I would be transfusing blood from the aorta to the distal coronary arteries for circulation. So they succumb to the high blood pressure flowing through the conduit during systole. And this is the reason why there is aggressive atherosclerosis in the vein grafts between 1 to 3 years, and it starts 1 to 3 years. Now, here you can do angioplasty and you can do a lot of things, but I am not going to show you something here because my video is not working. This is a very excellent study. This is a female patient, wife of a doctor, went for a CABG in some of the centers, who did a Lima to LAD and one vein graft to RCA. That lady, after 1 year, came to the same hospital, went to the same hospital, and with angina. So they put they did an angiogram and showed that there was the Lima is not seen. So they put a stent in the LAD, and the lady was discharged. Again, after 6 months, she came to the same hospital with again pain, and at that time it was shown that the SVG is blocked, and so they did an angioplasty to the RC. Again, the patient was having chest pain another 6 months, 1 year. She came to the hospital, There they did an angiogram and saw the blood from the LAD is going back to the subclavian artery, and the lima is all through patent. So the lima, which was not patent earlier, after putting a stent, that lima become patent and going in the reverse direction. So they said you have to block the lima then. So the patient was confused. She came back to me, and I did an angiogram. And this is the, this is the first angioplasty. When you could see that there was a lesion in the LAD, and the RCA was just like that. So lima was, this is the lima, which I could not show you, that the lima was blocked. And so the next time they put a stent, and you see that they have put a stent and the flow is nice. And after that, this is the angiogram again, where they could show that the lima is flowing back. So it came to my mind that when there is a still there is blood supply reversing the LAD blood supply towards the subclavian must be blocked. So I did a subclavian angiogram, and it showed that the subclavian has a 90%. I could not show you the video, it's not working, but you can see that the balloon is inflating in the subclavian, and I put a stent in the subclavian. This is the stent in the subclavian, you can see. And once the blood supply of the subclavian is maintained, the flow through the lima became less, and the patient became all right. So what was the problem then? Nobody cared about the subclavian. You have put a lima. Nowadays, when people do an angiogram, even I see my juniors, they go deep into the lima and take a shot, and lima is perfect, and they put the lima in across in the LAD. But they never think that lima is a branch of the left subclavian artery. If there is a lesion in the left subclavian artery at the ostium, which is not done if you do a non-specific shot in the subclavian, if you not see it, then you will miss it, and ultimately your lima will not flow normally. So this is a simple thing that before doing a CABG, someone must be careful about noting it. And also, this is a very simple test which we could see. You measure the blood pressure of the two hands, and when I measured the blood pressure on the two hands, the blood pressure was different. On the left arm, it was 90/70, but in the right hand, it was 140 something. So this simple test could detect that this patient is having. Even I got a patient who had a fantastic CABG done by one of the stalwarts that time, Lima Y, and the patient came back to me after say 10 years. He was a Bangladeshi, he got an angiogram done in Bangladesh, and it was seen that all his native arteries are gone. But he had a Lima Y which is working nicely, but he is having severe chest pain. So I had the experience of this, so I measured the blood pressure on two hands, and the blood pressure was different. And I put a stent I could not do anything to the patient. I just put a stent because his native arteries were lost. I just put a stent in the, subclavian artery, and self-expanding stent. Even I could not dare to stop the blood supply of the subclavian because of the severe angina, possibility of severe angina. And that patient, when I put the self-expanding stent in the subclavian artery, that gentleman for a few seconds became unstable. Gradually, the angina disappeared, and after 1 year, still he is working, still he is alive. So after maybe 5 years, I just put a stent in the subclavian. So in the follow-up, if you find that the patient is having CABG down the line and is having angina, please measure the blood pressure of the two hands. If the blood pressures are different, you know that probably there is a lesion in the subclavian artery, which is the origin of the main artery, which is the lifeline of CABG, that is lima. And if you can address that, the patient will be fine. And last is, I'm not going into this. Now it is working, no? What is? Yeah. So this is a story about basically there are a lot of things you can do for the vein grafts. So once the vein grafts are diseased, what you do? Basically, if the patient sometimes come for a, they do not come for angina. Patients comes in follow-up. You should do a treadmill in every year for every CABG patients. Because, why? Because you know that what would be the exercise limit of the patient. You know, after CABG, if some patients come to you with an exercise limit of, say, he can run up to 3 stages, 4 stages, and gradually his, exercise duration is coming down. So you know that something is happening. So though it is not producing any chest pain, you are asking to go for a treadmill, and you see that he is not working, doing well. He is having discomfort even after two stage. You do an angiogram, and if you see that there is a lesion in the vein graft, you address that. It is not like native native coronary arteries, where we know that about 70% is the limit where you put a stent. But here, if there is a 50% disease, the vein graft is going. Once there is a disease in the vein graft, it will gradually go. Then nowadays, we just put a stent across and save the patient. Why? Because the vein grafts are put in a artery which may be 100% occluded. Then why I open this? Because nowadays you know that once there is a 100% disease, there are 2 ways you can open the artery, either by antegrade way from the direct passing the wire directly through the artery, or through the retrograde way through the vein graft and cross the artery. So that is the reason why you open the vein graft, but you know that this vein graft will ultimately go. You need to do something to the main artery, which may be another angioplasty. Because redo CABG is not very easy, and redo CABG, the results are bad. Even after, even with the best of hands, the mortality is 7 to 10%. So you can do these vein grafts, but the problem of vein grafts, all the interventionists know that it contains a lot of cheesy material which can go downwards and clog the microcirculation, and ultimately there is no definite flow into the muscles, and that can be addressed nowadays by putting a filter. But I am not going into it because this is something technical. So lastly, if after 3 years a patient comes to you and now it is already atherosclerotic lesions can set in, and 70% of the post-CABG patients will present as ACAs. These patients come with ACAs. Now what you do? In a patient, if the patient comes to you with the I'm not going into it. If a patient comes to you with the ST elevation MI, because after 3 years, these patients will be coming to you with acute MI. Now, if a patient comes to you with the acute MI, post-CABG, what you do? The thrombolysis are ineffective. Absolutely. In vein graft, if the vein graft is clogged with, it is blocked, thrombolysis does not help. So in that cases, you should go for a primary angioplasty. There is no way out. So, and you can put lot of things, thrombosuction, GP2B3A, stent, etc. and etc. But this is the story of the the average patient who comes with acute MI. And if you look at the natives are already lost. If you see the RCA, it is lost. If you see the LMCA, it is already lost. So what can happen? See the lima. The lima is working. Now, if you look at the vein graft, one of the vein grafts is working nicely. Nicely working. So now you see the next vein graft. It is almost closing. So what you do? You go straight way, do a balloon, nothing. You shouldn't think of anything. Putting filter, putting nothing. Just go with the balloon and put a stent across. And here is the ultimate result. This is a very simple job. Only the importance is to detect and to send the right place at the right time. This is the only only mantra for success. And so I conclude that CABG is not a permanent event. Nothing is permanent in this world. So CABG patients are important patients because CABG patients are those patients which are not tackled easily. That's why they were sent for CABG. But lifestyle modification, evaluation of the ischemia at each stage of the follow-up should be done by a physician, and we should look for the lifestyle modification, whether the patient is taking right frame of drugs. We should see that whether the parameters are normal, whether his blood pressure is controlled, whether his diabetes is controlled, where the lipid numbers are normal, whether he is developing CRF. These are all bad parameters for developing post-CABG disease. PCI can be helpful in most of the situations, and in an early, if you think that something is going on, send the patient for angiography, and if possible, for a palliation by a PCI. If possible, the native arteries should be open, but for to open native arteries, sometimes you need to open the grafts. Firstly, open the grafts and then open the native arteries, so that the chance of getting a open native artery will be most. Thank you very much for patient hearing.
Thank you, Dr. Subhanan Roy, sir, for deliberating speech in our platform. We are enriched and we are grateful to you, sir. Now, I would request to felicitate Dr. Subhanan Roy, one of his favorite disciple and junior, Dr. P.R. Paja, Dr. Pankaj Ranjan Paja. Please come over the stage.
Before taking this, I would add a few words about Dr. Paja. Dr. Paja and myself shared the same room in the hostel, and he is the man who used to drive me on a prehistoric scooter to Baguyhati to type my thesis that time. And he has the unique brain to solve out all the mathematics. Of that time there was no calculator. All the mathematics of statistics, just like that. He can do that easily. He was fantastic. He was a fantastic brain and a fantastic human being. Thank you, Dr. Pankaj is a great leader. Thank you so much.
Well, I can observe a mini Abcdcon reunion here with Ashish Da, Dr. P.R. Paja, Dr. Roy and Dr. T.N. Banerjee, of course. Next, I would like to felicitate Dr. Vikas Waika, HOD Medicine, Bardhaman Medical College. Actually, we are glorified by his presence in the stage, and without his blessings, we cannot move in Bardhaman as a body. So I would request one of his student, Dr. Dharmendra Gupta, to please deliver the memento to Dr. Vikas Waika. Well, we have come to an end of a very exclusive and very informative session of post-CABG. Now, the person I am going to welcome in the dais is a person very close to our heart. His blessings we got right from the beginning of our journey. He is our famous cardiologist. you can say ABCD's heartthrob, Dr. Arunangshu Ganguly. Please welcome to the stage to chair this session. Once again, I would like to call Dr. Shubhamoy Chatterjee, his favorite junior, and once again, Dr. P.R. Paja, please come and please chair this session. Over to Dr. Shubhamoy Chatterjee to open the session.
Thank you. As Arnav has rightly said, our organizing secretary, and I have already reiterated in my inaugural speech that Dr. Arunangshu Ganguly, our beloved Arunangshuda, is right from the first Abcdcon, wholeheartedly supporting our academic endeavor. So without wasting much time, nothing much to introduce Dr. Arunangshu Ganguly. Sir is MD, DNB, MNMS. He is fellow of many international societies. He is a senior interventional cardiologist, chairman and MD of Health World Hospital, and visiting consultant cardiology of Ramakrishna Mission Seva Pratishthan, Vivekananda Institute of Medical Science, Kolkata. He is instrumental in laying down interventional cardiology in actually the suburban areas in South Bengal, outside Calcutta. And he is also a General Secretary, West Bengal Academy of Echocardiography, Executive Committee member, Cardiological Society of India, author of multiple national, international publications and several chapters in various textbooks and update books. So with that, I would request Arunangshuda to please deliver his lecture.
Good afternoon, everybody. এটা অনেকটা বাড়িতে ফিরে আসার মতো। All my seniors, বিকাশ দা, তারক দা, সবাই আছেন, সুব্রত দা, my juniors and my colleagues, আর আমার মেন্টর বললো ভুল ভালো হবে, আমার ইন্সপিরেশন শুভানন্দা। কারণ শুভানন্দার কাছে মেডিকেল কলেজের আরএমও মানে শুভানন্দ যখন মেডিকেল কলেজে আরএমও, আমরা তখন প্রথম ব্যাচ অফ হাউস স্টাফ। তো ইসিজিটা দৌড়তাম শুভানন্দার পেছনে, যে দাদা ইসিজিটা কি, তখন তো ইসিজি একটা সাংঘাতিক ব্যাপার ছিল। তো সেই জায়গা থেকে জার্নি শুরু। একটা সেকেন্ড, আজকে অনেকগুলো বছর হয়ে গেছে। ABCDcon আমি প্রথম বছরই এসেছিলাম এবং বলেছিলাম যে ABCDcon-এর সাথে আমি ABCDcon-এর শেষ অবধি থাকতে চাই, অথবা আমার শেষ অবধি থাকতে চাই, যে কোনো একটা। সো দ্যাট প্রমিস আমার তরফ থেকে থাকবে। শুধু একটা রিকোয়েস্ট, বিকাশ দা, এই মেডিকেল কলেজগুলো আছে, আরও মেডিকেল কলেজের ছেলেগুলোকে আনতে বলো না। সকাল থেকে অরূপ দুর্দান্ত বললো, অশোক খুব ভালো বললো, শুভানন্দ তো চিরকালই মানে টিচার। কিন্তু ঘটনা যেটা হচ্ছে সেটা হচ্ছে যে এই ছেলেগুলো যদি সেখানে এক একটা সেশন, অবস্ট্রাকটিভ স্লিপ অ্যাপনিয়া এত ইম্পর্ট্যান্ট একটা সেশন, প্রচুর শিখলাম অরূপের কাছে। ও আর্নির ফিজিওলজি প্রেজেন্ট করলো এত সুন্দর, এইগুলো কিন্তু আমাদের এমডি ছেলেদের আসা উচিত। আর একটা রিকোয়েস্ট দাদা তোমার কাছে, অ্যান্ড অল দ্য সিনিয়র্স হিয়ার, আমার চিরকাল মনে হয়ে এসছে, আমি জানি শুভানন্দারও এটা মনের কথা, এমডি মেডিসিন শুড বি দ্য সুপার স্পেশালিটি, তার আন্ডারে বাদবাকি শুড বি সাব স্পেশালিটি। তবেই আমাদের মেডিকেল প্রফেশন ঠিক দিশাতে যাবে। আমরা ভুল জায়গায় যাচ্ছি। 6 সুপার স্পেশালিস্ট সিইং অ্যান এলিফ্যান্ট ইজ লাইক সিইং 6 ব্লাইন্ড পারসন সিইং অ্যান এলিফ্যান্ট। এবং সত্যি কথা বলতে গেলে কি, এমডি মেডিসিন করার সময় আমাদের ছেলেগুলো বসে বসে ডিএম এন্ট্রান্সের জন্য এমসিকিউ করে যাচ্ছে, তারা না শিখছে মেডিসিন, না শিখছে সুপার স্পেশালিটি। শুভানন্দারও সেটা থাকবে। আমরা যত জুনিয়র্স ইন্টারভিউ নিয়ে অশোক আর আমি কথা বলছিলাম, সবাই মেডিসিন ভুলে গেছে, সোজা কথা। কার্ডিওলজি মানে হয়ে দাঁড়িয়েছে স্কোপিস্ট, কার্ডিয়াক সার্জন হয়ে দাঁড়িয়েছে কাটো, এভরিবডি ইজ ফরগেটিং দ্য ফিজিওলজি, কেননা কেউ মেডিসিনটা জানে না। শুভানন্দার সুবিধা হয়, আমাদের সুবিধা হয় কাজ করতে ওই একটাই কারণে, বিকজ দ্য চেস্ট পেন চিন টু সিমফিসিস পিউবিস ইজ নট কার্ডিয়াক। এই জায়গাটাই প্রথম আমাদের বুঝতে হবে অ্যাকচুয়ালি। তো এইটা একটা রিকোয়েস্ট বিকাশ দা, এটাকে কিন্তু তোলা উচিত। মানে ইন্ডিয়াকে যদি বাঁচতে হয় তাহলে আমেরিকা হলে চলবে না, ওরা ইউরোপ হোক, দ্যাট ইজ মাচ বেটার। শুরু করছি। কার্ডিয়াক ইন্টারভেনশনস মানে, আমি শুভানন্দার পরের থেকেই শুরু করছি, আমি বললামও তাই যে ইটস এ কন্টিনিউয়েশন থিং। লোকে ভাবে যে কার্ডিয়াক ইন্টারভেনশনস মানে পিডিসিএ করবে এবং পেশেন্ট বুকে ব্যথা হলেই কার্ডিওলজিস্ট পিডিসিএ করবেই। এই যে একটা ভুল ধারণা, তার চেয়ে সার্জনের কাছে পাঠাই বাবা, কিছুদিন ওষুধ দিয়ে রাখবে, পরে দরকার হয় কেটে পার্মানেন্টলি সলিউশন করে দেবে। পিডিসি এর মতো টেম্পোরারি সলিউশনের প্রয়োজনটা কি? ফার্স্ট থিং ইজ দ্যাট কার্ডিওলজি ডাজ নট মিন PDCA. One has first to understand it's a total spectrum. Intervention cardiology আজকের দিনে একটা total spectrum that encompasses coronary, non-coronary. Coronary ক্ষেত্রে the things are absolutely set piece, guideline and physiology directed. এর মধ্যে কোনো questions হবে না। আজকে একটা পেশেন্ট চেস্ট পেন নিয়ে এসছে, 30 বছরের মহিলা, TMT পজিটিভ, এর ফার্স্ট ইনভেস্টিগেশন অ্যাঞ্জিওগ্রাফি হতে পারে না until and unless there is a set of risk factors, there is a set of huge risk factors. কেননা এই TMT পজিটিভ does not mean ischemic heart disease. একটা 25 থেকে 30 বছরের মহিলা চেস্ট পেন নিয়ে এসছে, তার ইসিজিতে কোনো চেঞ্জ নেই, টিএমটিতে একটু ডিপ্রেশন আছে, নাইট্রোগ্লিসারিন চলছে অন্য কারণে চলছে, রিলিফ অন্য কারণে আছে, তার এসোফেজিয়াল স্প্যাজম আছে, হ্যাঁ, কিন্তু ইসকেমিক হার্ট ডিজিজ ছাপ্পাটা পড়ে আছে লেপ্রসির মতো। তো দিস থিংস আর থিংস যেটা নিয়ে আমি কথা বলতে চাই, মানে যেটা থেকে আমি শুরু করব। প্রথম, করোনারি ইন্টারভেনশনস আজকের দিনে গাইডলাইন ডিরেক্টেড সেট পিস। দু রকমের ডিসঅর্ডার, একটা অ্যাকিউট, একটা ক্রনিক, দুটো কমপ্লিটলি সেপারেট প্যাথোফিজিওলজি। যদি অ্যাকিউট এমআই ইজ এ রোড ট্রাফিক অ্যাক্সিডেন্ট, আর ক্রনিক স্টেবল অ্যাঞ্জাইনা ইজ এন এজিং প্রসেস। সুতরাং পিসিআই দুটোতেই করা হয়, কিন্তু দুটোর ডিরেকশন বা দুটোর লুকিং অ্যাট ইট ইজ কমপ্লিটলি ডিফারেন্ট। একটা অ্যাকিউট এমআই একটা প্লাক রাপচারে হয়, সেই প্লাক রাপচারটায় ন্যারোয়িং থাকতে পারে, নাও থাকতে পারে। Even in normal looking angiographic arteries you can have a full-fledged infarct. So this has to be kept in mind. Or acute infarct, the time window is most important. Baba হাসপাতালে যদি thrombolysis থাকে, first do a thrombolysis. কোনো দিকে তাকানো নয়, first do a thrombolysis. Then you send the patient. But after that, then you send the patient for coronary evaluation. Thrombolysis করার পরে যদি failed হয়, do not wait, because time is important. যদি টাইমে না করা হয় তাহলে অ্যাঞ্জিওপ্লাস্টি করার অর্থ থাকে না। সো দ্য গোল্ডেন পিরিয়ড 1 hour, গোল্ডেন 2 hour, দ্য সিলভার 2 hours অ্যান্ড অ্যাট লিস্ট দ্য ব্রোঞ্জ 4 hours হ্যাজ টু বি ফলোড। তাই যদি 2 ঘন্টার মধ্যে পৌঁছানো সম্ভব না হয় ইন অ্যান অ্যাঞ্জিওপ্লাস্টি ডুইং সেন্টার, ডু আ থ্রম্বোলিসিস। টিপিএ ইউজ করো। টিপিএ দামও কমে গেছে আগের তুলনায় অনেক। একটা 15,000 20,000 যে কেউ অ্যাফোর্ড করতে আজকের দিনে মোবাইল ফোন কিনে বেড়াচ্ছে লোকে। একটা টিপিএ দাও, টিপিএ মানে রিপারফিউশন অ্যারিথমিয়া রেটস কম, ইউ ক্যান গিভ ইট ইন এনি এমার্জেন্সি, বাট ডু এ থ্রম্বোলিসিস, ইউ উইল সেভ দ্য পেশেন্ট। ইন টিপিএ 75%, ইন streptokinase 54%। বাদ বাকিটা ইফ ইট ইজ ফেইল্ড সেন্ড, তার আগে নয়। ওকে, আর যদি তাড়াতাড়ি শিফট করতে পারো তাহলে প্রাইমারি পিসিআই ইজ দ্য বেস্ট অপশন। রিমেম্বার ওয়ান থিং, অ্যাকিউট ইনফার্ক্ট CABG হ্যাজ নো রোল। Shubhananda, am I correct? It has no role, because the time taken for the patient to shift to CABG is the time taken to murder the patient. So acute infarct, never think of CABG. কারণ আমার এলইডি টেরিটরি ইনফার্ক্ট হয়েছে, 4 ঘন্টা পরে এলইডি টেরিটরি নেই, তো আমি বাইপাসটা কাকে করব অ্যান্ড কেন করব? আমি তো বাইপাস করছি RCA এবং সার্ককে। অর্ধেক সময় দেখা যাবে 50 to 60% লিশন আছে, সেখানে ভেনাস গ্রাফট ফ্লোই করবে না বিকজ অফ কম্পিটিটিভ ফ্লো। সো ইয়োর CABG ইজ ইউজলেস। সেকেন্ড, 50% mortality with CABG in acute settings. So acute situation, CABG questioning আসে না, it's a PCI. It's a PCI. হ্যাঁ, even left main, it's a PCI only. And don't go in for, don't think about anything. Now comes chronic stable angina. Chronic stable angina is a normal aging process. কারেজের আগে অবধি 2014 সালের অবধি লোকে প্রচুর আর্টারি খুলেছে, আজকে আমরা খুলি না, বিকজ ইট ক্লিয়ারলি স্টেটেড কারেজ অ্যান্ড অল দ্য ফলো আপ স্টাডিজে যে there is no difference in mortality in opening up an artery which is amenable to medical treatment. So a person has to buy a surgery in chronic stable angina. Chronic stable angina te amra multivessel disease dekhi, ei multivessel disease jegulo amra dekhi সেগুলোতে CABG করব না PCI করব, there is syntax score. Even syntax score is more inclined towards CABG. তাহলেও syntax score is more or less আজকের দিনে একটা definite parameter যার ভিত্তিতে আমরা decide করি where PCI is class 1, where CABG is class 1, আর যেটাতে দুটোই করা যেতে পারে, because don't think that PCI is in 70s. এই যে গত 30 বছরে পিসিআর হার্ডওয়্যারে যা চেঞ্জ হয়েছে, আমরা গল ব্লাডার শুরু করেছিলাম কি করে, পুরো কেটে, আজকে কটা গল ব্লাডার কাটা হয় না। সো আমাদের নর্মাল অ্যান্ড ন্যাচুরাল টেন্ডেন্সি ইজ নট টু অপারেট। সো এনি ট্রিটমেন্ট, টিবি ট্রিটমেন্ট কি দিয়ে শুরু হয়েছিল, পালমোনেক্টমি, বিকজ এনিথিং টু স্টার্ট উইথ হ্যাজ টু বি র্যাডিক্যাল। তারপরে পিপল স্টার্ট থিঙ্কিং এর অল্টারনেটিভ কি হতে পারে। সো দ্যাট ওয়াজ হাউ প্রথমে ঠিক আছে এটা রাস্তায় বাইপাস করতে হয়, বাইপাস করে দিলাম, কিন্তু তখনও আমরা ফিজিওলজি জানি না পুরোটার, আমরা এক্সপিরিয়েন্স জানি না। গ্র্যাজুয়ালি পিটিসি এলো, বাহ এটা তো পরিষ্কার করা যাচ্ছে। সো মেনটেনিং মোর অফ দ্য ফিজিওলজি, মেনটেনিং টোটাল ফিজিওলজি, ইউ আর ডুইং এ পিসিআই। কিন্তু যখন একটা নতুন জিনিস শুরু হবে তার প্রচুর আননোন তথ্য বেরোবে, সেই আননোন তথ্যগুলো বেরোতে থাকে এবং সেগুলো হাইলাইটেড হতে থাকে। বাই কারা? বাই দ্য পারসনস হু আর নট ডুইং পিসিআই। কেন? ওই যে বললাম, আমব্রেলা শুড হ্যাভ বিন মেডিসিন অ্যান্ড দ্য সাবস্পেশালিটি শুড হ্যাভ কাম বিলো, তাহলে এই মিস ইনফরমেশনটা হতো না। বিকজ দ্য মাস ওয়াজ মেডিসিন প্র্যাকটিশনার who did not do PCI, and a segment of person doing PCI were becoming gods. So this was more of a social stigma internationally rather than a medical stigma. কেননা এটা নর্মাল ইভলিউশনারি প্রসেস। এর মাঝখানে 10-15 বছরের মধ্যে যে একটা সাংঘাতিক চেঞ্জ অফ হার্ডওয়্যারস হয়ে গেছে, দ্যাট ইজ ওয়াই দ্য রেজাল্টস বিকেম ইকুইভ্যালেন্ট। এই জিনিসটা না ওয়েস্ট অ্যাকসেপ্ট করতে পারছে, পুরো মানে খাচ্ছে কিন্তু গিলছে না, সর্ট অফ জায়গায় পড়ে আছে। তাই ইন পিসিআই মাল্টিভেসেল ডিজিজ, ভেরি ক্লিয়ারলি রিমেম্বার ওয়ান থিং, গো বাই দ্য সিনট্যাক্স স্কোর, ইউ আর কারেক্ট ইন 90% অফ দ্য কেসেস। পৃথিবীর কেউ 100% কেসে কারেক্ট হয় না। লেট আস টক অফ দ্যাট। আনস্টেবল অ্যাঞ্জাইনা, ইট ইজ ক্রনিক আনস্টেবল অ্যাঞ্জাইনা অ্যান্ড ইনফাক্ট হচ্ছে এই স্টেপ থেকে ওই স্টেপ। সো ইফ ইউ ক্যান ইন্টারভেন অ্যাট দ্য লেভেল অফ আনস্টেবল অ্যাঞ্জাইনা, by PCI, you save more muscle, produce less complication than intervening at the time of infarct. Unstable angina mane when the patient is having chest pain at rest, where the distance is coming down gradually. These are patients who are patients with unstable angina. চারটে জিনিস তো angina, চারটে 1, 2, 3, 4 পয়েন্ট হলে angina হয়। Unstable angina চারটে সিচুয়েশন, পোস্ট ইনফার্ক্ট angina, যেটা post revascularization angina, you have an angina which is crescendo অথবা recent onset angina। এই চারটে আনস্টেবল অ্যাঞ্জাইনার মধ্যে পড়ে। অ্যাকর্ডিং টু ব্রনওয়েল ক্লাসিফিকেশন সেখানে ইন্টারভেন করতে হবে। ইন আনস্টেবল অ্যাঞ্জাইনা ইন্টারভেনশন ইজ হাই রিস্ক আনস্টেবল অ্যাঞ্জাইনা। কি করে হাই রিস্ক আনস্টেবল অ্যাঞ্জাইনা বুঝবো? ট্রপ পজিটিভ। ইফ ইট ইজ অ্যান আনস্টেবল অ্যাঞ্জাইনা, ট্রপ পজিটিভ মানে ইউ আর সিটিং অন দ্য ফেন্স, ইউ হ্যাভ টু ইন্টারভেন। But trop negative, wait, treat medically. Patient jodi stable hoye jay, do a TMT. If you find that there is a change in the first stage of TMT, then you send the patient for a angiographic evaluation. Eta hocche in unstable angina. Coronary মধ্যে এই দুটো আমি Bimla Bhui, at a 55 years female patient, severe retrosternal chest pain, hypotension, bradycardia. এই হচ্ছে presentation. I'm sorry. Left system, right system gone. ঠিক আছে? এটা ঝুলছে. Hypotension, bradycardia, because right coronary artery is not there. So obviously this is an acute MI, inferior wall MI, AV ব্লকের জন্য bradycardia রয়েছে. You just open it up. কিভাবে open up করলাম, that's not more important, but you have to open it up. এরপরে how do you treat the AV blocks? Wait. If the rate is maintained around 40, wait. It reverses by itself. Don't hurry for a pacemaker here. That is very clear. Most of them recover by itself. MD Ladan, 60 male, presented after 12 hours with chest pain, hypotension, severe breathlessness. He was having chest pain. There is nothing. Okay? RCA is flowing. You did an angioplasty, definitely to the thing. You had this result. You see, Shubhananda knows the myocardial demand is not high. This patient, the flow is bad. 12 ghanta periye geche. You have a lot of dead muscle here. So this patient, this angioplasty has been done, but the results will be cosmetic. So early angioplasty always gives you a better result. Krishna Devi presented with severe fatigue and breathlessness, retrosternal discomfort. This is not the case. There has been some problem here. Just a minute. Actually, the one slide has been, this is actually Ashok Das. The slide has changed. Ashok Das, he presented with effort angina. Remember, this is a very nice case. Effort angina over 6 months. So this was his angiogram. Can you find something? Have you seen the left main, just beyond the catheter? Right coronary artery is okay, but have you seen the left main? See this portion. This is the origin of all the arteries. So now convincing this patient for an angioplasty was very difficult because patient's attendants were not ready to believe. But the moment we cannulated the patient crashed. This is all with cardiac massage going on. Okay? So here, whatever artery we found, we put in, we dilated the left main. After that, you put it again past the LED wire and you did it. Now, this patient still comes to the OPD, but that day, if he had not been convinced to do the surgery, to do the angioplasty at that setting, he would have died. This is what a high-risk unstable angina is. The patient had loss of distance movement in last 1 month. When he presented severe chest pain, TROP-T was positive. We told them that an angiogram should be done. They were very reluctant. But after all, when they got ready after 1 hour, the moment we introduced the balloon, the patient crashed on the table. And the whole angioplasty was done giving a cardiac massage. Ashok and me both were there. Okay, so this is what an unstable angina. If he had, this would have been a sudden death syndrome, had the patient not turned at that time. Now, this is a coronary intervention. This is what you call acute MI and unstable angina. In a chronic ischemic heart disease, I already told you what to do. But cardiac interventions do not restrict themselves here. The second part is the non-coronary, and by far that is a huge spreading domain, and most of you do not know about it. 2 things you know is peripheral vascular disease is one. So This one, this patient had a left femoral artery stenosis. See, the left femoral artery is not there. The catheter is there. From the right side, you pass the wire and you just opened it up. I am not going to balloon, you opened it up. So this artery was not there. This patient had peripheral claudication on walking. Okay, so this is what you can, just simple thing. You have a lot of diabetic patients today who have widespread peripheral vascular disease, whom we go on all medical management. They remain good for a certain period of time. But after that, that don't work. So a peripheral angioplasty is a boon to them in that situation. Similarly, you can have a right femoral artery stenosis also, and you can open it up. This is the right femoral artery which is closed. After opening up, you will see that there is a normal flowing right femoral artery. You put in a self. Okay, I am not going into it further because 2 examples is enough. You can have a bilateral lower end of aorta with bilateral aortoiliac stenosis, very common in this diabetic age groups. And you can do a Y graft there, stent graft instead of stent. We can do a Y graft just as we have done in this patient. You see a Y graft, this is a stent graft. Without operation, we put a Y graft. So that improves his normal quality of life. Okay. So this is opening up arteries. Carotid artery stenting. 65-year male presented with TIA. Doppler showed 70% stenosis, right carotid artery. Yes, there is stenosis. You did a angioplasty and you see this one is the right carotid normal flow that you get. This, you know, in the studies, if there is 70% or more occlusion, you can do it. Renal artery stenting is now not routinely indicated except in situations where the person is having flash pulmonary edema with uncontrolled hypertension. You see the origin of the renal artery here? It has become narrow like anything. You put in a stent and the number of drugs you use for controlling hypertension will gradually come down, but before that he will no longer be admitted for flash pulmonary edema. Then structure of the heart, balloon mitral, a mitral stenosis, balloon mitral routinely done. We forget that it is a cardiac intervention. Okay, so this is a very routine procedure. All the medical colleges are thriving on it. In a country where this is common, coarctation of aorta, one of the causes of resistant secondary hypertension. It's not as uncommon as you think. Do you find the coarct segment? This is the coarct segment. You see above, below, there is a coarctation. You put in a stent. You dilate it and put in a stent. You see the coarct segment dilating. A figure of 8. That mid portion is the coarcted segment. When it is fully dilated, you find fully dilated. You leave a stent there. Stent placed across coarctation. You have a flow. Then aortic dissection. See the dissected segment. The whole wall has gone in. This is just a 34-year-old male working in coal mines. Had a fall of coal chunk on his back. He came here with a spine fracture, but ultimately he was having severe hypotension. And this was the cause of hypotension. He was having aortic dissection. You do a stent graft there. After doing a stent graft, you find that the whole area has been repaired. This patient after that had a spine surgery done and is working in the coal mines once again. Large thoracic aorta aneurysm, the most difficult site where a surgeon can reach, because all the blood vessel supplies are from there. You just see the size of the aneurysm. See the aneurysm in the thoracic aorta. You can't do a surgery there. You have to do a stent graft. And after doing the stent graft, you will see what happens to it. This is the post-stented area. So these are very simple things we go on forgetting. Pulmonary valve balloon dilatation. This is also a coronary intervention. It's also a non-coronary intervention. Have you seen the pulmonary valve? This is the pulmonary valve here. I'll show you while dilating. You see, this portion is the tight pulmonary valve, okay? This is the balloon above the pulmonary valve, this is balloon below the pulmonary valve. Now you see what happens to the balloon. Opens up and your pulmonary valve is dilated. Device closure of PDA. You have a large PDA. You see the PDA. You close it with a device. I'm just not. You leave the PDA there. Aortic disc is open, pulmonary disc is open, and this is, see, there is no flow. No longer the flow is there, which was already there. ASD. You can close most ASDs, average sized ASDs with device. See, this is a simple one. You just put in the left-sided disc. Then you pull it and see that it is in the septum. Now pull in the right-sided disc. And you leave it. It is closed. Such a simple procedure. Device closure of VSD, you do it in babies. Before the age of 4 years, it is done. But you know that this is one of the most important mechanical complications of a infarct. These patients die. This is a patient which has moved everywhere, almost in shock, following an MI. So there was an apical VSD that you found through the flow. I'm showing you. You saw here that there was an apical VSD. Could you find the apical VSD? Could you locate it? Could not. I'll show you once again because this is a very important thing to detect. You see, just look at the area where I'm pointing. There is turbulence at the peak. That is where the VSD is. At the peak. At the apex. So there you put, this one is the VSD device. You do a device. So this patient hemodynamically improved and went home. Now a patient is having bleeding. What to do? 42-year-old male patient presented to emergency with profuse hematemesis, bleeding almost 1.5 liter. The hemoglobin fell to 3 gram% from 11 gram%. The gastroenterologist could not see anything, only could see a pool of blood. We took the patient up. Look at this point. Keep looking at that point. I'm sorry. Go back once again. See, here you can see a blood flow. This is, you give the blood. See, here there is a bleeding. The point where there is this marker, below this, there is a blood flow coming like this. That is the leaking from the superior mesenteric artery twig, celiac artery twig, rather celiac artery twig. So what do you do in these cases? You just go and glue it. The bleeding stops. And here that has been done. You see, in the next, here you are seeing the bleeding. But in the next view you see, there is no artery above this. There is no artery above this. This is this artery outline you see, nothing else. Because this has been stopped by glue. In the same patient, there was another bleeder here. Look at this point. You see something flowing out. That is the inferior mesenteric artery bleeding. So again we put glue there and it is stopped. This patient after 7 days walked home. A role of intervention cardiology. 18-year-old male patient, diagnosed cavitary tuberculosis. Diagnosed cavitary tuberculosis. Came with profuse hemoptysis. Okay? You see here there is, the blood is flowing out, this point. Once again I am showing you, this is very important for you to see. Where I have kept it, there is the blood coming out. You see, there is the blood coming out into the cavity. Now what we have, there is a blood coming out into the cavity, something. So what we have done is, after this we have, you see, it's coming down into the cavity, something freely flowing. We have put in coils. We have put in coils there, coil embolization of the artery. So there is, now you see there is no more blood above this. There is no more blood above this point. Up above this point, there is no blood. The whole artery is closed. So there is no more bleeding. This patient would have died because medicines, it was beyond medicine. It's a free-flowing vessel which is leaking into a cavity. Forget CRTD. This is one thing I would love to enhance. This is the first time done outside Kolkata. This is the second case. A patient with severe aortic stenosis, with multiple comorbidities. Aortic valve gradient was 100. The patient's LV ejection fraction was 40%. The surgical risk was very high, and the patient could not, the surgeons refused to do the surgery, but it had to be opened up. So this is the first TAVI done outside Kolkata, and we did it 2 months back. We never came public with it because we were following up the patient for 2 months. The patient is doing fantastic, and that is why we are showing the slide today. This is the first TAVI done outside Kolkata, and together this is the second TAVI done in West Bengal in this patient. And right now the gradients are 20 millimeter mercury across the thing, and the patient is with much less medications. There is no hospitalization in 3 months, where he was getting hospitalized every month for it. So this is also gradually slipping out of the surgeon's domain. Because I told you, hardwares are improving, we do not want to operate upon. There are many post-surgical risks. So one thing to be very sure, that cardiology does not mean only coronaries, number one. Number two, cardiology does not mean only interventions. The revolution in last 10 years, last decade, is with medications only. With the resurrection of aldactone, with the advent of ARNI, with the advent of statins and the data regarding statins, with the advent of newer hardwares, it is a total effect that have led cardiology to this place. So please try to widen your vision. And cardiology does not restrict itself to coronaries and mitral valve alone. It can be used in areas to open up any stenosis, to stop any bleeding. You are having severe postpartum hemorrhage, not being able to control. You do a uterine artery embolization, because this gel foam that you give, that recanalizes after some time. So there will be no necrosis of the uterine artery. The bleeding will stop. The cap will be formed. After that, the blood flow will again be restored. So in severe hemoptysis, severe hematemesis, you are doing a PCNL. The urologists do a lot of PCNL. And often there are renal artery twig bleeding. We do gel embolization or coil embolization, whatever is suited to that subset, to stop the bleeding. So that is a huge domain which we do not. The next domain is the electrical domain. The CRTDs, the ICDs, they have revolutionized heart failure management along with the drugs by reducing the admission frequency, by increasing the walk time, decreasing the number of drugs, and so many things. So that was the perspective that I wanted to place before you, because the identification has to be done at the physician level. A patient does not come and tell you that I have angina. Patient comes and tell you I have chest pain. A patient does not come and tell you I have a bronchial artery bleeding. A patient comes and tell you that I have hemoptysis. A patient does not present to you that I am having coma. A patient presents to you with hematemesis and melena. So ultimately the clinicians are the persons who decide the next stage. And we as clinicians often avert this. This does not come in my domain. This goes to somebody else. And the patient is roaming about. No. Because the amra to ebhabe shikhini. We were taught to diagnose the patient, be it renal, be it cardiac, be it. Let us go back to the old school. That will help today much, much more better. Thank you so much. Thank you for the patience and for this time.
Thank you, Arunangshuda, Dr. Ganguly. No questions are being invited for this session because we are running late. And if someone wants to ask any question to Dr. Ganguly, he can ask over lunch. So I would request now Dr. P.R. Paja to deliver the memento to Arunangshuda, Dr. Arunangshu Ganguly.
Dr. Arunangshu Ganguly, please come over the stage. A lot of thanks to you, sir. We are once again fascinated, and please come here year after year to deliver your elegant speech, sir. We are enriched.
This is a specifically made Mihirana and Sitabhog. Please test it.
Now, I would request Dr. T.N. Banerjee, one of the very good friend of Dr. P.R. Paja, our chairperson, to deliver the memento. Thank you, Dr. Paja. So once again, we are completed the session, and this is the last session for the pre-lunch. As pre-lunch session, we invite Dr. Sushmita Raichaudhuri, chest physician from Fortis Hospital, to please come over and deliver her lecture of post-COVID pulmonary complications. To chair this session, I request Dr. Rupam Kumar Ta to come over the stage. If we consider Dr. Shantanu Ghosh as the father of chest physician of Bardhaman, Rupam is the elder brother of physician of Bardhaman. And to co-chair this session, I request Dr. Shantanu Pramanik to please come over the stage and open the session. Dr. Rupam Kumar Ta, please.
Good afternoon, friends, and we are little bit hungry, definitely, because it is already 1:30, so we will not delay much. Today's topic is very pertinent because we are just coming across the COVID third wave. We do not know what will happen next, and we are getting more complications of the COVID, just like neurological complications, cardiological complications like arrhythmia, and pulmonary complications like fibrosis, and other muscular complications, patient not able to walk. So there are a lot of complications are there for the post-COVID sequelae or long COVID. This is a very pertinent that in most of the medical college they have started the long COVID clinic, and today's topic is management of post-COVID sequelae, mainly the pulmonary sequelae. We have with us our eminent speaker and one of my good friend, that is Dr. Sushmita Raichaudhuri, and he is graduated 1997 and MD MRCP, and she is attached with the Fortis Hospital now and doing lot of interventions, like mainly the pulmonary interventions, pleural interventions she is doing. Now she is giving the lecture on post-COVID complications, mainly pulmonary complications. Dr. Chaudhuri, please.
Thank you, chairpersons. Thank you to the Association of Cardiologists and Diabetologists and Abcdcon and Dr. T.N. Bhattacharya for asking me to come and speak here. I won't keep you very long, I promise. So we'll just start. Basically, all of us have for the last 26 months dealt with a lot of cases of COVID. Thankfully, the last wave was a mild wave, but a lot of patients are coming back with symptoms that are significant to them. So this is a 27-year-old lady who only had mild COVID, was treated at home for isolation, and her lowest saturations were 95% only. She was seen only on teleconsultation, no comorbidities, but 4 weeks later came back feeling breathless, tired, and has a dry cough. And I'm sure all of us sitting here have seen these kind of patients on a daily basis ever since COVID has come. So how do you proceed to evaluate? Because a lot of patients present with tiredness and breathlessness and a dry cough. Coming to cough, the Omicron wave especially has left people with a lot of cough, with nothing else, no previous history of airways disease, nothing else. So the first symptom when the patients are seen, the thing to teach them is cough control. Cough syrups don't help in most of these patients. Anti-allergics don't help in most of these patients. The history to be taken is very important, whether there is a post-nasal drip or not, because the third wave has brought on a lot of upper airway problems, and they are left with post-nasal drip. And they'll clearly give you a history that when I lie down at night or wake up in the morning, my cough is worst. If there is a post-nasal drip, then the way to treat that is to basically give them some nasal decongestants or nasal steroids, and sometimes anti-allergics help, but not always. Inhaled budesonide is quite useful in these patients, and given for 6 weeks helps a lot of people because most of them develop some amount of airway hyperreactivity. Having said that, in the first 2 weeks, what helps is cough control, and each of us must teach our patients how to do it. What do? Ask the patient to take a deep breath in and then control breathing for 20 to 30 seconds, 3 to 4 deep breaths, and then again breathing control, and then huffing followed by cough if needed. And you will find that a lot of your patients will benefit from this maneuver, especially the elderly ones, especially the ones that are smokers. They help from this cough control. Staying hydrated helps significantly, and inhaled steroids. Antitussives should be last on your agenda, and clearly antibiotics and oral steroids have used in very, very minimal number of cases. Breathlessness, we have all realized, is the most common symptom. And in these patients, even after they have stayed at home and their saturation levels have not gone down below 92, pulse oximetry at rest and after 6 minutes of walking is recommended. And those who can't walk for 6 minutes, then 2 chair test. This was devised by our own Dr. P.S. Bhattacharya, where 2 chairs are just kept 30 meters apart and they walk between those 2 chairs in the room that they are in, or they can walk 40 steps or sit and stand in one place for a minute. Any of these, if there is any hypoxia, it is revealed by a fall in saturation of more than 3%, and that is significant. As you will see, this is a patient who came and said he was breathless, but saturations at rest were 97%, and this is 4 weeks after. And after they are walking, their saturation is dropping down to 93%. So if we had only checked the 97% saturation, we would have been happy enough that there is no VQ mismatch in the patient. But a simple 6-minute walk test unearths that, and this is a patient who will probably benefit from 5 days of oral corticosteroids if necessary. So follow-up post-admission, I should, even in patients who have been at home, I know we are a little bit too late talking about this now, 2 weeks post-admission, and review in OPD 4 to 6 weeks with a 6-minute walk test in symptomatic patients should be done. CT must not be routinely recommended. A lot of people come back 4 weeks later with a CT scan, 2 months later with a CT scan. It is not necessary in most patients, but if they have been admitted, then at 4 weeks, at 2 weeks, do check their blood counts, CRP and D-dimer. That tells you the level of inflammation going on in some of these patients. And if liver function was deranged, can be checked. Let's come to the second case of a 51-year-old gentleman admitted with moderate COVID, was treated with remdesivir and steroids. The lowest oxygen saturation for this gentleman was 89% in hospital. He received steroids for 10 days, attends OPD after 8 weeks with a dry hacking cough. Saturation at rest is fine. This is the gentleman we had been talking about. What should you do? Chest X-ray or CT scan? What should you do? 6-minute walk test, we have discussed, we should do that. Should a pulmonary function test and diffusion capacity and an echo be done? The answer is that PFT, DLCO, 6-minute test and echo, all are recommended. So if you look at this scan, this is a patient whose scan here shows multiple bilateral organizing pneumonia-like lesions, and 8 weeks later when he comes back, people call this fibrosis, but this is not fibrosis. Recognizing ongoing consolidation, organizing pneumonia from interstitial thickening to fibrosis is extremely important, because that is where your treatment will benefit the patient. So this is a patient who had ongoing organizing pneumonia, and this is a patient who will definitely benefit from further doses of steroids. So even though guidelines suggest that steroids are not needed for more than 5 to 10 days in lots of patients, but those who are hypoxic and have ongoing organizing pneumonia may need it for 4 to 6 weeks even after the initial procedure. And that has to be assessed, and your radiologist will help you know which of these are looking more ARDS fibrosis and which of these are actually looking more like ongoing organizing pneumonia. So if patients are still hypoxic, and then they will require steroids, but they must need to be followed up, and they should be in a reducing dose by a 5 milligram every 5 to 7 days, and they should be seen back in 4 weeks' time. And this is the 6 months. After 2 months of giving that, the saturation, which was dropping down from 93 to 85%, after 8 weeks is much better. Coming to the third case, severe COPD, severe COVID, lots of people are around at the moment attending our OPDs. This person needed mechanical ventilation and oxygen for 4 weeks. Resting saturation was 92% on air and desaturating to 84% on exertion. How do you manage this case? Again, the entire idea is knowing your CT scan, otherwise having a good pulmonary radiologist who can help you read the CT scan. For example, this is a patient, initially this is what the scan was, and later on he comes back with this kind of a scan, and this is 8 weeks apart. You can see that when we see this, a lot of us end up giving antifibrotics to these patients. Is it necessary? No. not all patients will require antifibrotics if there is no underlying interstitial lung disease, because as we are following up our patients, we are seeing that even the worst cases in 6 months' time are showing significant amount of clearing on their CT scan. And this is the case where you can say that fibrosis, a certain amount of fibrosis has developed, and some patients with severe COVID may continue to have organizing pneumonia, interstitial thickening and desaturation, as I just discussed. And these are patients who are labeled as pulmonary fibrosis, but a good radiological assessment is essential. And this is the patient who had received steroids reducing over 8 weeks. And that is the scan after steroids with no nintedanib. So this is the study that shows that persistent post-COVID-19 interstitial lung disease benefits from steroids in a certain subset of patients, and they must be assessed by trained pulmonologists rather than just give it to them. Coming to patients who already have interstitial lung disease, like our lady here, who was admitted with moderate COVID and her resting saturation was 90%. She was discharged on day 10 after remdesivir and steroids, and we were very happy because her saturations were much better when we discharged her. But 5 weeks later, she came back into ER with saturations of 66%. So what are the differentials? Obviously, we are worried about whether there is pulmonary embolism or not, whether this is ongoing inflammation or not, and whether this is acute exacerbation of ILD. As you can see, rheumatoid ILD, which was before, 5 weeks later, this is how it looks like, and this is acute exacerbation of interstitial lung disease, which you see in a lot of patients with ILD coming back and showing. In these patients, antifibrotics, what role do they have? So this is a very important study which showed that people who gave people with COVID, who gave antifibrotics, there is a certain role, because pirfenidone and nintedanib both have been shown to have a little bit of anti-IL-6 activity. And some of the patients who have ongoing fibrosis or hypoxia and fibrosis on their scan, they do benefit from nintedanib and pirfenidone. So that is probably the rationale where people who have been using antifibrotics in acute ILD with patients continuing to have hypoxia and evidence of early fibrosis are justified in using them. For how long? Nobody really knows. So management of post-COVID interstitial lung disease, depending on severity, continue previous ILD treatment as before, continue antifibrotics in a known UIP ILD patient and monitor their liver function tests, because you know COVID itself causes transaminitis. And if you are giving them nintedanib, please be very, very careful, because nintedanib along with the NOACs or the newer anticoagulants can cause massive hemoptysis in patients. And that is a very, very important thing to look out for. And reducing those steroids may be needed over weeks while monitoring saturation at rest. And pulmonary rehabilitation is very important in all these patients. Above all, before the patient is going home, there should be an algorithm that should be followed. This is very easily available on the BTS network, and you can have a look at it. I will not keep you away from lunch trying to tell you what investigations should be done. Finally, 22-year-old male whose COVID status was not known was treated at home because there were no hospital beds, and attended for the first time in clinic with 85% saturation and central chest pain. So we have seen in COVID, if you look at the chest X-ray, it looks quite innocently normal. But if a patient who has had desaturation at home and central chest pain comes to you 5 to 8 weeks later also with severe COVID-like features when they were at home, always please do a CT scan. And you can see here, there is a mild pneumomediastinum. With COVID, we have found a lot of patients developing pneumomediastinum because of the peripheral nature of the disease and the plebs giving away, causing pneumomediastinum. You can see there is pneumomediastinum here and here, which is the cause of the central chest pain. The good news is that most of these patients, unless they have severe underlying disease, will get better by themselves just by rest and antitussives alone. And nothing needs to be done, as was the case with him. But the rupture of subpleural bebs can cause havoc in some of the severe COVID patients, and they may not improve, and they pose a significant challenge to their management and sometimes survival. For example, as you can see, this is one of the patients where they presented with pneumomediastinum, and 27-year-old, 8 weeks post-discharge presenting with that, and some of them can really die. Pneumothorax again is another problem. So 57-year-old male, oxygen dependent, bilateral chest strains, and was cachectic, and he came to us after having visited another 3 hospitals, and we really didn't know how to help him. As you can see, there was bilateral pneumothorax on the right as well as the left. So the right one is a small loculated area. We didn't need to do anything. This patient was completely dependent on oxygen, and we had no way to we went in with a bronchoscope to see whether if we could identify one area and we could stop the leak. And we found that he was leaking both from the upper lobe and the lower lobe, and closing both areas. And finally, massive hemoptysis in severe COVID. Please remember, TB is our old friend. It has not gone away. And a lot of people with cavitary disease have had worsening because of the steroids given to them, not knowing that they have had TB, and presented with severe hemoptysis. So management of pulmonary sequelae is an MDT, has to be multidisciplinary. Management needs to be done because it's not just the lungs, it's the entire body, and the long COVID syndrome, which involves more or less all the organs. Shivananda will remember that one of the patients, she came and was every time taken in as COVID, but she basically had post-COVID myocarditis that needed to be treated, a young lady, and she still remains under the radar of Shivananda for 3 months at least. And corticosteroids and antifibrotics have to be given in a very judgmental way in these patients. At least for the next 6 to 12 months, we will be seeing a lot of these patients in all our clinics, and it will require multidisciplinary management, not just a pulmonologist or a cardiologist. Thank you very much.
Thank you, Dr. Rai Chaudhary, for finish it in time, and very lucid lecture. And we can allow 2 or 3 questions from the audience, because it is a budding problem which we are facing. Any question?
I have made myself clear, I think.
I think.
Yes, of course.
Yeah. Yeah.
And during the flight, she had a chest pain, and we found she had a DVT and she had a pulmonary thromboembolism following that. So, how are you finding this pulmonary thromboembolism problem after COVID?
I think pulmonary thromboembolism in the first 2 phases was not as much as the third one. In the Omicron wave, we are finding a lot more cases who are presenting with DVTs, with thromboembolism, not that much, but definitely stroke-like symptoms. A lot of them. So this one is a very procoagulant variant, whatever it is. And I think these are the patients where if they are not mobile, if their D-dimers are more than 1000, and if they have underlying comorbidities, we are giving them prophylactic NOACs for 4 weeks at least.
Because any question? So if there is no question regarding this, so we can conclude this session.
Thank you, Dr. Sushmita Rai Chaudhary, for being with us. Your excellent lecture, we are enriched. Now, I would request a youngster from Bardhaman, Dr. Priya Mondal, please come over the stage to deliver memento to Dr. Sushmita Rai Chaudhary. We have come to an end before the lunch session. Now, I would request Dr. Ranjit Gayan to please come over and deliver the memento to Dr. Rupam Kumar Ta. Thank you, Dr. Ta, for coming here once again. Now, I would request Dr. Jayanto Chakravarti to please come over the stage and deliver the memento to Dr. Shantanu Pramanik. both Dr. Chakraborty and Dr. Pramanik is a very active member of our ABCD, and often we meet in our seminars, different seminars. Thank you, thanks to both of you. So with this, we have concluded the pre-lunch sessions, and I would request all the delegates to please have lunch in the lunch session. We are having a half an hour break since we are running short of time. Please, after the lunch, please do come over here for the next exciting post-lunch sessions. Thank you all. Good afternoon. Welcome delegates once again to our post-lunch session of 7th Abcdcon. Again, we have a galaxy of good speakers and very relevant topic to our practice. To start with, we have Dr. Sunip Banerjee, eminent cardiologist, who will be talking about integrated HFrEF management approach, role of dapagliflozin. To chair this session, I would like to welcome Senior Physician of Bardhaman, Dr. Gishpati Chakraborty, to please come over the stage. To co-chair the session, again, I would request Dr. Sumanto Dasbokshi to please come over the stage and introduce the session. Over to Dr. Gishpati Chakraborty.
Hello. Welcome everybody. At the beginning, I am introducing Dr. Sunip Banerjee, MD DM, PGI, FSC CALT, SCI, FACC. Dr. Sunip Banerjee is the senior interventional cardiologist. He has distinguished himself in all branches of clinical and interventional cardiology with a vast amount of patients and interventional cases, more than 2,500 coronary angioplasty, more than 150 peripheral angioplasty, 15 renal angioplasty, and always eager to adopt of newer techniques and devices like FFR, more than 70 cases, CRT implantation, etc. He was invited as faculty in several cardiological conferences, including EuroPCR, NIC workshop, NEW, CSI and BIT in recent time, and presented some excellent interventional cases, including bifurcation stenting, CTO, complex peripheral angioplasty, using hardware like OCT and IVUS. So, I would request Dr. Sunip Banerjee to please come and let us have the session started now. Okay.
Thank you, Chairperson sir. Am I audible and visible?
Yes, sir. You are audible and visible.
Can be allowed to share screen?
Yeah.
Is my screen visible?
Sir, visible.
Thank you. So,
sir, screen, sir. Actually, the
yes. What do you wanted?
Your all slides are visible, sir.
Okay, I have to make it full screen. Fine.
Yeah. It's perfect, sir.
Thank you. I am indebted to the doctors of Bardhaman and AstraZeneca for giving me this opportunity. My task is to go through in next couple of slides on this concept of integrated heart failure with reduced ejection fraction management approach. So, how relevant it is for the physician and cardiologist? Yeah, it is very relevant. And although you've gone through my CV, they are focusing on intervention cardiology, but intervention cardiology is only the part of the problem or part of the task. But many of these patients invariably will have coexisting heart failure. So you need to have a holistic approach of heart failure management. And nevertheless, you need to understand that this subset of populations are very high. And so we try to master the integrated concept of heart failure with reduced ejection fraction management. Now, with this, if we go to the next slide, which highlights one important thing, that and that is a very important issues, and in every heart failure lecture we start with this. So there are stages of heart failure. So is the prevention is better than treating a heart failure. So what is prevention? As a physician, we must treat diabetes, we must treat hypertension, and we must treat the bad lifestyle, sedentary lifestyle, consumption of bad food. And all of us have this risk factor of development of heart failure, including those who are attending these sessions, including me. So if I get an acute coronary syndrome, or if a woman becomes pregnant and gets a cardiomyopathy, or somebody gets a viral myocarditis, this produces some structural abnormality, which can be detected by echocardiography. But the patient will not have clinical heart failure. And when the clinical heart failure comes, with each exacerbation, it goes downhill. So obviously, the purpose of today's meeting is to highlight the role of dapagliflozin on the stage C, heart failure. That means who have a heart failure already edited. They may be improved, but your task is to prevent further decreasing symptom. And this is what we need to understand very clearly, that if you decrease the exacerbation and you decrease the heart failure hospitalization, then the patient will be benefited. Now, how you suspect heart failure? Suspicion of heart failure comes with risk factor, what we say. Symptom and sign, very important and basic thing, what we forget most of the time. And abnormal ECG, all these three are important. Suppose the ECG is normal and you have a clinical suspicion of heart failure, you have a hepatojugular reflux which is positive, you need to check BNP to stamp as heart failure, but may not be immediately possible. So what you give IV furosemide, what you are doing actually. So, and you are doing the right thing. If the patient is improved with the IV furosemide, that means this is a acute heart failure, not a acute exacerbation of chronic obstructive airway disease, or a lactic acidosis, or diabetic ketoacidosis, or anxiety neurosis. So these are the common differential diagnosis of acute heart failure. And then you have to do echocardiography, and then we categorize in three subjects. One is ejection fraction mostly preserved, another is very decreased ejection fraction less than 40%, and there is some gray zone. So if I ask me if the dapagliflozin is effective in this subset or this subset, I think both subsets. And also to some extent this subset, but our indications of our purpose of discussion is to highlight this subset only. But in clinical practice, we get some of the cases who have a ejection fraction of 45, 46, and they are very symptomatic. So probably they will fall into this category. So in science, it is not like the treating of blood sugar, or treating like potassium hyperkalemia. So there are some gray zone where you have to take an individual decision. Now, what are the treatment of heart failure? This is a very clear medicine which you all give is diuretic, loop diuretic. So it is a very cheaper drug, and still we will be using it. But the problem of loop diuretic is that if you have a heart failure, acute decompensated heart failure, with the sodium chloride excretion, it becomes a ceiling level, it becomes less in a patient who has a ADHD. But if a healthy person takes, the more he will take IV diuretic, he will produce more sodium chloride excretion. And that's what the concept that in ADHD, the oral hardly works, but intravenous definitely produces more diuresis. So that we all know. So this dapagliflozin a water pill. So let's see what is the action of dapagliflozin. So there is a glucose filtration, glucose absorption. 90% of this is by this molecule, the receptor, which is called sodium glucose transporter 2 receptor, and 90% of this is being absorbed. And what our dapagliflozin is going to do is decrease the absorption of this thing, so that they are available in the distal tubule for increased glucose excretion. So it is actually excreting glucose, and whenever the glucose is there, it will carry fluid with it. So to some extent, it is a diuretic with more glucose transport. So SGLT, you can remember, it excretes sugar and glucose both, and that's the beauty of this medicine. With this concept is mind, what we have understood right now, probably we are talking about a medicine which is going to decrease the blood sugar and also will produce diuresis. So what is the role in heart failure? And this has been addressed in this trial which came up 2 years back, and we have to go through this trial a little bit detailed rather than just seeing the PowerPoint presentation. So I thought that I will go a little bit in this NEJM article, and this is a primary outcome of worsening heart failure or death from cardiovascular cause. An episode of worsening heart failure or unplanned hospitalization or urgent IV furosemide injection required. If this can be decreased by dapagliflozin, the trial was aimed to look into that. And who are these patients? Those who are more than 18 years, has an ejection fraction of 40% or less, as I told you, and who are really symptomatic. So not all of them has class 3 symptom, even class 2 symptom were there. So your task as a physician to pick up the class 2 symptoms. Many times people ignore and they think that this may be normal, so you must exclude deconditioning effect, anemia in these cases, but more importantly look for the patient have a heart failure. And if you do a echo and if you find the patient has only questionable symptom, then check the NT-proBNP. In absence of a previous hospitalization, if it is more than 400 picogram, then it is subjected diagnosed as a case of heart failure with reduced ejection fraction. If you have atrial fibrillation or flutter, then the baseline value has to be double than this. Now they have excluded one thing is that people, this is a run-in phase of the trial, who cannot tolerate SGLT2, who have a type 1 diabetes, and who has a hypotension and very sick with a systolic blood pressure of 95, and also a significant decline in GFR, that is a GFR below 30 ml per minute. Now, how sick is this patient? You need to understand. Before that, you focus on this, that this being a diabetic medicine at the beginning, in this 1:1 placebo-controlled trial, 40% of the patient has only diabetes. That means 60% doesn't have any diabetes. And that's the important reason why the cardiologist is being in the picture to give a lecture on dapagliflozin. And many of them have only mild heart failure. Remember, mild heart failure, that will be the limitation of from your end to start this medicine, that if the patient is mildly symptomatic, should I give it? Yes, you should give it, because in this case, majority of these patients are only mildly symptomatic. And as they are mildly symptomatic, their blood pressure was also acceptable, the NT-proBNP was high, and majority have a ischemic cardiomyopathy. In the non-ischemic form, it might be a postpartum, it may be a viral myocarditis or any related cardiomyopathy. In some cases, we have not been able to understand the reason. And all of these patients were very sick, as I told you. And some of this patient has a cardiac device in the form of resynchronization therapy or implantable defibrillator. So implantable defibrillator we give if the patient has an ejection fraction of less than 35%. So these are really sick patient, and also some patients who are mobile. are these patients being given a heart failure medicine already before giving a dapagliflozin? That is important. And as we know, before dapagliflozin, we have few drugs, that is diuretic, which actually produces symptomatic relief but no survival benefit. The other diuretic-like actions, the mineralocorticoid and receptor antagonists, that is eplerenone or your spironolactone, was the next commonly used. ACE inhibitor or ARB was used in a substantial number of population, and beta blocker also given in a very high number of population. Sacubitril valsartan came just in the market, so it was not being used, and probably it will not be used in our country to great extent because of the cost of the therapy. And the diabetic patient also are receiving several things, but my cast is to focus on, is the diabetic or non-diabetic population was equal in the outcome. And also you need to understand what are the symptoms. Symptom was dyspnea, decreased exercise tolerance. So many a times if you ask your patient, do you feel breathless? They will say, no, it's fine. Then you have to understand that there are many patients who decrease their activity because of reduced exercise tolerance and fatigability. And other symptoms of worsening organ perfusion, that is your renal dysfunction, confusion, all this thing. And this is very important in clinical practice to know that if a patient with heart failure, chronic heart failure, suddenly is not well, just not well, nothing else, it may be a decompensating heart failure. And they had a peripheral edema, they have pulmonary crapules, that is 3. So why I am talking about this slide is because we need to understand that clinical medicine triumphs over anything else. And these are the echocardiographic finding. I am skipping it because that's the next thing. And many of the patient was also on inotrope vasopressor because acute decompensation was there. And what they did, there was a run-in period where the SGLT2 was being tolerated by them or not. Many a patient may not tolerate it, but as the glucose was being excreted, if they have a long prepuce, if they have a phimosis, or they have a very bad genital hygiene or obstructive uropathy, they may have a recurrent. So if they cannot tolerate in this 2 weeks time, they are out. Otherwise, they have been equally divided in 2,500 almost patients who have on existing medicine for heart failure, that is either ACE inhibitor. So numerous, pneumonia, sepsis, bronchitis, cellulitis, multiple things. But the thing is, in non-diabetic patients, the chances of your renal infection in this ballonoprosthitis and all was not significant. This is most important to know. So even there was no patient who had a chronic or acute kidney injury, which happens with a diuresis. And JAMA group last year wanted to see that how much is beneficial this medicine, which has been originally destined for diabetic patients, but now we are saying patient with normoglycemia and heart failure with reduced ejection fraction, they are getting benefited. So this is a subgroup analysis, and what they have found that even in non-diabetic patient, dapagliflozin works better. The risk reduction is robust. So you have to come out from this concept that my medicine is a patient who will have a glucose, urinary glucose 2+, and he will come, sir, I might become diabetic. So you have to explain all these things. No, you are not diabetic. Your sugar is being going out. And this is neither a diabetic pill, neither it is going to produce hypoglycemia. And you are not going to have any other anti-diabetic drug. And so is it all diuretic-like effect? No. This is a slide from the basic research sciences from Europe. They found that actually it produces glucosuria, decreases serum uric acid, and decreases the oxidative stress. So rather than giving febuxostate, give this or allopurinol. So the uric acid marginally will calm down. Intracellular sodium load will be less. So the mitochondrial health will be improved. With this, there will be more autophagy. That means the bad or apoptotic muscle will be dead, and cardioprotection is robust. So the medicine is a diuretic-like medicine, produces glucosuria, but doesn't produce hypoglycemia and produces cardioprotection. And with this thing in concept, the foundation for heart failure, now you have ACE inhibitor or ARB, you give either ramipril or valsartan. And if your patient can afford, switch over to ARNI, and obviously beta blocker, that is metoprolol, succinate, not the tartarate, bisoprolol or carvedilol. Carvedilol is preferred if the patient has an advanced chronic kidney disease or the blood pressure on the higher side. Otherwise, the beta blocker carvedilol is less preferred. Aldosterone antagonist, and if you give these two, you have to keep a close eye on the potassium. And there will be new medicine coming sometimes this year where the potassium issues will be resolved. And then the most important thing is the addition of dapagliflozin. So this foundation 4, 1, 2, 3, 4, or 1, 2, 3, 4 is the key to the success for a smart approach in heart failure with reduced ejection fraction. I end here. This is my email ID. If you wanted to communicate with me, can send me question. I will be happy to answer. Thank you, Chairperson, sir. I end it here. Yes, Hajra sir, you are ready for the next talk. Any question from your end? If not, then we move to the next session.
It's not audible from audience part, sir. I believe sir is saying something from the dais. If there is any question,
I am waiting. I am waiting.
Now I would welcome to felicitate our chairperson, Dr. Mofidul Islam, please, to Dr. Gishpati Chatterjee. Dr. Shumanto Dasbokshi, please. Well, once again, thanks, a special thanks to Dr. Sunip Banerjee for delivering his lecture. Now, we are on the verge of another new session, and we have a very, very famous and elegant speaker, Dr. P.K. Hajra. Dr. Hajra sir will be speaking about antiplatelet drugs, newer versus conventional. To chair this session, I would request Dr. Sujan Sarkar to come over the stage. And Dr. Satyajit Rai from Asansol, all the way along he has come to attend the conference and we are glorified by his presence. Please come over the stage. Now, session is over to Dr. Sarkar and Dr. Satyajit. টপিকটা হচ্ছে antiplatelet newer versus
antiplatelet drugs newer versus conventional.
Good afternoon, respected delegates. Now we are going to start this session. Our speaker is eminent cardiologist Dr. Prakash Kumar Hajra. He will talk on antiplatelet drugs, newer versus conventional. Dr. Hajra is MBBS, MD Medicine and DM Cardiology, and he is a senior interventional cardiologist, presently HOD, Department of Cardiology at Amri Hospital, Dhakuria. I will request sir to start the session.
Thank you very much, ABCD, and all the best wishes from Kolkata. My topic is antiplatelet. You know, the concept of antiplatelet or double antiplatelet did not come from any randomized.
Voice test.
It came from a prospective from France, and she is the lady who introduced this DAPD concept with ticlopidine. So if you replace warfarin and aspirin by ticlopidine and aspirin, perhaps you reduce death by reducing stent thrombosis. And since then, we have a beautiful journey in the treatment of coronary artery disease, cerebrovascular strokes, peripheral vascular disease, with or without stents. Now, if you're dealing with small coronary arteries, where the diameter varies from 2.5 to 5 millimeter, the need for antiplatelet is very strong if you put a stent. The need for antiplatelet in the peripheral vascular disease, for example, if you put a stent in the legs or in the subclavian artery, the need for longer antiplatelet is very minimal. Perhaps most of these cases can be done with bare metal stent. Now, there is some historical myths about our science and the progression of the science. We need to as metal stent. Then I first that was a kind of mistakes we have done about the design. But most of the stents are now very safe. So coronary artery disease is like a pimple of the face. It is mixed with flesh, bone, scarred, treated, untreated, necrotic rupture. The fresh pimple, fresh eruption can cause acute syndrome, and they are they poison. I mean, they are going into chronic stage. We need some drugs which can give rise to a pain-free or a stress-free life, like you are stabilized. So antiplatelet along with statins and other drugs are very important to make this pimple, which is erupting with necrotic core in the form of rupture or environmental function. Once you go downstream with time, perhaps the need for double antiplatelet or aggressive antiplatelet comes down to single antiplatelet. Now, out of these, there may be some ups and downs, which can be due to many things like stress. So stent actually needs a cosmetic cover. You can put one stent for one pimple, two stent for two pimples, and a long stent.
once you increase the number of stents and you make it very complex, like biophysics that train for the syndrome, there is always a fear of death, and that is because of stent thrombosis. Now, even if you do not put a stent, this pimple can be on your back, can be on your hand. So this is quite widespread atherosclerosis. So some are visible, some are not visible. So invisible coronary artery disease in other territories, the plaques, the peripheral vascular disease, cerebrovascular territories, will be protected from future event, acute event, by polypharmacy, which is very, very interesting nowadays in presence of diabetes like SGLT2, GLP-1, statin, PCSK9 inhibitor, gene silencing, sRNA like inclisiran, bempedoic acids, and fish oil. But ultimately, you need at least one antiplatelet, which is ticagrelor most of the time. And the need for aspirin is coming down, but we cannot forget aspirin, the basic idea of preventing acute complications or acute event came from aspirin only. So that is a long journey of aspirin, and we have many trials started with aspirin, then ticlopidine. The problem of ticlopidine was the pancytopenia and bone marrow depression. Then we are quite happy with clopidogrel, but clopidogrel story got little bit subdued because of Asians. 30% they are clopidogrel resistant. And once you have this clopidogrel resistance, you can have a breakthrough event like stent thrombosis. Then we look for a stronger, better, more efficacious P2Y2 inhibitors like prasugrel, and which came from a large randomized clinical trial in 2006. Then the ticagrelor trial, Plato trial came. Again, in 2015, after almost 10 years, we learned that if you reduce the dose of ticagrelor, where the bleeding is an issue from 90 milligram to 60 milligram, you can perhaps continue this 60 milligram twice in a day, lifelong, without aspirin, or with aspirin. If you think that he's got high ischemic risk, that means you have put too many stents, small vessel, diffuse disease, overlapping stent, CTOs. So there are some cardiological interventional criteria which makes your patient angioplasty more complex, but most of the time it is a single stent. So Pegasus trial took us further, and with the advent of newer dimensions of your antiplatelet, newer patient characteristics, there were some trial which told us that pre-treatment and the timing of antiplatelet with ACL. Now, pre-treatment with antiplatelet, especially ticagrelor, did not show us any significant advantage over the on-table MAT means during the angioplasty. So we have moved with many trials. There are many, many trials, but in essence, we have increased the number of tablets initially from single to double. Now we have come down from double to single again. So this topsy-turvy course is complemented by newer imaging and newer data. And we have moved forward with a lot of promises from this trial, and a lot of wisdom came from this Pegasus trial and Compass trial. So perhaps we are moving from single antiplatelet to DPI, where aspirin plus rivaroxaban can reduce in a very complex situations like more than 65 years with 2 additional risk factors like smoking, hypertension. That is one special way of treating some patients. The usual way of treating these patients from double antiplatelet to single antiplatelet, and the timeline of antiplatelets has changed over time as you have gone through this PCI-QO trial. And this trial is almost 20 years back. We are celebrating 20 years of clopidogrel and PCI-QO trial. From clopidogrel, as I mentioned, prasugrel, ticagrelor, the timing in ACS has not changed from 12 months. So most of the ACS patients, 12 months, but if you have chronic coronary syndrome, you can reduce the duration of antiplatelet to 1 month if you're putting 5th generations of coronary stents. There are some trials which tells us it can be continued up to 3 months. There are some trials or some strain where it can be stopped even after 15 days, like Cobra. So Indian and Asians, they bleed more. So we have to use a molecule which can give rise to protections from the acute stent thrombosis event. At the same time, will cause less bleeding. So there are different factors who are responsible for this increased bleeding, maybe some genetic factors. So Asians, Indians, we bleed more. So bleeding is a nuisance bleeding most of the time, but sometimes the bleeding is a blessing in disguise. For example, if you bleed from the GI tract or bleed in the urine, perhaps you go for endoscopy to pick up cancer, to pick up bladder tumor. So sometimes the bleeding is a blessing in disguise. But if it is in the neuronal structure like brain, it can cause death. So we don't want bleeding, but if it comes, it should be investigated. And we are compelled to stop many antiplatelet if somebody bleeds. So somebody who bleeds, they bleed usually early in the course of the disease, the first year, usually who tolerate double antiplatelet therapy, either aspirin, clopidogrel, aspirin, ticagrelor. They do tolerate if you do not bleed. And another situation, you know that most of the time, we use many other associated drugs like GP2B3 receptor antagonist. Now we have many people who has got acute myocardial infarction. They usually vomit on the table. They go into cardiogenic shock. Once you give morphine, they vomit more. Once you give any other drug because of heart ischemia, they vomit more. So we have to use some drugs which can work immediately. So that is cangrelor, that is intravenous antiplatelet. Now it is available in India. That has removed one prescription, that is GP2B3 receptor antagonist, in the armamentarium of acute antithrombotic in cardiology. So GP2B3 receptor is dead because of cangrelor and ticagrelor especially. And we have moved from longer duration to shorter durations. That is new. Another new thing is now if you have a ticagrelor on board, if you are dealing with acute emergency appendix, you can have a problem of bleeding. The surgeon may not agree to operate. And the problem is same with clopidogrel and prasugrel, but especially ticagrelor, you have now reversal agent. So 6 days, 7 days waiting sometimes is not permissible because of patient's condition like rupture gallbladder. You can go ahead and operate, but there will be some bleeding risk. So there is a ticagrelor reversal agent available, and it is proved by trial. So the rapid CEBG, before CEBG or any other drug, if you can stop, you can stop for 6 to 7 days if it is chronic coronary syndrome. But if it is very early in the course of stenting, then only one way you can now you can have less risk of stent thrombosis during surgery, like gallbladder surgery or this hernia surgery. You have to stop ticagrelor. Then you have to infuse cangrelor, which can last for just 5 minutes. The half-life is 5 minutes. Once you stop intravenous cangrelor, you operate, then you switch to ticagrelor as and when it is permissible by the surgeon. So simplistically speaking, you fall back on newer antiplatelet P2Y2 inhibitors like cangrelor, that is called bridge to surgery, followed by your clopidogrel or ticagrelor. Now, there is a disturbing news of bleeding from China, and they have said that if you lower cholesterol with PCSK9 or statin, those who are on clopidogrel, you can reduce up to 54 milligram, but you cannot reduce below 88 milligram with ticagrelor. Some people do not believe this story, but that is one of the newer observations. So Twilight, Global Leaders, Top Deputy, Smart Choice, Smart Deputy, DAPT, TICO, there are many trials which tells us the shorter is the better. If you are compelled to stop, you can stop in chronic coronary syndrome. If you want to continue, you can continue lifelong, but usually after 6 to 7 years, the effect of ticagrelor wanes, and perhaps you can continue aspirin with statin. If you have atrial fibrillations, you can continue clopidogrel with NOAC or clopidogrel with warfarin. But if you do not have atrial fibrillation, if you're in sinus rhythm, either you can live with DPI way, that is rivaroxaban 2.5 milligram twice a day plus aspirin, or DAPT way, which can be either aspirin plus ticagrelor, which is my practice. Now, as I said before, that many things already known to you, and many people have said it before, and I want to say it again, that most of these cases which we are doing in nowadays is followed by good imaging, a good job on the table, followed by DAPT for some time, 1 to 3 months, then SAPT for lifelong. It can be either ticagrelor or even prasugrel for reason. Prasugrel, you have to understand that more than 75 years, less than 60 kg, no history of strokes. Those kind of inhibitions are there with prasugrel, but it's not there with clopidogrel or ticagrelor. Elderly people, you can use clopidogrel. CKD patients, there is no issue with ticagrelor or clopidogrel. So with that, the things are progressing very fast, and perhaps there will be a competition between DPI way and the DAPT way. With that, I would like to thank for your kind attention. Thank you very much. Yes, yes, yes. Yeah, that's a very good question. Like, it is not that strong with CABG because you are not putting any foreign body there. Most of the CABGs are done nowadays with arterial grafts. If you're putting arterial grafts, perhaps there is no need for double antiplatelet for longer duration of time. The problem comes if you're putting venous graft. So if your CABG is done with LIMA and RIMA, you may escape double antiplatelet. You can live with just aspirin alone. If patient cannot tolerate aspirin, you can give them a clopidogrel. But there are studies now that if you have a mixed scenario like venous graft plus arterial graft, you do not know whether this venous graft will close immediately or not by any other means, because most of the CABG patients, they do not present like stent thrombosis, like chest pain and hypotension. And they present with hypotension immediately after CABG. So if you think that this aspirin plus ticagrelor or aspirin plus clopidogrel for at least 3 months, and you know this patient are having extensive atherosclerosis, to prevent the event, not only the grafts, because we are protected coronary artery now proximally, you can prevent a stroke in the brain. It might have put a graft in the coronary disease, it might be having the access to the plaque in the carotid in the brain. So giving antiplatelet of preventing stroke, these people are more prone for stroke if you have a CABG. For the venous graft, some people also are thinking of Euroxon 2.5 mg twice a day along with small dose of aspirin. So in one word, post CABG patient, if you have venous graft, then you have issue with DAPT, but if you have pure arterial graft, you can just continue aspirin for some time, and if somebody is having low bleeding risk, perhaps you can continue lifelong.
Thank you. Any other question? I've got one question, Dr. Thank you very much for this presentation. Suppose I am having a patient who has very thrombotic burden, very much thrombotic burden, and now developed onto DAPT and now developed upper GI hemorrhage or any organ hemorrhage. So how to reintroduce and when to reintroduce the SAPT or DAPT? Can you highlight on that?
Right, so very good practical question. If somebody who is already on DAPT or SAPT, it could be either on aspirin, clopidogrel, aspirin plus ticagrelor, aspirin plus prasugrel, or monotherapy like ticagrelor, clopidogrel, or prasugrel single-handedly, or even some people can be all over a one, and they bleed their resting to bleed. Those who bleed their usually bleed early in the course of initiation of therapy, usually in the first 6 months. Most of these bleeding are from the GI bleeds. Next site is your urinary bleeding. And the rarest is your
brain bleeding or spinal cord bleeding. And nuisance bleeding from epistaxis or dental bleeding are not taken into considerations. There is no need to stop DAPT because of nuisance bleeding. The two serious bleeding, as I mentioned, we need to stop both the events. And if it is acute like event like the Abcdcon syndrome, you just put the stain with the left vein, you cannot stop both antiplatelets at this one antiplatelet. So we continue to do the endoscopy. If there is a lesion which can be cauterized, we cauterize them. If there is a prostatic hypertrophy causing bleeding, you just go for embolization of the prostate artery. If you have a bladder tumor, you remove that bladder tumor by cautery. So if it is a disease where there is a therapy and that can be done without major surgery, you can go ahead. Second, if you have a bleeding like a spotting artery in the urinary bed, like Dupois or something like that, you can go for angiography, you can go for embolization of that venous artery, whether it is aneurysms, so many things. But before going into reintroductions of double antiplatelet or single antiplatelet, one antiplatelet should be started at one time, not the both antiplatelet. Perhaps with the BSL means from stronger antiplatelet like pacibutylate or 2 clopidogrel, and clopidogrel first, then you can start aspirin. Now, the prostaglandin inhibitors are also used if you have aspirin on board. That can be reversed with prostaglandin inhibitor, but clopidogrel, clopidogrel cannot be reversed with prostaglandin inhibitors. The best way, as I suggested, that if you have a recent stent, you give them Cangrelor, do the endoscopy. Cangrelor is reversible, very rapidly reversible in 2 seconds or 2 minutes. If you have detectable ulcer, bleeding parts, you close them by surgery or endoscopy means. You can continue intravenous Cangrelor as long as you want, but these are costly. Once you are happy that he is not going to bleed anymore, you can go for a cover with the single antiplatelet, something factor 7 is required, sometimes the plasma is required, the glucosamine manner. Everything has to be looked into thoroughly so that anything is you are not missing any untoward cause of bleeding like liver cirrhosis, abnormal INR, variants. So these things are very important. But this is the real problem. So your patient is in front of you, you take your call, which you want to go, but it can be stopped if you really want to stop after 3 months of Abcdcon syndrome, after 1 month of Abcdcon syndrome, with modern stents, like giants, like your Onyx, these stents are very safe. What about the intracerebral hemorrhage? One can start this going with the DAPT or etc. That's a little tricky situation. Now we go by the NIH score. If you have a mild bleed, if you have a recent stent, we can continue one antiplatelet therapy. Now we have to judge which one is more important. Like if you put the stent in the diagonal artery, if the diagonal artery closes, nothing is going to happen. But if you come to DAPT, you can die due to bleeding in the intrathecal parenchyma. If you put the stent in the left vein, the proximal level, the chance of death is very high. You cannot stop both. So stop one, most likely is aspirin to stop because we can safely drop aspirin nowadays with the advent of P2Y2 inhibitors. If someone is interested, we change it. We change it to SEPA, like clopidogrel, and if it is a major, there is a certain score, like a score or CT scan. If it is a major bleed, it cannot bleed anything. It is going to die because of accumulation of double antiplatelet. If I other reversal agent might be available, as I said, these MAPs are really available, and ticket or reversal agent, but no such thing available for clopidogrel, aspirin, or Prastil in the time being. We can give these factor 7 inhibitors, if it is not induced bleeding, we can give some reversal there. But DAPT is really true, if it is major bleed, we stop it, if it is minor bleed, it is your fault.
Thank you very much. If there is any other question, I can put it in the chat box. Thank you, Dr. Abcdcon, once again for your excellent deliberation. Thank you so much. Next, we are invited. that is all for this DAPT. Next program is CN Group 2 to co-chair. Over to Dr. Banerjee. Please on that.
safer, but not so in the general population. So who are the at-risk population? The household and sexual contacts of hepatitis B positive people who have used intravenous drugs, who have got multiple sexual partners, inmates of correctional facilities, people who are undergoing renal dialysis, people who need immunosuppressive therapy for rheumatological or oncological reasons, and all pregnant women are at-risk population to get hepatitis B. Now, hepatitis B is a little like tuberculosis. As we say that everyone in India has got the tuberculous bacillus inside our body. Whether it creates disease or not is the question. So we all are TB infected. Maybe we do not have the disease yet. So similarly, if a person has got hepatitis B inside his or body, so that may be manifest or that may be latent. So we need to know two things about hepatitis B. I'll just spend a few minutes on the life cycle of the phases, natural history of hepatitis B infection. So if the hepatitis B is lying silent inside the liver, it is known as infection. If the body's immunological response is targeting the hepatitis B, that is, body is no longer immunotolerant towards hepatitis B, then what happens? The immunological reaction acts on the hepatocytes. It destroys the hepatocyte, and we have an inflammatory reaction in the liver, which we know as hepatitis. Other than that, we have the E antigen of hepatitis B to consider. Now, traditionally, we know that E antigen is a find out whether the patient has received some hepatitis B therapy before. Comorbidities are also very important because they will guide the natural history of the infection and as well as the patient's treatment responses, the treatment planning. So we need to find out whether the patient has diabetes, hypertension, CKD, any cardiovascular disease, any neurological disease, any malignancy, or if there is any life-threatening illness. So how do we decide on whether to treat a person with hepatitis B positive? So remember, we require 3 or 4 things. Number 1 is the hepatitis B DNA. If the hepatitis B DNA is negative, the person does not have any hepatitis B DNA, it's below detection limit, we will just follow up, no need to treat. How do we follow up? I will come to that later. If the patient is hepatitis B DNA positive, we need to answer a question, whether the person has got liver cirrhosis or not. If there is ascites, if there is varix, if there is history of variceal bleed, if there is low albumin, if there is on ultrasound, there is irregular margins of the liver, if there is presence of splenoportal collaterals on the ultrasound, these, if they tell us that yes, the patient is a cirrhotic patient, then whatever be the DNA level, we will treat that patient. Even if that person has got a 75 or 125 DNA level, if the person is cirrhotic, if he has got a varix, if he has got ascites, we will treat that patient. If the patient is not cirrhotic, for example, a person who has come for a routine cholecystectomy, the liver ultrasound is okay, the fibroscan is okay, then we need to find out whether the patient has got a E antigen positive or E antigen negative. As I mentioned before, E antigen negative means the disease has been there for a long time. So the threshold, so our tolerance level for E antigen negative individuals is less. We will start treatment at lower threshold values because the disease has been there for a longer time. So the cutoffs for E antigen positive patients is DNA of more than 20,000. If an E antigen positive patient has got 2,000 international units of DNA, we will not start therapy. If the person is E antigen negative and the DNA is more than 2,000, we will consider it as a threshold for starting therapy. Next parameter we should consider is the ALT. So the first was DNA, second was E antigen, third is ALT or SGPT. Now, this signifies whether active necroinflammation is going on inside the liver. If we see that ALT is normal, it has been normal over the last 3 months, over the last 6 months, it is persistently normal, then we can be justified in following up the patient, not starting the therapy. Because hepatitis B therapy usually is a lifelong therapy. So we should be very stringent in whom to start the therapy. So E antigen positive person with DNA of about 21,000, ALT is 16, 18, 21 like this. So we can opt to follow up the patient. If the ALT is more than 2 times the upper limit of normal, suppose 96 ALT, suppose we consider ALT upper limit of normal if we take it as 40. So if the patient is having ALT of 115 or ALT of 120, we will straight away start the therapy for the hepatitis B. Now, this is very clear, less than persistently normal and more than 2 times the upper limit of normal. What happens to the gray zone in between? If the patient's ALT is continuously between 42, 46, 61, it is persistently 1 to 2 times of the upper limit of normal, then we have to take some additional help from either liver biopsy or fibroscan. Now, liver biopsy is a cumbersome process. It's not possible to do in our daily practice unless we have got an institutional backup with us. There are some complications with liver biopsy like bleeding, some pain, so patients might not be preferring that. And the word biopsy evokes a terror in every patient. Oh, biopsy, I'm having cancer. So it's very difficult to convince people even to have a biopsy. So that is why fibroscan is very important. I'm not going into the exact details of the fibroscan. Basically, what it does is it measures through an ultrasound probe how stiff the liver is. Now, for example, we all know that during the winter months, we can hear the sound of the railway station, like the announcements from the railway station. That is because the air is thicker, the medium is more dense. So the sound waves travel faster. Similarly, if the liver is more fibrotic, if the liver has got chronic damage, the liver will be more denser and the ultrasound waves will travel faster. So using this principle of fibroscan, we can correlate or back calculate how much liver fibrosis is there. So if the liver biopsy or fibroscan tells us, now I'll just stop here and tell a special scenario. You remember the persistently normal ALT values which we left for follow-up? If those patients are more than 30 years of age, if they have a strong family history of cirrhosis or HCC, then we may be justified in offering them liver biopsy or fibroscan, because in those people who have got a family history of cirrhosis or HCC, the virus which they are having probably has got more mutagenic potential. So these are especially at risk population, and we can also offer them liver biopsy or fibroscan. So if the liver biopsy or fibroscan shows there is significant necroinflammation or even some mild to moderate degree of fibrosis, we will be justified in starting hepatitis B therapy. So to recap, we have hepatitis B DNA, we have got ALT, we have got liver disease severity. If the DNA is more than 2000, ALT is more than normal, there is moderate necroinflammation or fibrosis on the biopsy, we will start therapy. Any cirrhotic patients, compensated, decompensated, whatever be the ALT value, whatever be the DNA, we will start therapy. If the patient has got more than 20,000, ALT is more than 2 times the upper limit of normal, whatever be the liver disease severity, we don't need a biopsy, we will start the therapy right away. If the HBV DNA is high, maybe like 10 lakh hepatitis B DNA, the ALT is persistently normal. If the person is E antigen positive, person who is around 34, 35 years of age, we may be justified in starting therapy as a special case. And of course, if the, as I mentioned, if there's a family history of cirrhosis or family history of HCC, we can start hepatitis B therapy at any DNA or any ALT value. The drugs in our armamentarium include tenofovir, entecavir, lamivudine, adavovir, telbivudine, and tenofovir alafenamide. These are all potent drugs with high antiviral efficacy. They provide long-term suppression. They have got usually a very high barrier to resistance. Other than this, PEG interferon can also be used, but that is a separate ball game altogether. I'm not going into PEG interferon. So tenofovir, entecavir, and tenofovir alafenamide are the main drugs in our armamentarium. How do we monitor people on therapy? So all people whom we have started on tenofovir or entecavir, we should do an ALT and a DNA every 3 to 6 months, ideally 3 months, but sometimes financially it is not possible, so we should do it every 6 months at least. To know the E antigen status, we should repeat the E antigen and anti-HB every 6 months to know whether the E antigen positive patient has become E antigen negative while on therapy. Very important for every people it must be done is the HCC screening. Hepatitis B is a very, very strong risk factor for hepatocellular carcinoma. If we pick it up at an early stage, we can have curative therapy for hepatocellular carcinoma. If it is late, we won't have much choice of treatment. So HCC screening, ideally every 6 months an abdominal imaging should be done. So 6 months, in June you do an ultrasound, in December you do a CT scan, again next June you do an ultrasound, again next December you do a CT scan. In this way, even if there is development of HCC, we will be able to pick it up early and send the patient for therapy. Renal toxicity monitoring should also be done, especially on patients with hepatitis B therapy. Normally, the hepatitis B DNA will fall rapidly. It will become undetectable. We call this virological response. If there is less than 1 log response after 1 year, it is called as primary non-response. If there is more than 1 log response in the hepatitis B DNA level, but it does not touch the baseline, we call it a partial virological response. And if the HBV DNA after starting therapy becomes undetectable, then again rises up, we call it virological breakthrough. So how do we evaluate for response? We look for E antigen loss. We look for HBsAg loss. We look for normalization of ALT. And if a repeat biopsy or a repeat fibroscan is possible, we try to look for decrease in the necroinflammatory activity or decrease in the fibrosis score. So the endpoints of therapy is long-term suppression of hepatitis B DNA, E antigen loss and development of anti-HB, and a distant and probably not achievable goal is HBs antigen loss and development of protective anti-HBs antibody. Can we stop the therapy? If there is hepatitis B surface antigen loss, we can, but this is a very rare occurrence. If the patient is E antigen positive from the beginning, and then over serial monitoring, we find that the patient becomes E antigen negative, develops anti-HB antibodies positive, that is E seroconversion occurs, the DNA remains below detection limit for a long time, then we should give the therapy for 1 more year to consolidate our gains, and then we can stop. For E antigen negative patients, if the DNA is below detection limit for at least 3 years, then we can stop, but we should inform our patients that we are stopping it, but there is a 50% risk of virological breakthrough within 1 year of stopping the antivirals. If the patients are not on therapy, if E antigen positive patients, they should be followed up approximately every 6 months. E antigen negative, more than 2000 DNA, they should also be followed up about 3 to 6 months. Tenofovir alafenamide is the new drug which has come as a newer prodrug of tenofovir. What it does is it decreases the bone marrow and it decreases the bone density and the renal side effects of tenofovir. So advantages of using tenofovir alafenamide are people with existing bone disease, like those who are using steroids for a long duration, history of fragility or fracture, or those known to have osteoporosis, or people with already existing renal compromise. The advantages of using tenofovir alafenamide is the same efficacy, no resistance, improved GFR, and improved bone mineral density. I'll just spend a few slides on the hepatitis B in special populations, especially in CKD. Treating hepatitis B in CKD is a challenge because of the polypharmacy. Renal failure itself is an immunosuppressive condition. There is chances of recurrent nosocomial transmission, and people with CKD, if they undergo a kidney transplant, they will be having lifelong high-dose immunosuppressant therapy. The amount of drugs we have is also limited in CKD, and it is very hard to get evidence about efficacy of these drugs in CKD because CKD patients are usually never included in any of the drug trials. So we don't know what are the criteria for starting therapy, whether the cutoff values, but a practical way would be to start hepatitis B therapy in all patients undergoing hemodialysis if the DNA is more than 2000 regardless of the ALT level. If the liver biopsy can be done safely, or else the fibroscan shows a moderate fibrosis, then we should be starting therapy. The dose modifications of hepatitis B drugs for CKD patients are, for tenofovir, we split the dose in alternate day or every 3-day doses. For tenofovir alafenamide, we can safely give this medicine for till the GFR is about 15. We can give 25 milligram per day even without any drug dosage modification. If the patient has got a lesser GFR than 15 and the patient is on hemodialysis, we can give the 25 milligram dose of tenofovir alafenamide immediately after the hemodialysis. If your patient is already on tenofovir, the earlier prodrug of tenofovir, 300 milligram tenofovir dipropoxyl fumarate, or the patient is on entecavir and the patient comes back to you after 1 year, he's still taking the old drugs, you are justified to adopt the practice of switching over to tenofovir alafenamide or TAF because it has been shown to have equal antiviral efficacy and rapid decrease of surface antigen levels. For HIV, hepatitis B co-infection, the ART should be started irrespective of the CD count, and the antiretroviral therapy should contain either tenofovir dipropoxyl fumarate or tenofovir alafenamide. In pregnancy, if a pregnant lady is newly diagnosed with hepatitis B during pregnant, if the DNA is more than 2000 IU per ml, the tenofovir is to be started at 24 to 28 weeks of the gestational age and continue 3 months postpartum. This is done to prevent the transmission of the hepatitis B from mother to child in the peripartum period. So we want to start the therapy earlier, give the chance for the virus to come down during the delivery period so that maternal to child transmission will not occur. If the patient is HbSAg positive already on entecavir becomes pregnant, we should shift to tenofovir, because tenofovir has got a wonderful safety profile in pregnant and breastfeeding women, as shown in ample evidence in HIV positive mothers who have been treated in Asia and Africa for a long time. And it is always very important to confer with our gynecology colleagues who will be actually delivering the baby. We should remind them that the child immediately after being born should receive active and passive immunization immediately after birth. And we should reassure the mother that breastfeeding is not a contraindication while taking the hepatitis B therapy, that is tenofovir. I'll wrap up very soon. So what we have here is, what we actually do is a cosmetic cure for hepatitis B. All this talk that I gave is basically a cosmetic cure. We are clearing the blood of the hepatitis B DNA, so that the next time I do a blood test, it will show no virus in the blood, and I will tell the patient, oh, you're doing so well. But what actually happens is the hepatitis B genome, it gets integrated inside the human genome, inside the hepatocyte. So although we are curing the virus from the blood, the virus of the hepatitis B still gets integrated inside still remains inside the hepatocyte. So the factory is still there. The factory, raw materials are still there in the factory. As soon as we stop the medicines, the factory will start running again, will produce more viruses, and will cause the breakthrough, as we saw a little while earlier. So the concept, as we can see here, the particles in the blood are getting decreased, but still there is integration inside the hepatocyte genome. So the concept of functional cure, the complete cure, is to eliminate the presence of the close covalent circular DNA and the integrated genomes inside the hepatocytes. We will be searching for cure of hepatitis B virus, complete cure inside the life cycle of the hepatitis B. Numerous medicines are coming which are targeting the entry point of the hepatitis B into the hepatocytes, which are some have got silent siRNAs, some immune modulators are coming, but these are still in the research stages, and probably we will have much better medicines in our armamentarium in the future. I thank you for your patient hearing.
For asymptomatic HbSAg positive patients, whether to treat or not?
Yes, sir. So if the patient is asymptomatic, we still have to find out whether the liver disease is there or not, whether the patient is having a compensated cirrhosis, some advanced fibrosis is there or not. If you do a fibroscan in that patient and find out the fibroscan value is about 18 or 20, so which is quite high and suggests that there is significant advanced fibrosis. So even if the patient is asymptomatic, we will have to start the therapy. We will not wait till the patient develops jaundice, we will not wait till the patient develops a hepatitis B flare and decompensate with ascites. We will not wait till the patient develops an HCC. So it's better to start therapy early, even in asymptomatic patients.
Thanks, Dr. Vishnu, for your excellent lecture. If there is any question from the audience, I think this is a very extensive and very conclusive lecture. So if there is no question, I am going to declare the session to an end, and I would request Dr. T.N. Banerjee to announce for the next session. Dr. Vishnu, please wait for your memento. I would request Dr. C.N. Gupta to please hand over the memento to Dr. Saptarshi Vishnu.
May I request Dr. Banerjee, just hand over the memento.
Good afternoon once again. So, welcome delegate. Please charge up yourselves, no more yawning. We have another good session from a very well-known cardiologist, Dr. Debashish Ghosh. Dr. Debashish Ghosh, he will be talking about GDMT in de novo HF-REF patients. To chair this session, I would request Dr. Jayanto Rana to please come over the stage to chair this session. And Dr. T.N. Banerjee once again to please come and chair this session.
Now our renowned speaker, Dr. Debashish Ghosh, has a vast experience, is 25 years in the field of cardiology. He is the professional membership in the Royal College of Physicians, Cardiology Society of India, British Society of Endocrinology in UK, and specialty, that is accreditation of the Cardiology, Royal College of Physicians, Cardiology Society of India. There is many awards and recognition is there, National Science, that is Talent Search Scholarship, Government of India, and University Gold Medalist in Biochemistry, and Best Speaker Awards, that is very good regarding Cardiology Society of India of Kolkata Conference, and Chief Federation Examiner MRCP in UK, and Best Speaker of CSI, and from 2006 to 2007. And his education characteristics is MBBS, Deep Cut, MD, MCP from London, FRCP from Edinburgh, and FRCP from London also. So he's a renowned and vast experience, and as well as he's a very good speaker. So many times he's getting the award, best awards as a speaker. So he's now giving us very good lectureship regarding the cardiology. And now start it. Please start.
Good afternoon, everybody, and thank you for giving me this opportunity to be in this conference. Tarok and I have been friends from our MBBS days, and it's nice to see all of us having a chance to interact in this somewhat difficult times. So if you give me the permission, I will start my lecture, and if you allow me to share my slides, please.
Let's go ahead.
So, is my slides visible? Hello?
You see?
Is the
Yeah, it's
slide
visible. Yeah.
Okay.
Visible. Okay. Okay. So I'll make it the large screen. So again, thanks a lot. So some of the slides are from, I must declare that Novartis has done some of the slides, but some of the slides are my own. So what we'll do is to just define what is de novo heart failure in the first few slides. De novo heart failure is acute heart failure in someone who's not known to have cardiac disease. So this is the first presentation, and we'll slowly see how it is a little different from people who've known to have chronic heart failure and then has acutely decompensated. So it's clearly different. These are people who are not known to have heart failure or heart disease initially, but has suddenly presented to you with an acute heart failure decompensation. So this is a little different from people who've already known to have chronic heart disease or heart failure and who have now decompensated suddenly, and that is acute decompensated heart failure, as we all know. And so what it can, how does it cause? Again, the classical causes of heart dysfunction: pump failure. It can be due to reduced perfusion pressure, pulmonary edema, and a high afterload. So this is what we need to clearly differentiate a little bit: de novo heart failure and acute decompensated heart failure. De novo, as the name suggests, means the first presentation of heart failure signs and symptoms and cardiac dysfunction in people who have not known to have cardiac dysfunction. And usually you have a precipitating event, and you have LV diastolic function, and basically pulmonary congestion. This is a little different from people, as I've repeatedly said, from acute decompensated heart failure. These are people who are known to have chronic underlying cardiac dysfunction. And then they have a precipitating event which decompensates them. Are they very different? And we will slowly, this will be the content of my lecture. We will slowly discuss the outlook of de novo heart failure. Is it any different from acute decompensated heart failure in known heart failure patients? And we'll discuss some of the what of the guideline decompensation. Now, in your clinical experience, I think I would suggest that at least 5 out of 10 patients of acute heart failure coming to your unit or coming to you will belong to this category. That is de novo heart failure. They did not have a history of heart failure previously, but has suddenly come to you with a decompensated heart failure. So that is de novo, as the name suggests. So I think the incident would be 5 out of 10. So let's have a case scenario. It's a case scenario. This is typical. A 53-year-old government officer rushed to hospital because she suddenly had difficulty in breathing. And a lot of these people have been treated initially as bronchial asthma because they did not have cardiac admissions or cardiac disease, not known to have. They are often treated as respiratory problems. And especially in the COVID scenario, it's not unlikely that they were even diagnosed as COVID initially. She has had some sort of a history of being short of breath for a while, and it's then suddenly decompensated. And this is what you straight away get. You have a low ejection fraction and more or less an intact renal and function. So this is basically, this lady is what you would call a typical case of de novo heart failure. Now, how are they different? How is the worsening chronic heart failure different epidemiologically from de novo heart failure? De novo heart failure are younger. They are more likely to be of women. They are more likely to have non-ischemic etiology, somewhat lower rates of mortality and readmission, but not ignorable. And that is why we need to take very cognizant. We often disregard this group. We are not very aggressive in this initial treatment. And that is why the entire focus of the lecture is to say that these de novo heart failure patients need to be treated as intensively as people who have come in with worsening heart failure, which are older patients, more of men, more ischemic etiology. And basically, we are often very, very geared in this group, not so much. We often say, okay, this is the first instance, maybe we will actually go a little slow on them. But let us see what is the problem. The problem is this group, this de novo heart failure, unfortunately was not included in most of the major trials of heart failure. Most of the major trials of heart failure, whether that be beta blocker trials, ACE inhibitor trials, ARB trials, included people who have had known to have heart failure. They were not presenting with acute decompensated heart failure. You had to be included in this trial. You had to have some amount of history of heart failure in the past. Is it any different? So let us see what the mortalities are. So if you see the 30-day mortalities in acute de novo heart failure is not very different from people who've had acute decompensated chronic heart failure. So again, no difference. So if you are aggressive, if all the trials, you want to use all the recent medication on this group, Why not this group? And that is the contention, because if you see the 30-day mortality is not very different. And if you follow these patients up 1 year, the mortality increases to 22% if you're not very well treated, and 10-year mortality, nearly actually 2/3 of the patient will not survive. So what is the total with the first presentation? 4.7% people will die in their initial hospitalization. The 6-month mortality is 15.2, and recurrent ICU admission in 1 year will be 55%. So that is very, very high. So what you need to prevent, not only mortality, also recurrent hospitalization. So do we have a lot of data? As I have said, most of the long-term heart failure trial data included people who already had diagnosed heart failure. They were not presenting with heart failure. And if you see that, that the risk of readmission in de novo heart failure, despite the treatment, ACE inhibitor, ARB, aldosterone, and beta blockers, the readmission rate were 10.9% at 30 days and 27% of 6 months. So there's a lot of scope of improvement in this data. So these are people who were de novo heart failure. You had started what we would have called the standard therapy till about 2017. This would be the standard care of therapy for all heart failure patients, an ACE or an ARB, an aldosterone antagonist, and a beta blocker. This is circa 2017 and before. But despite these therapies, you still had a very high rate of rehospitalization of nearly 1/3 of the people came back to the hospital in 6 months' time. So what is the guidelines? What are the guidelines saying about this group of patients, this de novo heart failure, hospitalized de novo heart failure patients? They are obviously hospitalized patients. Should you treat them with ACE-ARB as a what would you do with your the modulator therapy for the renin-angiotensin modulation? Would you use an ARNI or would you use an ACE inhibitor as the initial choice? And let us see what the evidence we have till date. So if you see that acute hospital with acute decompensated heart failure de novo, though we say ACE and ARB is good, we do not have any well-designed trial which tested that, which was introduced absolutely at the initial part of the first presentation of the heart failure. Most of the heart failure trial, the SOLVE study, the SAFE study with ACE inhibitors were people who had chronic heart failure and then went on to treat with an ACE or an ARB. MRA, mineralocorticoid antagonist, yes, there is some data, but not a whole lot of data, that if initially fairly early of the first presentation, 30 to 90 days post-discharge, is associated with a significant benefit. Again, beta blocker again has some evidence that impact heart failure trial, that if you started in hospital with the first episode of heart failure, you did have some benefit. So what about sacubitril and valsartan? That's what we know as ARNI, which is now the neuromodulator rather than a renin-angiotensin inhibitor. It's a modulation. We want to uptitrate the vasodilator's arm or and downregulate the angiotensin arm. So this was what it was in before 2017. So you had a patient who had reduced ejection fraction presenting with you with a reduced heart failure with reduced ejection fraction. The 3 triple therapies, as I have said, would have been introduced, ACE or an ARB, if they are ACE, a beta blocker, and MRA, and you would titrate the dose to the maximum tolerated dose. Then you would reassess the symptoms. If they continue to be asymptomatic, you would continue with the triple therapy. But they were symptomatic, you would consider switching the ACE and ARB to an ARNI for eligible patients. And if they are very, very symptomatic, you could even think of a device therapy. But what it was, this was before 2017, when we had before we had the full data from the more recent heart failure trial. And so basically, what do? We now have two pivotal trials, the Paradigm heart failure trial with ARNI and the DAPA heart failure and the EMPEREG heart failure trial with SGLT2 inhibitors, which clearly showed two things. One, ARNI was better than ACE inhibitor in management of heart failure. It decreased not only mortality, it's reduced hospitalization. And as I will show you, the benefit of ARNI occurred very early after starting the therapy as compared to an ACE inhibitor. So not only does it benefit the patient, it benefits with early use. The curve started diverging within a month of initiating ARNI. Similar story with SGLT2 inhibitor, but that is will be not our discussion today, because that would be an extensive topic then. So where do we put ARNI and SGLT2 inhibitors in our modern armamentarium? This is basically the old armamentarium, which was 2017 and before. So we now have what is called the 4 foundational therapies of heart failure therapy with reduced ejection fraction, and these are called 4 foundational. And if you notice, MRA stays there, beta blocker stays there. We have 2 new kids on the block, ARNI. If you see, ARNI has now been set as a foundational therapy in preference to ACE and an ARB. So this is very important. And an SGLT2 inhibitor is the new thing which has come in. So how do we start the therapy? Does it make a difference? So here was a recent data comparing that if you had what we call a comprehensive therapy, that is ARNI, beta blocker, MRA, SGLT2, as compared to the conventional therapy, which is ACE inhibitor, ARB, beta blocker. So in this conventional therapy, ARNI was not there, SGLT2 therapy was not there. In the comprehensive therapy, however, both ARNI and SGLT2 inhibitors were even. Clearly, the difference is remarkable. If you see, this is the conventional therapy reduction, and this is the steepness of the curve, shows phenomenal actually decrease. If you see the steepness of the curve between the comprehensive therapy, that is with ARNI, as compared to the ACE inhibitor, you clearly the benefit would have been very significant. So in a 55-year-old man, sorry, I'll just go back to the previous slide. In a 55-year-old man, if you introduce comprehensive therapy for acute heart failure from his first presentation, he would improve event-free survival by 8.3 years and overall survival by 6.3 years. This is not against a placebo, but against the conventional therapy. Please remember this. So there is a clear benefit of using what we call comprehensive therapy with ARNI and SGLT2 therapy rather than ACE inhibitor and beta blockers only. So this was the trial, which was, as I have said, the Paradigm heart failure. I put this on to show you where the diversion of the curves occur. The enalapril arm clearly shows increased rates of event, both in mortality and rehospitalization, and the sacubitril arm starting diverging very, very early instead of introducing ARNI. Now, there was initially, after the Paradigm heart failure, a lot of people said, okay, in Paradigm heart failure period, you had a run-in period of 6 weeks before the acute decompensation, after the acute decompensation, before you introduce ARNI. We now have 2 very good trials called Pioneer and a transition trial, which tested the hypothesis that if we introduce ARNI in the hospital instead of an ACE and an ARB, was it not only safe, was it safe? Yes, it was safe. The answer was yes, it was safe. And yes, the benefit of the Paradigm heart failure trial would have been achieved with that. So now we know, we have confidence that ARNI used as the primary molecule for renin-angiotensin pathway modulation would be superior to ACE inhibitors and ARB, even in the acute stages of the heart failure, after maybe the first 24 hours or first 36 hours of initial hospitalization, where you need to improve your basic hemodynamics. So I'm not saying introduce the therapy in the first 24 hours, but definitely prior to discharge. Definitely prior to discharge. So this is a sequence by Packard, suggested by Packard. This is the conventional sequencing therapy, what we used to practice in the past. You used an ACE inhibitor, beta blocker, MRA, and only later would you introduce an ARNI and SGL2. But with, as I said, with the two overwhelming trials, Paradigm heart failure and the DAPA heart failure trial, clearly these two agents have really replaced basically ACE inhibitor, and this is an addition. So the new proposed sequence, that if a patient comes to you with acute decompensated heart failure, maybe the first 24 hours, 36 hours, you would need to stabilize the patient with IV diuretics. Once you have more or less rendered the patient euvolemic, relatively free of oxygen, and is able to shift out of the CCU, your first agent of choice is a beta blocker. Why beta blocker as a first agent of choice? Because beta blocker is the only agent which prevents sudden cardiac death early, because it prevents arrhythmias. ARNI and SGLT2 also prevents arrhythmias to a certain extent, but later in the disease process. The earliest to hit the sudden cardiac arrhythmias, ventricular tachycardia, is beta blocker. So in your step one, you would introduce a low dose beta blocker and either an SGLT2 or an ARNI. This is a tailored choice depending on the renal parameters, the blood pressure. So how would I choose ARNI? If the blood pressure was high, the patient was more or less euvolemic, I would use ARNI, and the renal function was reasonably all right. On the other hand, if the blood pressure was on a little bit on the low side, maybe say 90, 100, the renal function was borderline, I would use an SGLT2 inhibitor. The reason being that the SGLT2 inhibitors are slightly more kinder on the blood pressure. But ARNI would have been an ideal agent, especially if SGLT2 inhibitor has a problem that if you have an ongoing infection, this is not the time to introduce these agents. So a lot of patients with acute decompensated heart failure will have some amount of infection around. So that is how I would do it. So these two modules are interchangeable and it's tailored according to the patient's choice. And what about MRA? MRA comes in as the third step. So this, how soon we do it? Within first 4 weeks. The first 3 steps should be achieved within the first 4 weeks of the presentation of acute heart failure, whether that is de novo or whether that is chronic heart failure. So let us see some of the guidelines recommendation. This was in 2019, where clearly it has shown that initiation of sacubitril and valsartan rather than ACE inhibitor, please sort of take note of this, rather than ACE inhibitor or ARB, may be considered in hospital patients with new onset heart failure. This is the ones we are talking about, de novo heart failure or decompensated heart failure, to reduce the risk. So this again, no need to titrate ACE inhibitor and then switch on to sacubitril and valsartan. There's no need to trial. You can directly use ARNI as actually the preferred choice of agent for your renin-angiotensin modulation, pathway modulation, rather than go on to an ACE inhibitor. And you need not check your NT-proBNP. What about the ACC guidelines? Again, absolutely a similar story. This is the 2021 guidelines, which a direct initiation of ARNI rather than a pre-treatment with an ACE inhibitor on ARB, which we were practicing before 2017, is now being recommended because of that clearly difference in outcomes when these two agents were compared in the paradigm heart failure, and the benefit occurred very, very early. So what is the ideal time to consider introducing this agent? During the hospitalization patient of heart failure with reduced ejection fraction. So you need not be basically complacent. be active in the first presentation of acute heart failure, and it is always easier to introduce this agent. I have felt it much easier to introduce when the patient is recovering in the hospital, where you're monitoring the patient intensively and you introduce this molecule. Should there be a setback in the form of drop in blood pressure or in the deterioration of renal dysfunction, you will pick it up early. So I always try to start it as the patient becomes stable, usually after the 48 hours, when the patient is shifted from the ICU into the ward, but prior to discharge. So this is you're again very similar to the 21 guidelines, which have now clearly shown. Earlier it was a choice, and now it said it should be the first line agent instead of an ACE inhibitor on RD in all heart failure. So patient presenting with either new onset of heart failure, you need not have a trial of ACE inhibitor or an ARB before switching on to RD. You go on to RD directly, and then quickly introduce. Also, never forget to introduce all the other 4 foundational therapy. We call them the 4 foundational: a beta blocker, RNA, SGLT2 inhibitor, and MRA, and that should be within the first month of initiation or diagnosis of heart failure. Why the first month? Because if you do not treat these patients aggressively in the first presentation, as you have seen from my previous slides, that they will come into hospitalization again and again and have an increased mortality. So what about the impact? The impact of de novo hospital. This subset was studied in some of this de novo heart failure. So this is the first presentation of heart failure with reduced ejection fraction group, which showed that there was a significant decrease in composite endpoints of CV death or rehospitalization as compared to enalapril. So mind you, this is an ACE inhibitor. Please never think that there was no medication in this arm. This had enalapril, a classical ACE inhibitor. And if you use RNA, clearly the benefit in this group of early treatment benefited the patient. Again, biomarkers like NT-proBNP and troponin T, which are surrogates of improvements in cardiac functions, were also improved by RNA. So how do we start this therapy? I think with all of us, we need to do what is called a little gently, low and slow is what I would say. So you would start with 50 milligrams twice a day, and every 2 weeks, reassess the patient for their blood pressure, any symptoms of hypotension, any deterioration in renal function, and then move on to 100 milligrams and then 200 milligrams. A 2-weekly gap is what is advised. So this is how we can achieve. A majority of the patient, if you see, will actually tolerate 50 milligrams BD. It is only a very low people who tolerate. However, if the patient was on an ACE inhibitor or an ARB prior to coming into the hospitalization and they had tolerate, you might want, and their pressure is say 130, you might want to straight away start on 100 milligram BID. Does RD prevent us? So early, this is the few adverse event in de novo patient. Whether it's de novo or chronic heart failure patient, basically the side effects or the adverse events were not very, very high with this early introduction of RNA in this group of patients. Did it prevent basically any difference in basically uptitrating? Did it prevent you from uptitrating or introducing the other agents? I don't think so, because if you see this is the MRA randomization and a beta blocker. So it did not prevent, our addition of an RNA did not prevent the uptitration or the introduction of the other foundational therapy, MRA and beta blocker, and even, in my experience, SGLT2 inhibitors. Is there some theoretical way where we can say that this molecule improves cardiac remodeling by inhibition of myocardial cell death and hypertrophy? I think this is more of a laboratory well work. It has been shown that there are some theoretical pathways that the RNA molecule helps to limit cardiac myocyte death or cardiac apoptosis, and improve remodeling. So basically, this is basically a study which showed that there was an improvement in ejection fraction after introduction of RNA in this over a 12-month period. Mind you, in the paradigm heart failure trial, ejection fraction was not studied, but this study showed that even with the ejection fraction, which a lot of us feels very comfortable when we introduce a molecule, we want to see a number often, and that happens with the introduction of RNA. So to conclude, that we know that in de novo heart failure patients, that is people presenting for their first episode of acute decompensated heart failure, people who have not known to have cardiac disease in the past, it is shown that introduction of sacubitril and valsartan or RNA can be early. You need not have a trial of basically ACE inhibitors or an ARB before considering this therapy. And you can actually achieve this in addition to the 4 guidelines. This is not only about RNA. You must hit it in absolutely what we call goal-directed medical therapy, which, let me remind you, is the 4 foundational therapy: RNA, beta blocker, MRA, and an SGLT2 inhibitor. And that should have been done with Mitali within the first month of her arrival in the heart failure, with heart failure. So thank you. I hope I've been able to convey some of the messages of this talk. So stop sharing.
Okay. Thank you, sir. Your very good deliberation of speak and your vast experience is shared with us. And now some questionnaire session. My question is to you, sir. If the patient is on discharge, yes, I am audible to you? I am audible?
Devasis, am I audible?
Yes, you are audible.
Yeah, continue.
Am I audible?
I think you don't.
Yes, you are.
Okay. Okay, sir, my question is, if the patient on discharge, because you already give the drugs, the diuretics is not included in the discharge. Can I, on discharge patient, can I include the diuretics? Another thing is that, what will be the fluid restriction to the patient? When I discharge the patient, there is any fluid restriction to be given to the patient?
A very good question, and actually it involves several parameters. First of all, loop diuretics. We are not talking about MRA. MRA also is a lag diuretic in the corticosteroid antibodies, but we are talking about, I believe you are mentioning loop diuretics.
Loop diuretics.
Now, loop diuretic does not decrease mortality or hospitalization. So it's very, very important to note that. It is a good symptom relieving measure. And yes, you would have to treat with everyone with loop diuretic when they come in with decompensated heart failure in the form of pulmonary congestion or edema. But we need to actually reassess the volume status of the patient on a daily basis and come down to the minimal amount of loop diuretics that is required. I agree with you that most patients at discharge will require some amount of oral diuretics. Discharge may be a furosemide or a torsemide at discharge to a minimal extent. But once the patient becomes euvolemic, especially on the first follow-up visit, you can actually think, if the patient is totally dry, his lung bases are clear, there is no edema, the JVP is not raised, it is a time to actually decrease the diuretics and stop it if the patient is already sick. Because you have to understand, it will help you to introduce these 4 foundational mortality-reducing drugs. If you have a very high dose of diuretics on board, it's often difficult to introduce RNA or ACE inhibitor, whatever you are using, or even an SGLT2 inhibitor. If you remember, SGLT2 inhibitor also has a mild diuretic action. So it is very important to assess your volume status of your patient and keep them on the minimal diuretic levels. And that is actually also the fluid management course. Yes, most of them will have to have some amount of fluid reduction, and usually that depends on the body weight of the patient. Usually I give about 1.2 liters to 1.3 liters as they go home, because if you say 1.2 liters, most people will end up with 1.5 liters. That is what it is very difficult to measure exact quantities of fluid at home. But yes, again, diuretic use has to be tailored. So please understand that diuretic does not improve mortality in patients. So if the patient is wet, yes, you need to have some amount of diuretics on board. On the other hand, you might have a heart failure patient who is now completely dry. And there, you might not need any diuretic at all, because you already have two mild diuretics already in your foundational therapy, which is an MRA and an SGLT2.
Thank you, Dr. Ghosh, for a wonderful presentation. You have highlighted what is de novo heart failure, how it is different from decompensated heart failure, what is the incidence, how should you approach, and what is the sequential management. You have rightly told that it's really fascinating to hear from you. But this simple comment is that guidelines are guidelines. You are the best judge. You look at the patient, look at the pulse rate, look at the volume, or look at the pressure, and take decision how the patient is going to be managed. And GDMT is definitely you should follow the GDMT, but you are the best judge. Is there any other questions? If it not, then I close the session. Thank you very much. If there are any questions, please put it in the chat box. Thank you very much.
Thank you for giving me the opportunity to interact.
Thank you.
Thank you, Dr. Debashish Ghosh, for such an excellent deliberation and be here with us. Next speaker on the line is Dr. Gaurav Bhaduri. He will be speaking about early diabetes management, RSSDI, ESI consensus. To chair this session of diabetes, I would request Dr. B.D. Chatterjee to please come over in the dais and chair the session.
Good afternoon. So our next speaker is Dr. Gaurav Bhaduri, who is a consultant in the Department of Diabetes and Endocrinology, Medicare Super Specialty Hospital and Apollo Sugar, Kolkata. He is a member of AAC RSSDI API, author of the API Medicine Update, and faculty in various regional and national conferences. So I am requesting Dr. Bhaduri to start his lecture.
Thank you, sir, for the very kind introduction. Just allow me to share my screen. I hope the screen is clearly visible and I'm audible too, sir.
Yes, you are audible.
Yeah, thank you, thank you. So my topic today is early initiation of combination therapy, the key to better diabetes management. And I thank you all for joining me today on this. So the table of contents that I will talk about is introduction. I will give you a brief introduction regarding the topic that I will talk about. Then we'll talk about patient-centric approach and how it is different from the glucose-centric approach. Then we'll talk about treatment initiation with metformin, and then about the dual or the combination therapy approach. And finally, we'll go into the individualized therapy consideration as per as the RSSDI 2020 consensus, and then we'll finish it off with the summary. Now, the paradigm shift in diabetes management has happened, and this is what has happened is that one size fits all approach has gone into the individualized approach. And this is very, very important and this is a structural change that has happened in the management of type 2 diabetes. Now, the goal of individualized approach to diabetes management is to improve the glycemic control while minimizing the hypoglycemic risk, the weight gain, and reducing the risk of diabetic complications. And the first step of diabetes management is to set a HbA1c target level. This we all must be doing in our clinics, setting a HbA1c goal for the patient we are about to treat. Now, the glycemic targets for Indian patients with type 2 diabetes, as recommended by the RSSDI 2020, if you look at the data from here, what we see that the fasting plasma glucose, they're recommending in between 100 to 125, the 2-hour postprandial glucose in between 140 to 199, and HbA1c in between the range of 5.7 to 6.4. Again, this is a rough recommendation, but cannot be followed for all of our patients, but we can target for a certain number of patients to achieve a very tight control of sugar. Now, the patient-centric approach and the evidence-based approach for Indians with type 2 diabetes is where it all comes to. So type 2 diabetes therapy should target factors beyond the glycemic control. It should focus on the hypoglycemic risk of the patient, the quality of life, the weight management issues, the glycemic efficacy and the safety profiles, the comorbidities that the patient is having, and the cardiovascular risk of the patient. So all this assessment is must before we go on to treat diabetes of a patient. And an individualized patient-centric and evidence-based approach takes into account all the metabolic derailments that accompany along with type 2 diabetes. The problem is of plenty with the currently available anti-diabetic therapies. So currently 12 available classes of anti-diabetic therapies available, significantly beneficial for our patients because we have more options now, but HCPs need to be vigilant and knowledgeable about the advantages and disadvantages of every type of therapy is there. So the classical approach has been to initiate with metformin. So on diagnosis, monotherapy with metformin and comprehensive lifestyle management has been recommended by most of the associations. So metformin has indeed a proven beneficial effect in terms of HbA1c reduction, weight neutrality, and cardiovascular mortality reduction. So there has been a paper from Khan et al. In Diabetes Care 2016 suggesting initial combination therapy to be considered in patients with HbA1c who present with HbA1c of more than 7.5%. Though there can be a little bit of discussion more as I will go for whom or early dual combination therapy can be, we can target. But why at all should we consider early combination therapy? So this is because tight glycemic control has been shown to reduce the risk of complication, yet this is not easily achieved, or even if it achieved, it is sometimes not maintained. So if you look at the Wikipedia's data showing the percentage of patients who maintained a HbA1c of 7% even after 9 years, so what we find is those patients on monotherapy plus diet had a success rate of only 9%. So to insulin, only 28% of the patients, and sulfonylurea, 24% of the patients. So there is some deficiency over here, what we look at, and especially with monotherapy along with diet. So early initiation of combination therapy has been proposed as an approach to delay the deterioration of glycemic control, which eventually happens in all the patients of type 2 diabetes, and increase possibility of beta cell function preservation as much as we can. Now, if you look at Indian patients on metformin monotherapy, they tend to fail early. And this data is from the Indian patients in the famous verified trial. So if you look at the median time to failure, so with the initial monotherapy group versus the combination therapy group, what we find is the initial monotherapy, the median time to failure was 1.5 years versus in the early combination therapy group, it was 4.75 years. So 50% of the patients failed metformin at 1.5 years versus 4.75 years for the early combination group. So Indian patients on monotherapy tend to fail earlier than the global verified population. And this is again very, very worrisome because not only what we saw is the initial monotherapy having a tendency to fail much more and much earlier than the early combination therapy, If we compare this patient population data with the global verified data, then what we find is that the global verified population in the initial monotherapy group, the median time to failure was 3 years versus 1.5 years for Indian patients. So a dual therapy is something where we can think about initiating in patients for giving a patient a much longer course of sustainable action. But the challenge is of choices. So if you look at the ADA guideline, it suggests that dual therapy must be initiated if HbA1c is more than equal to 1.5% above the target. So if HbA1c target, again, if not achieved by the monotherapy after 3 months, you can again go ahead with the dual therapy. The 4 oral combinations with metformin, currently we'll say it is 5 because we have the along with the sulfonylurea, the glitazones, the P4 inhibitor, and the SGLT2 inhibitor, we also have now the oral GLP-1 receptor agonist as an option with us. The SU plus metformin, obviously the most commonly used OAD combination after an initial metformin failure. It is a cost-effective therapeutic strategy used worldwide for achieving target glycemic control after the initial metformin monotherapy failure. This is quite popular, widely popular. But there are certain concerns regarding the use of sulfonylurea. Now, sulfonylurea as a metformin, as a monotherapy, can initially control blood glucose levels. There is no doubt regarding that. But subsequently, it becomes more ineffective and must be replaced or added to with insulin. So there is a risk for the secondary failure. There is a question regarding the durability of the molecule, and with the older generation sulfonylureas, there is blunting of the ischemic preconditioning. Weight gain is also an issue with sulfonylureas. Hypoglycemia risk is again there, though it is much lower with the modern sulfonylureas that we have, but still it is significantly there, it persists. And with the older generation sulfonylureas, the mortality risk is again there. So we must be thinking about the individualized therapy consideration and a step-by-step thought process for treatment initiation as recommended by the RSSDI 2020. This help you in structuring the approaching a patient in a very structured manner. So RSSDI ESI 2020 recommendations for individualized therapy approach. For here, patients who have been diagnosed with diabetes consider a combination of metformin and an appropriate add-on based on the ABCDEFGH approach. What is this approach? We'll learn later, but treatment goals reducing the blood glucose levels while minimizing the side effects, especially hypoglycemia and weight gain. Now, using the ABCDEFG approach to make an optimal treatment choice: A for age, B for BMI, C for chronic kidney disease, D for duration of diabetes, E for established cardiovascular disease, F for financial condition, G for glycemic status, and H for hypoglycemia concern. So other consideration for drug choices should also include the patient preference. This is again a very, very important one. We need to discuss the pros and cons of the medication with the patient and also take into account the patient feedback. Presence of various comorbidities and complication and the drug characteristics. Now coming to age, A for age, and we must remember that the different classes have got different kind of action at different age groups. So if you look at DPP4 inhibitor, it is suitable for all age groups, including the elderly greater than 65 years of age, avoids the risk of hypoglycemia and weight gain, and those may need to be adjusted in case of severe renal impairment, which can sometimes accompany with age. Now, with the glitazones and sulfonylureas, if you have a look, then with glitazones, it is restricted in the elderly, mostly because of complications like weight gain, fluid retention, peripheral edema, aggravation of congestive heart failure, and osteoporosis. Gliclazide and low-dose glimepiride from sulfonylurea can be safely used in elderly, but it has to be used very judiciously to minimize the risk of hypoglycemia, which still persists even with lower doses of gliclazide or glimepiride. SGLT2 inhibitor is suitable for all ages, reduces the cardiovascular risk, but increased risk of genital mycotic infection and urine tract infection, hypovolemia, postural hypotension, and weight loss may limit their use in the elderly. So we need to be cautious while using this molecule in the elderly population. Now, if you look at vildagliptin, which was effective and well tolerated in type 2 diabetic patients of all age groups. So this is on the left-hand side, you can see the data of age greater than 75 and age less than 75 and comparison of HbA1c and fasting plasma glucose when vildagliptin as an add-on to metformin. The improvement in adjusted mean change in HbA1c with vildagliptin was with no confirmed hypoglycemic event. So this is again encouraging. And on the right-hand side, you can see that the Indian subset of the verified study, the young onset diabetes patient of less than 40 years. So the early combination therapy significantly reduced the risk of time to initial treatment failure, even for the young onset diabetes. So either in the, whether it is in the young onset diabetes or it is for those patients who are aged even more than 75 years, vildagliptin metformin combination tend to perform very well. If we look at the body mass index, so the varocentric models helps to choose appropriate glucose lowering therapy based on BMI, and this has also been advocated by the American Diabetic Association guidelines if you look at them also. So what they are saying is if the patient is underweight, focus should be on the lifestyle management, and drugs like pioglitazone can be a good option in those categories. For normal weight patients, it is very important to use medications which are weight neutral. So focus obviously on the lifestyle management must be there so the patient doesn't gain any extra weight, but DPP-4 inhibitor is a very weight neutral agent. Then we have the model sulfonylureas like glimepiride and glyphoside modified release, which causes very less of weight gain or maybe even weight neutral. So, and the glinides can also be considered. Even in the overweight category, there should be extremely high focus on the lifestyle management. And as far as medications are concerned, SGLT2 inhibitors and GLP-1 receptor agonist, because now orally also it is available, so that can also be considered. Now, vildagliptin plus metformin led to relative weight loss as compared to weight gain with sulfonylurea plus metformin. This is a study by Ferrani et al. And if you look at the duration is 52 weeks, so quite a long duration study as an add-on to metformin with vildagliptin versus glimepiride. On the left-hand side, you can see clearly that the vildagliptin 50 mg BID plus metformin versus glimepiride up to 6 mg once a day plus metformin. The in-between treatment difference is quite huge. So vildagliptin showed relative weight loss compared to weight gain with glimepiride at 52 weeks study. Now, if you look at the chronic kidney disease aspect, so we have discussed about age, we have discussed about BMI, now we are going to the point C of chronic kidney disease. Now, again, here the choices are based on many different factors. So I will not be able to cover because of paucity of time of all the medication, but let us have a little bit of look around the second generation SU. So if you look at the gliclazide up to GFR 30, no dose adjustment is required, less than 30 low dose preferred. If you look at glimepiride, again, very widely used, GFR less than 60, use should be with caution, and less than 30 it is preferred. It is better to avoid the use of glimepiride. So very, very low dose glimepiride can be used up to 30, but it's preferred not to use it below 30. With glitazone, there is no dose adjustment required, but we have to remember that there is the issue of fluid retention with glitazone. So at advanced, CKD cases of stage 3 and stage 4 and stage 5 onward, there is a high chance of fluid retention and development of cardiorenal syndromes from where the glitazones can precipitate a congestive heart failure. So we need to be a little cautious while using glitazone in those cases. For DPP-4 inhibitor like linagliptin, there is no requirement of any dose adjustment. For gliptins like sitagliptin and vildagliptin, there is a requirement for adjustment of dose according to the GFR. If we go at 1 year vildagliptin therapy showing clinically significant reduction in HbA1c level in patients with moderate and severe renal impairment. So here is a study on the left-hand side. You can see results for patients with moderate renal impairment And on the right-hand side, you can see the result for severe renal impairment. So you can clearly see that the efficacy of the molecule is being preserved whether the patient is in the moderate renal impairment or the patient is in severe renal impairment. Now, another very important, factor which makes our decision of, molecules we use for the treatment of diabetes very crucial is diabetes duration. So patients with long-standing type 2 diabetes are difficult to treat and attributed to the reduced beta cell function and addition of many comorbidities along the journey of diabetes. So the incretin-based therapies and SGLT2 inhibitors have the ability to lower HbA1c level and have significantly lower risk of hypoglycemia as compared to insulin. So some of these molecules like the SGLT2 and the DPP4, they tend to work even when the patient is having a very long-standing diabetes, and especially when you're using insulin along with that. So vildagliptin demonstrated less dependency on the duration of type 2 diabetes. And here we can see a one-year observational age study by Brack H. et al. And there is the dotted line is representing sulfonylurea and the straight line is representing vildagliptin. So 5 times lower rate of loss of function for every year with vildagliptin compared to sulfonylurea. Again, a very, very encouraging result for vildagliptin as compared to sulfonylurea in the H study. Coming to the established cardiovascular disease, intensive glycemic control can reduce severe risk and microvascular complications in patients with type 2 diabetes. And we all know that the American Diabetic Association and many other associations are now focusing more and more on the established cardiovascular disease component while making a treatment decision choice. So the CV safety of the molecule is again very important, and DP4 inhibitor is preferred over conventional use in patients with increased risk of cardiovascular disease or established CVD. For glitazones, we know it is contraindicated in patients with subclinical heart failure or patients with low ejection fraction. SGLT2 inhibitor again is suitable for patients with cardiovascular disease. If we look at DP4 inhibitor like vildagliptin to reduce the risk of hospitalization for CVD compared to sulfonylurea, so this is a retrospective cohort study of DP4 inhibitor versus glimepiride. Now, DP4 inhibitor did not increase cardiovascular risk compared with glimepiride, regardless of the history of CVD, diabetes duration, or even treatment duration. So 13% decrease in the risk of hospitalization for CVD with DP4 inhibitor compared to glimepiride. F, coming to the financial concern, high cost burden on Indian patients is there. There is a direct cost, that there are indirect costs. So most patients do not have medical insurance over here, and treatment needs to be continued for life, and patient pays out of pocket. So ACUs are a cost-effective option in the short term. DPE4 inhibitor or SGLT2 inhibitor can be considered when sulfonylurea plus metformin does not achieve desired HbA1c outcomes. And given the current situation, because there has been a significant reduction in the treatment cost with DPE4 inhibitor, DPE4 inhibitor has now become even more attractive than ever before. And coming to the glycemic status, we look at the glycemic control of various agents as an add-on to metformin. So individual agents, we do not expect more than 1% of HbA1c drop. So sulfonylureas is around 0.5 to 1, glitazones around 1 to 1.2, DP4 inhibitors 0.5 to 0.8, and SGLT2 inhibitors of 0.5 to 0.9. Now, here is a study showing the effect of HbA1c, vildagliptin plus metformin versus sulfonylurea plus metformin at 3 months and at 1 year. So comparison of reduction of HbA1c at 3 months. So in both the groups, similar reduction in HbA1c from baseline was seen at 3 months. So whether you're using a glimepiride plus metformin or a vildagliptin plus metformin, expect a similar degree of HbA1c change from baseline when measured at 3 months. Another very important concern is the hypoglycemic concern, which is the last of us all. And the hypoglycemia, an important limiting factor while deciding therapy for type 2 diabetes. Sulfonylurea and insulin have the highest risk of hypoglycemia events compared to other agents. So we can clearly see that in the risk of sulfonylurea being much higher than the glitazone or DPE4 inhibitor. So for patients who are at very high risk of hypoglycemia, consider SGLT2 inhibitor or a DPP4 inhibitor or a GLP-1 as the first choice add-on to metformin. And this is a study showing the relative risk of hypoglycemia of vildagliptin versus glimepiride. So there is a 14-fold higher hypoglycemic event risk with glimepiride compared to vildagliptin. This is the RSSDI ESI therapeutic wheel with the lifestyle management and metformin at the center. And then we're talking about this ABCDEFGH approach. And then we have the green zone where you can use all the medications. And then from there to yellow to red, you go into the outer cycle, which is the red zone. And in the middle, you have the yellow zone. And then you need to follow the hierarchical order in terms of a clockwise manner. The implementation of the RSSDI ESI therapeutic wheel in clinical practice. So the impact of type 2 diabetes management has substantial effect on the individual health, psychological well-being, economic repercussions, societal health, and the quality of life. Type 2 diabetes treatment is not a one-size-fits-all approach, and it needs to be individualized considering the individual patient preferences, needs, values, and reducing impact of negative long-term outcomes. Use of the RSSDI ESI therapeutic wheel can help clinicians individualize treatment strategies for their type 2 diabetic patients. To conclude, we must be asking ourselves a few very important questions that the questions to consider in choosing early combination therapy or sequential titration of individual agents. Would there be a delay in deterioration of glycemic control, better durability, or better beta cell function over the time? Does the approach that I'm using address the pathophysiology better? Does it allow for assessing the individual response? Are the costs appropriate? Now, would this approach result in cost saving and reduction in complication over a longer duration of time? Is the risk-benefit ratio acceptable? Would it improve unmet clinical needs such as weight gain and hypoglycemia? Would adherence and compliance remain issues, or is it due to our clinical inertia? And in summary, I would like to state that early initiation of combination therapy has been proposed as an approach to achieve glycemic goals earlier and delay the deterioration of glycemic control, and with a possible better preservation of beta cell function. The RSSDI 2020 proposes a patient-centric approach to guide the pharmacological choices, and one size does not fit all. And considerations include a ABCDEFGH approach to help reduce the clinical inertia while providing the patient with the best possible choice for a dual therapy. Vildagliptin plus metformin used as an early combination is effective and safe, keeping in mind every aspect of the ABCDEFGH approach as compared to sulfonylurea and metformin. And we have seen that data in the form of verified trial. The RSSDI ESI proposed therapeutic wheel can serve as a real-world approach, providing care that is responsive to individual specific unique needs, preferences, and values, and also help to combat negative long-term outcomes. Thank you for your patient listening. I am ready for any questions that you might have.
Dr. Bhaduri, for your nice and elaborate deliberation. Now I am asking one or two questions from the floor.
Thanks.
Hey, এটা.
Thanks, Dr. Bhaduri, for your good deliberation. My question is because as a practitioner, I am getting some patient when on vildagliptin coming with the increased pancreatic enzyme level. Sometimes patients come with pain abdomen, and when I going through that, the enzyme level is high. Probably patient does not have any hypothyroid, it's not as a comorbidity, or he's not a any polylithiasis. Still, some patient is coming with liver enzyme raised as well as pancreatic enzyme is raised. When I stop the drug, patient reverse the situation. If you have any experience regarding that, can you share with us?
Yes. So what I will suggest is that whenever we are using So whenever we are using DP4 inhibitor, there is a responsive slight increase in the amylase lipase level, but it is not to the extent of more than 3 times of the upper limit of normal of the amylase lipase to at least classify it as a case of pancreatitis. If we find that, then obviously there we need to evaluate further and dig deeper. Regarding the liver enzymes, so again, it is if we need to check the liver enzymes even before starting of vildagliptin. So if it is already raised more than 3 times, we need to go into a more detailed evaluation why the liver enzymes are raised. And at that point of time, we should avoid using this particular molecule. We should hold ourselves. But most of the times, the liver enzymes at the very baseline are a little bit elevated because the patient may be already having a non-alcoholic fatty liver disease. And because of that, the AST/ALT levels might be a little bit raised. For those patients, if you are using medications like vildagliptin, it is usually quite safe, but we need to keep on monitoring so that it doesn't get even higher and cross the threshold. But upon a resolution of the type 2 diabetes and with the implementation of lifestyle changes, most of these patients can achieve a reduction in the AST/ALT level over a period of time. But obviously, we need to screen the patient for as simple few things like hepatitis B surface antigen and anti-HCV antibody. So these basic things we can carry forward and can assess and take our call based on that.
Thank you.
Thank you. Any more question from the audience?
Hi, Dr. Bhaduri. Thank you very much for your nice deliberation. I have one question. The metformin, with metformin as an add-on therapy, vildagliptin is okay. But is it superior to other gliptins like sitagliptin or linagliptin or even this cheaper teneligliptin? Should it have any special preference for this molecule, vildagliptin?
Yeah. So, data, as far as data is concerned, as far as efficacy if you're talking about, so all these molecules are having a very similar efficacy. So from the efficacy point of view, there is not much difference in between a vildagliptin and a sitagliptin and a linagliptin. Regarding, because vildagliptin, they did not market in the United States of America, they did not need to go ahead and do a cardiovascular outcome trial. So that data is not there with us, but we have enough other data from the, because it's being marketed in the European Union. So we have enough data from there to suggest that it is quite safe as well. However, for teneligliptin, I would not put that molecule in the same league of vildagliptin, sitagliptin, or linagliptin that you mentioned, because there are certain other concerns and much limited data with teneligliptin compared to these 3 other molecules which are used widely and have been in use for a longer duration of time with more data available with us.
Thank you, Dr. Bhaduri. Just one more question from the audience.
Yeah, Dr. Bhaduri, thank you for your wonderful presentation. I've got one question regarding that pancreas, increase in the enzyme of the pancreas. Will you reintroduce the gliptins? It comes back to the normal. The patient is asymptomatic. You accidentally found that there is some elevation in the enzymes. Number one question. Number two is, what is your take on once daily vildagliptin? There are a lot of companies are coming with this once daily vildagliptin. What is your opinion regarding this?
Yes. So, regarding the elevation in the enzymes, as I told you, that if the patient is asymptomatic, and if the enzymes level are not in that range where we can call we can state that the patient has gone into the zone of pancreatitis. So, if that is the case, after a certain period of use, usually most of these levels come down automatically. We did not need to withdraw the use of any gliptin at that point of time. So if the patient is a known case of recurrent pancreatitis and there is no obvious cause like a gallstone or a history of alcohol, so for those patients, we avoid a DP4 inhibitor from the very start. So for these patients, we need not withdraw, and if by chance somebody has withdrawn, they can very well reintroduce a DP4 inhibitor and can continue the patient on it. What was the second question?
Once daily dose.
Once daily dose.
Yes, once daily dosing. So yes, studies have come out that once they have tried this molecule with a crossover trial of 50 milligram twice a day. Patients, one group of patients were given, one group was given 100, and then they did a crossover. The patients who were receiving 50 twice a day was given 100, and the patients who were receiving 100 were now given 50 milligram twice a day. So it was from the efficacy point again, it was similar. There is one data I found regarding the liver enzyme elevation, which was a concern, because I was personally concerned regarding this, because the 100 immediate release had an issue with the hepatic liver enzyme elevation, hepatotoxicity. Because of that, vildagliptin was launched in 50 milligram BD dosing, not 100 milligram OD. But with the sustained release formulation, this again, the AST/ALT levels were not elevated in the study. So I am into building my opinion regarding this on a longer term basis still. So I am using it currently for a very selected of patients, and I am following them for their liver enzymes and other parameters of concern. Till now, the data has, from my side, I have not published it yet. So, but what I can say, because I use an electronic medical record system, so what I can see from a preliminary basis, it is safe. And it is effective. There is no doubt regarding that previously. Regarding the safety issue, I have not yet found any problem specifically regarding, I'm focusing there more regarding the liver enzyme elevation. I'm not finding any such as of now.
Thank you, Dr. Bhaduri.
Most of the studies have shown that twice a dose will cover this SGLT2 inhibition nearly 80 to 90% in diurnal, 24 hours. But if it is used for once daily formulation, I think that this SGLT inhibition is much less. When at the end of the day, at the end of 24 hours, maybe less. What is your opinion on this formulation?
No, on the crossover study, what they have done, they have shown that the DPP4 inhibition remains as good as the 50 milligram twice a day. So there is data based very clearly showing that there is no difference in between that.
Thank you so much.
As there are no more questions, I am closing the session, and thank you, Dr. Bhaduri again.
Sir, actually one request to the audience, there is always a live chat box. This program goes live in the internet, so you can always type your question and all speakers will be happy to answer. Thank you, Dr. Bhaduri.
Thank you.
Thank you. Thank you. Thank you, sir.
So, our next speaker is Dr. Dipankar Ghosh-Dastidar, and interventional cardiologist. His topic is proof of concept of SGLT2 inhibitor in heart failure beyond diabetes. And for this session, I will invite our senior physician member, our mentor, Dr. Tushar Kanti Botobal, to please chair this session. With him, Dr. Arnab Banerjee, our organizing secretary, will co-chair this session. Please come to the dais, sir.
Good afternoon once again. We have respected Dr. Dipankar Ghosh-Dastidar, interventional cardiologist, working presently at Onamoy, Department of Cardiology, Onamoy Hospital, Bardhaman Medical College. Having done DM Cardiology from IPGMR, Kolkata, worked in several hospitals including SSKM, Calcutta Medical College, as a teacher, clinician, and interventional cardiologist. Dr. Ghosh-Dastidar has several publications and been awarded FESC, FSCC, FICP, and FCSI. Dr. Dastidar keenly participates in the national and state conferences as speaker and has been conducting the quiz program at CSI Update, West Bengal annually. He was the scientific chairman of the recently concluded CSI Update Program 2019 at Kolkata. Currently, he is the executive member of West Bengal CSI branch and assistant secretary of Central CSI Committee, and conducted the National WIS program at CSI Hyderabad in 2021. His skill in angioplasty, radial approach angiography, cardiac catheterization, balloon mitral valvoplasty, cardiac arrhythmia, atherosclerotic heart disease, and cardiosclerosis is there. So Dr. Ghosh Dastidar, we are thankful that you are here. Listening you will be our privilege. Please, sir.
Thank you. Good evening, everyone, and thank you for all those kind words. And I must thank the Association of Bardhaman Cardiologists and Diabetologists for having me here. So today we will be talking on SGLT2 inhibitors in heart failure beyond diabetes. That is the role of SGLT2 inhibitors in non-diabetics with heart failure. So this is empowering the spectrum of heart failure. Now these are the outlines that I will be discussing. First we'll be challenging the proof of concept, then we'll talk something about the clinical evidence and initiation in stabilized acute heart failure and optimization of the place in heart failure therapy. So as you are quite aware that empagliflozin induces modest glucosuria in people without type 2 diabetes. Now one mechanism of action of empagliflozin in diabetes is glycosuria. Now we can see that in patients who have got type 2 diabetes as well as without type 2 diabetes, the excretion of glucose, urinary glucose amongst the ones without type 2 diabetes is minimal. So this 40 to 50 gram of glucose loss that occurs in 24 hours in people without diabetes, and this modest glycosuria does not predispose to hypoglycemia. So there may be a question that we are using an anti-diabetic agent in patients without diabetes. So does that cause hypoglycemia? So this modest glycosuria does not cause hypoglycemic events. In people without type 2 diabetes, empagliflozin does not significantly affect fasting and the postprandial blood glucose levels also. So this is clearly seen that in normal persons, the fasting plasma glucose and the postprandial blood plasma glucose does not change very much with use of empagliflozin. And most of these trials have used empagliflozin in the dosage of 10 milligram. The proof of concept. Now effects of SGLT2 inhibition on the pathophysiology of heart failure. Now it works in all these different steps. It reduces the preloads, its effects are on their myocardium, and it also reduces the afterload. Now preload reduction is by increasing diuresis, causing free water clearance and decreasing in the stressed blood volume. Now what do we mean by stressed blood volume? It is the amount of blood volume which causes stretch in the vascular wall. So this is the stressed blood volume and it reduces that. It reduces the pulmonary vascular pressures and the renal pressures also. The interglomerular pressures are also reduced. So the renal dysfunction which accompanies heart failure creeps in slowly with use of SGLT2 inhibitors. It's more delayed. Now effect on myocardium. It increases metabolic efficiency, helps in diastolic relaxation. You know, there is increased amount of fibrosis in the heart with aging which causes diastolic dysfunction. So this molecule reduces that also. And the demand supply mismatch is prevented, reduces LV hypertrophy and reduces remodeling and fibrosis. As an afterload reducing mechanisms, it improves the endothelial function, reduces vascular stiffness. You know, in elderly we have got atherosclerosis by which you get very high pulse pressure, that is high systolic pressure and low diastolic blood pressure, all because of increased vascular stiffness, and that is reduced by this molecule. And also it modulates neurohormonal stimulation as well as the increased derangement in autonomic imbalance is prevented. So empagliflozin reduces stressed blood volume in patients with heart failure with reduced ejection fraction, and this is clearly shown in the EMPIRE heart failure study. You can see there are two mechanisms now we are talking. We are talking about the total blood volume and the blood volume that causes a stretch in the vessel wall. That it is around a normal healthy individual, it is around 20 to 30% of the total blood volume. So that stretched blood volume is reduced and as a result of which all the deleterious effect in the cardiovascular system, you can see there is 8.8% reduction in the stress blood volume, and there is 3-fold greater loss in the stress versus total volume, and the pulmonary capillary wedge pressure is also reduced. So you will have less dyspnea in these patients. Now, empagliflozin directly improves diastolic function in human heart failure. You can clearly see in the graphs, with use of EMPA, the amount of fibrosis is quite less, and it directly enhances phosphorylation of the myofilament, particularly titin, myosin binding protein C, and TROP-I. So these effects reduce the diastolic dysfunction. Now, empagliflozin improves cardiac structure and function in patients with heart failure reduced ejection fraction, as shown in this EMPA tropism study. It improves both the LV end systolic volume index and the end diastolic volume index. Basically, in a dilated heart, we have a high end systolic volume index, meaning by which even after systole, not all the blood has been pumped out. And the end diastolic volume index tends to be compromised also. So you can see with use of SGLT2 inhibitors, particularly empagliflozin, there is significant change as compared to placebo in both these indexes. Also, another marker of diastolic dysfunction is the LA volume. In echocardiography, we often get large size LA in patients with diastolic dysfunction. Now, that LA volume is also reduced with use of empagliflozin. So overall, the diastolic function is improved. And mind you, this is possibly the only drug that has recently been approved to have significant benefit in heart failure with preserved ejection fraction. So long we have got lot of molecules in heart failure with reduced ejection fraction, but with heart failure with preserved ejection fraction, that is the EF above 50%, and patients coming with heart failure, which compromises almost 50% cases of heart failure. And most of the cases in our day-to-day life, patients coming with dyspnea, doing an echocardiography, and in echocardiography, the ejection fraction is coming out to be normal, to the tune of 70–75%. But the patient is in heart failure. If you just do NT-proBNP in these patients, you will find very high elevated NT-proBNP levels. Possibly these patients also have got left ventricular hypertrophy. These patients are hypertensive. Maybe they have diabetes as comorbidities, or they might have renal impairment. Now, the diastolic parameters, if you look at the echo, you will have diastolic dysfunction, grade 1, grade 2, whatever. You can even have a grade 3 diastolic dysfunction like restricting filling pattern in the mitral level. And you have large size LA. There may be biatrial enlargement also. So all these parameters are improved by SGLT2 inhibitor. So this is one subset of heart failure which comprises 50% of our study population, that is heart failure with preserved ejection fraction. Till date, no molecule has been shown to be significantly beneficial in heart failure in preserved ejection fraction. Neither AC inhibitors, we tried a lot with ARBs, we tried a lot with beta blockers. Only comorbidity management so far has been advocated in this subgroup of patients. Possibly this is the first time the US FDA has already approved empagliflozin in patients with heart failure with preserved ejection fraction. So now, ladies and gentlemen, you can use empagliflozin in patients irrespective of the ejection fraction. And this is a great thing coming up in 2021 and 2022. Now, empagliflozin improves cardiac function in patients with heart failure reduced ejection fraction. You can see this is the left ventricular ejection fraction as monitored by magnetic resonance imaging, and you can also see the oxygen consumption. So both of these parameters are improved with use of empagliflozin. Now, we have these three indexes also, like LV mass index. Now, left ventricular hypertrophy is directly correlated with LV mass index. So that is quite reduced with use of empagliflozin. Then you have, this is a very new parameter coming up, the extracellular volume fraction. Mainly this index, it justifies the amount of fibrosis in the myocardium. It is not very difficult to detect. Nowadays, apart from echocardiography, a very important investigation tool is coming up, cardiac MRI. I would recommend you to, whenever you are coming with multiple PVC in the ECG, or patient complaining of dyspnea, and the echo report is coming normal, please do suggest cardiac MRI. Because MRI can pick up a lot of things in the heart. It can pick up the amount of fibrosis in the heart. It is a prognostic marker. It can tell you about the arrhythmias. Now this extracellular volume fraction, which actually denotes the amount of fibrosis, it can be easily picked out by cardiac MRI T1 phase contrast study. Another important index I would like to talk about is sphericity index. I mean, how much globular is the heart? Now, a lot of time we have confusion between acute anterior wall MI vis-a-vis Takotsubo syndrome. Both come with regional wall motion abnormality, mainly involving the apical portion of the heart. Now, as you are quite aware, Takotsubo is a emotional disorder, mainly affecting the elderly female population. Mimics, the ECG changes mimics MI absolutely. And the echo will also show you wall motion abnormality, but if you do the angiography in this patient, all the coronary vessels come out to be normal. This is the main differentiating point between anterior wall MI vis-a-vis Takotsubo. The prognosis of Takotsubo is more or less is a lot better than MI, I would say, because it's majority of the time it's a reversible disorder. And with time, the wall motion after 3 months or something like that, the wall motion comes back to normal. Now this sphericity index is one mechanism by echocardiography by which you can clearly differentiate between Takotsubo and anterior wall. The sphericity index in Takotsubo is a lot higher than in anterior wall MI. So these are useful echo parameters that are now coming up, and these are new things. Next, I would like to talk about the clinical evidence in patients with chronic reduced heart failure or mid-range heart failure and in preserved ejection fraction. Now, this is the Emperor reduced study, and from the morning you have been listening the role of SGLT2 inhibitors in patients with reduced ejection fraction, that is the less than 40% ejection fraction. Now we classify heart failure in 3 groups. One is less than 40%, one is the mid-range group between 40 to 50, and one with the preserved ejection fraction, more than 50%. Now it's clearly documented that SGLT2 inhibitors are one of the drugs of choice, or one of the pillar molecules, foundation molecules in the management of heart failure with reduced ejection fraction. So the dosage here is mainly 10 milligram once daily, but if you want additional blood sugar control, you can use 25 milligram dosage also. But the trials mainly have been done with 10 milligram dosage. And in non-diabetics, you can easily prescribe a 10 milligram dosage of SGLT2 inhibitors. The benefit of using early SGLT2 inhibitor vis-a-vis using ARNI is that you can use SGLT2 inhibitors in renal dysfunction patients also, up to certain level. You can't use ARNI. You can't use ARNI where you are getting hyperkalemia. You can use SGLT2 inhibitors in those subgroup also. And moreover, the combination of beta blockers with SGLT2 inhibitors has been found to be superior than using early ARNI. So now there is a proposed hypothesis coming up that the first drug you want to add after beta blocker may be an SGLT2 inhibitor. So we have to wait about what the guidelines are about to say. But early initiation of SGLT2 inhibitors in heart failure with reduced ejection fraction is of immense benefit. So you can see these are comparisons with placebo. I would love to see one comparison with ARNI if possible in future. But with placebo, you can see all the beneficial effects are there with use of SGLT2 inhibitors in heart failure with reduced ejection fraction. So it improves cardiovascular death, heart failure, hospitalization reduces. So irrespective of the age, sex, ARNI use or MRA, that is mineralocorticoid receptor antagonist use. So all these data favors use of empagliflozin. Now, among safety, you can see it does not cause any severe hypoglycemic events. So the issue of genital tract infection, that can be controlled itself by proper hygiene. You can teach your patients proper hygiene, and it is not a sinister problem as compared to the benefits one can get by using SGLT2 inhibitors in heart failure. So even renal derangement, you know, the intraglomerular pressure is reduced by use of SGLT2 inhibitors. So there is a profound benefit of using SGLT2 inhibitors early in heart failure, because you know cardiorenal syndromes and all those things are there. So always heart and kidney, they go hand in hand. So it is quite useful to have a cardiac drug which has got a beneficial role in the renal parameters also. Now we come to the other part of the study, that is the one with the PRESERVE study, and this is a landmark trial, Emperor PRESERVE study. and it has been clearly shown that empagliflozin is beneficial when used in patients with preserved ejection fraction. And you can clearly see the composite primary endpoint that one wanted to see cardiovascular death or heart failure with hospitalization due to heart failure. So all these parameters are reduced with use of empagliflozin. Here again, I want to stress that in our daily clinics, we get more patients of heart failure with preserved ejection fraction rather than heart failure with reduced ejection fraction. So this is clearly a role that we should always be aware, and only certain biomarkers or a very detailed history taking may help you to detect this subgroup of patients. Now, mid-range ejection fraction, it has also been clearly seen that around 57 ejection fraction to the tune around 57%, particularly in female patients, empagliflozin has clearly been shown to be beneficial, reducing cardiovascular death or hospitalization. So mid-range ejection fraction is another group where you have beneficial role of empagliflozin. That is why now the recommendation is to use 10 milligram of empagliflozin irrespective of ejection fraction in patients without diabetes. Now empagliflozin consistently benefits, this is reduction in cardiovascular death, heart failure, hospitalization. You can see all the data, they are favoring use of empagliflozin. So these are the data from Emperor pooled analysis, and you can see irrespective of the ejection fraction, you can see the hazard ratio, they are all favoring empagliflozin. The all subgroup of the ejection fraction it's given. Now I do agree that the lower the ejection fraction, possibly the hazard ratio was tilted more in favor of empagliflozin, but still you can see even up to 65% or even above that, the green dots are in favor of empagliflozin. Now, when to initiate empagliflozin in the management of acute heart failure? Now, one must mention here that once the acute heart failure has been stabilized, now what is a stabilized acute heart failure? It means that the patient is off inotropic support, the patient is off dopamine, dobutamine, patient is receiving a fixed dose of diuretics, no more escalating dose of diuretics, and the patient of course is not orthopnic, is able to lie down with comfort. So these are the time, even maybe the patient is inside the ICU, this is the right time to start empagliflozin. So all the molecules that are now being recommended, like ARNI you heard, and empagliflozin also, they need to be started early. So once you start early, you can see that there is a sea change in their NT-proBNP within 1 month of therapy. From maybe around 8,000, 9,000 levels of NT-proBNP, the NT-proBNP will come down to say 1,000, around that. Another point is that in ARNI, it is very difficult to judge heart failure by using BNP, because ARNI modulates the BNP itself. So in SGLT2 inhibitors, this is one more advantage, that you can clearly, you can go for NT-proBNP or you can go for BNP also, whichever is available. Now, this is the IMPULSE study, and mainly they did it in the ICU patients. So patients currently hospitalized for acute heart failure and meets the stabilization criteria. So elevated NT-proBNP was there, and these patients were on IV diuretics because they were in heart failure at that point of time. And when did they start the medicine? That is just after 24 hours and no later than 5 days. So that's about the time they took to stabilize the patient. So then they used these agents. And which are the patients we should not try? Definitely not in cardiogenic shock, because these are the patients who are on inotropic support or who are on IABP or any left ventricular assist device like Impella. So this group you should not start. Or heart failure hospitalization triggered by some secondary cause like pulmonary embolism. So only time will tell whether we are going to use in this subgroup also, because we don't have any study or long-term trial data on this. So I don't know why it should not be beneficial in heart failure from this condition, but we are lacking at this point of time, we are lacking trial data. So we have to wait for that. So again, any revascularization procedure has been done, something like that, or the patient is in end-stage renal disease. So these are the subgroup of patients, they have been excluded from this trial. And this is a clear-cut criteria for who is on a stabilized heart failure. Now the BP is good, around 100. Again, here I would like to mention that a lot of times we keep on using dopamine and dobutamine when we find the systolic blood pressure around 80 millimeter of mercury, but patient has good urine output. Mind you, these are the group of patients whose normal blood pressure will be around 90 or 80. So you should always judge clinically whether the patient is truly having hypertension or not. Just a mere figure of 80 or 90 millimeter blood pressure systolic does not mean anything. If the patient has a good urine output, his mentation is clear, he can answer all your questions nicely, he is ambulatory, then I don't think this is a case of hypertension, and one can safely stop the inotropes and start these drugs. Again, no increased IV diuretic dose, no inotropes or any IV vasodilators. So these are the stabilization criteria. And you can see all-cause mortality and heart failure events, they are all reduced by empagliflozin significantly more than placebo. So these are the summary of adverse events one using empagliflozin, and compared to placebo you can see there is not much difference. So liver injury, renal impairment, UTI, and volume depletion. Of course, like one of my previous speakers was, I think Dr. Debashish Ghosh, he was pointing out to this very important thing, that overzealous use of diuretics should always be prevented when you are using a combination of ARNI and SGLT2 inhibitors. Sorry. So these are the summary of studies. We have now across the entire range of ejection fraction, you can have a lot of studies are there, and you can clearly see that with preserved ejection fraction, you have got soloist, WHF, and impulse study, and they have all been concluded. They have been completed studies. So the data is there with us. So you can use empagliflozin irrespective of the ejection fraction. So these are now the pillar stones: the ARNI plus beta blockers plus mineralocorticoid receptor antagonists and SGLT2 inhibitors. And you can see the hazard ratio is best with this combination. Of course, there are other promising combination coming up like vericiguat or omecamtiv. So these are there. And one popular combination that we still use in our clinics is with ACE inhibitor, beta blocker, and lanoxin. You can clearly see that is I think from the bottom, that is the third one. You can see the hazard ratio as compared with using lanoxin, which is still a very popular drug, and compared to these modern medications. So the outcome is a lot better, but you should always judge these or prescribe this medication based on the affordability of the patient also, because these are all lifelong, they require lifelong therapy at the same time. So these are foundational therapies in definitely in heart failure with reduced ejection fraction. These 4 beta blockers, SGLT2 inhibitors, ARNI, and mineralocorticoid receptor antagonist. So this is the patient-centric tailoring. So after these therapies, additional medications may be required, like even with maximum possibly tolerated dose of beta blocker, if still the heart rate remains high, you can add ivabradine. So these subtle changes you can add on, but SGLT2 inhibitors you can add to all these 9 types of phenotypes of heart failure. That is patients with CKD, patients with different types of heart rates, different types of blood pressure, and even with patients having atrial fibrillation as comorbidity. You can use it even in congested patient or in dry patients, and have to titrate diuretic dose with this. So these are the different patient profiles, and you can see SGLT2 is there as first line agents in all of these groups. Add-on therapies you can look in the other charts, and they can be added on top of SGLT2 inhibitors. And drug-drug interaction is not there very much with SGLT2 inhibitors also. So this is another plus point of using SGLT2 inhibitors. Now this is what is now coming up. This is a proposed hypothesis that one can add SGLT2 inhibitors even before ARNI. As of now, it is best left to your decision as whether you want to add ARNI first or you want to add SGLT2 inhibitor first. But pointers to add SGLT2 inhibitors earlier than ARNI would be if you are dealing with renal impairment, if you are dealing with hyperkalemia, if hypertension is really a problem issue, you can add a 10 milligram of SGLT2 inhibitors rather than 50 milligram or 100 milligram twice daily ARNI. So these are certain plus points for using SGLT2 inhibitors. So these are the different, you can see, therapies. So I thank you for your time and attention. So I would love to answer any questions you have. Thank you so much.
Thank you, Dr. Ghosh Dosidar, for your nice deliberation. You have fantastically described the importance of empagliflozin in the treatment of all sorts of cardiac failures, preserved and reduced ejection fraction, and all types of patients, diabetic and non-diabetic. Now, I will request our learned colleagues to put the question. If there are only 2 questions are allowed.
I have one question, sir.
Sure, sir.
Is it a special effect of empagliflozin only, or is it a class effect of other SGLT2 inhibitors like DAPA or CANA?
A very good question. We have now 2 molecules. One is the empagliflozin and one is the dapagliflozin. Now, both these molecules have been shown to be beneficial in heart failure. In reduced heart failure, both there are multiple trials showing their beneficial effect. Now, only in preserved ejection fraction, we have data and published trial on empagliflozin. The trial on DAPA is DELIVER trial. The results are yet to come out. I think probably by the end of this year or next year, you will have both these molecules in the same platform. But as of now, all the data are with EMPA and DAPA. And these are the only 2 molecules we are using in heart failure. Sure, sir.
In a non-diabetic population, is there any effect of SGLT2 inhibitor on the blood sugar level?
It is just minimal, sir. The initial slides I showed, it is only 50 to 60 milligram of sugar is excreted, and the data they have shown is not sufficient to cause hypoglycemia. So 10 milligram dosage, I mind you, it is 10 milligram dosage that is being used in non-diabetic population, not the 25 milligram dosage.
Okay. Thank you.
Can it be used concomitantly with diuretics? Any concern about electrolytes?
Yes, sir. Actually, 3 molecules are causing diuresis. One is these SGLT2 inhibitors, one is ARNI itself, and one is the diuretics. So when you are using 3 diuretics in that fashion, or 3 drugs that is causing diuresis, you must take care of the volume status. And you can, you might get pre-renal failure with very high levels of urea and creatinine just around 1.5 or 1.6. So one must titrate an Indian subset also, where there is so much seasonal variation in amount of sweating. So even you see that in our population, one antihypertensive throughout the year, most patients are not stable. In winter, you will find them to be hypertensive, and in summer month with that, they are having hypertension episode. So every drug and dosage needs titration, and particularly if you are using a combination of SGLT2 or ARNI, because these 2 drugs have so much of mortality benefit. So the axe is falling on diuretics. We are reducing the dosage of diuretics. Diuretics do not provide any mortality benefit. They are only morbidity benefit. But they are very essential drugs in acute heart failure scenario also.
Can we have separate schedule of antihypertensive in summer and winter in our patients? What is your opinion about it?
That is exactly what I wanted to say. The dose titration in certain patients becomes very important, because in summer months, because of sweating, the blood pressure sometimes does indeed come down. So there is so much temperature variation in our country in around the year. So the dosage also may need to be modified.
Thank you, sir. And
thanks to Dr.
Sir, wanted to have a question.
Thanks to Dr. Ghosh Dosidar. Now the session is closed.
Thank you,
Thanks.
sir.
Thanks, Dr. Ghosh Dosidar, for being with us. One moment,
it's been a pleasure to be here with you all. And this is one of the best seminars that I've attended. Thank you so much, sir.
Thank you so much. It is our pleasure too. I would suggest Dr. Tusharkanti Bhattavel, our senior physician, to deliver the memento to to Dr. Dipankar Ghosh Dostidar.
Thank you, sir.
Hello. Oh, okay. And sir, please, I would request Dr. Arnab Banerjee to present one humble memento to Dr. T.K. Botobel. A big hand, please.
Well, we have come to the end of a very interesting session by Dr. Ghosh Dostidar. Now we have a very, very good topic, and to speak on this, we have a very eminent speaker from Delhi, Dr. Amit Gupta. Dr. Amit Gupta will be delivering the speech about sulfonylureas revisited, glycoside a class apart. And to chair this session, I would suggest our senior physician, Dr. Tusharkanti Botobel, to please come over the stage and introduce the topic and speaker to the audience.
Welcome, Dr.
Thank you, sir. Thank you for having me here.
Achha, let me read out the biodata of Dr. Amit Gupta. He is MBBS, DNB, MNMS, FACE, FRSSDI, FICP, FISH, FRCP Glasgow, FRCP Edin, FSCG USA, and many other degrees. He is Director of Center for Diabetes Care, Greater Noida, Membership Advisory Group, American Diabetic Association, National Executive Council Member, Joint Secretary Diabetes India, Advisory Council Member, ACP India Chapter, Immediate Past Communication Director, ADA, AAC Diabetes Resource Center Committee Member, RSSDI, Defeat Diabetes Media Task Force Member, Apex Body Member, North Apex, The Art of Living Trust, Joint Secretary UPDA, Reviewer, Endocrine Practice, AAC Case Reports, UDDC, MKSAP 19, Diacare Award for leading most successful diabetes campaign, Defeat Diabetes 2021, ACP India Chapter, Community Teaching Award 2021, Times of India Health Icon Award 2021, Diabetes Excellence Award 2021, National Health Award, Double Helical Diabetes Education 2016, Diabetes Awareness Initiative Award, Diabetes India 2017, Investigator of the Year Award 2019, 2018, 2017, Padmakar Tripathi Young Scientist Award 2017. Now I will request Dr. Gupta to start his deliberation. Dr. Gupta, please.
Thank you, sir. Thank you very much for the kind introduction. And at the outset, I would like to thank the organizers, Dr. Subrata Bhattacharya, Dr. Subhamay Chatterjee, and Dr. Arnab Banerjee, sir, for giving me this opportunity and honor to present in front of such a learned audience. And I am very, very happy to be here. And with your permission, I would like to share my screen so that I can proceed with the presentation. I hope my screen is visible to all of you. Is my screen visible to you, sir?
It's visible. It's visible, sir. It's visible.
Yes. So today, when everyone else has been speaking on something which is new and what is new is happening, I am going to talk about a very, very old molecule, that is sulfonylurea, but we are going to do a revisit. And how does the glycoside as a sulfonylurea stands a class apart? Is there any difference between glycoside and the other sulfonylureas? We all know that type 2 diabetes had two clinical hallmark features. One is the insulin resistance, and we all know that this is the impaired ability of the insulin to suppress hepatic glucose output and promote peripheral utilization of glucose. And second is the compromised insulin secretion, that is the compromisation of the islet cell function. We know that in type 2 diabetes, there is a insulin resistance, there is insulin deficiency, and we all know that in patients with type 2 diabetes, both these features, they coexist. We also know that insulin secretagogues have been the backbone of management of diabetes for almost many years, for decades. And a logical part of the therapy of type 2 diabetes is that when we want to stimulate the beta cell to produce more insulin. And in almost all the landmark trials like ACCORD, ADVANCE, ADOPT, it has been seen that the sulfonylureas have been at the mainstay of the therapy. Sorry. Now, it is important to have a just brief look about the beta cell function and the insulin secretagogues effect of the sulfonylureas. We all know that sulfonylureas act on the sulfonylurea receptor 1, which are located in the pancreatic beta cell. And what they do is that when we give a sulfonylurea, there is the potassium channel is blocked, so potassium cannot move out of the beta cell. And this allows the influx of the calcium into the cell, and the calcium binds to the already stored insulin into the cytoplasmic vesicles, which is then excreted. So this is how the a secretagogue drug like sulfonylurea plays an important role. It is important to understand that for the management of diabetes, we have a lot of things which can be done. And right from the beginning of the lifestyle modifications, we have metformin, sulfonylurea, we have TZDs, GLP-1 agonists, now we have oral semaglutide also, the AGIs and other drugs also. But we know that the sulfonylurea have a robust HbA1c lowering effect, and this can be up to 1 to 2.25% of the HbA1c lowering can be seen with sulfonylureas. That is why they are known for a good effect on the HbA1c. But the question arises, are all the sulfonylureas same? So we will be looking into these different aspects of the sulfonylureas action. Is there something called beta cell exhaustion? What is the impact on hypoglycemia? How do they differ? Is there any selectivity, mortality risk, and CV safety? And what are the safety in comorbid conditions like CKD? So let us first look at the beta cell exhaustion. So the most pertinent question here is that, do beta cells get exhausted in type 2 diabetes? Yes, we know that. It is one of the truth, and there cannot be any debate on that. But the question is that, does sulfonylureas, they accelerate beta cell exhaustion? I think there can be people who will say yes, but I believe it is no. Sulfonylureas, at least the new class, that is the newer generation sulfonylureas like glycoside, they do not lead to acceleration of the beta cell exhaustion. And this has been seen in UKPDS as well as the ADOPT trial also. If you look at the DCC trial, you will find that the beta cell function decreases over a time. And over a period of 5 years, you will find that there is a significant and marked decrease in beta cell function. And this happens through all the group, whether it is the intensive therapy group or it is the conventional group. In both the groups, there was a decline in beta cell function. So it is the inherent pathogenesis of the type 2 diabetes, in which there is a continuous decline in the beta cell mass. And this is what leads to beta cell exhaustion. There have been many papers and many research which says that, for example, papers which have been published in different years, and they have found that the long-term usage of modern sulfonylureas have no detrimental effect on the beta cell functions. And even after a treatment as long as 5 years, in some studies it has not, there is no beta cell exhaustion has been found, and the insulin secretion potential remains the same. Also, the glycoside extended release preparation has the established property of preserving beta cell function because when you avoid the glucotoxicity, it is the glucotoxicity which is more dangerous to the pancreas cells than a secretagogue drug. If you look at this slide, you will find that in patients on whom the glibenclamide, that is the older generation's SU, was used, the time to insulin therapy was almost 8 years. And you will find that when these patients were treated with gliclazide, the time to insulin therapy has been extended up to 14.5 years. So many people were not requiring insulin when a modern sulfonylurea was used. But however, again, we can have a different patient profile. This can differ. An important impact is hypoglycemia, and we need to understand that hypoglycemia is often, we know that there can be multiple causes of hypoglycemia. It can be because of a missed diet, it can be because of other medicines which are taken together. It is more common in patients who are elderly and those who are on polypharmacy. And we know that insulin can also cause hypoglycemia, but why do we blame only sulfonylureas? Because we know that when a combination of drugs is given, then the hypoglycemic potential always increases. So if you look at all these sulfonylureas, starting with the glyburide to glipizide, you will find that the risk of hypoglycemia is almost 5% when it comes to gliclazide, in comparison to 21.3% when the older generation molecules like glyburide or chlorpromide were used. Also, there is a study in which sitagliptin versus gliclazide was compared. And the study was done in patients who were doing fast during Ramadan. And the study compared incidence of the hypos between sulfonylureas versus sitagliptin. And what this found is that the hypoglycemia incidence was similar between the DPP-4 inhibitor and the gliclazide, while higher with glimepiride and the glibenclamide. So the modern sulfonylurea, the risk of hypoglycemia is almost very less, or in comparison to any other drugs, it is comparable. If we look at this study and the DIVE trial, you will find that hypoglycemia when compared glimepiride versus gliclazide in almost 845 subjects, you will find the hypoglycemia incidence was 3.7% in patients who were on gliclazide, rather than 8.9% those who were on glimepiride. So let us look at some evidence regarding the selectivity, mortality risk, and the CV safety of the sulfonylureas. So glibenclamide and glimepiride are the non-selective sulfonylureas, and they have effect on sulfonylurea receptor 2 receptors, which are present in the heart also, while the gliclazide acts only on the SUR1 receptors, which are present in the pancreatic beta cells specifically, and so that does not interfere with the ischemic preconditioning, hence is more cardio safe. So this is one of the reasons that the expression of the receptors is different, that is the SUR1 and SUR2, and the gliclazide specifically acts on SUR1, and it does not act on SUR2, which is located in the cardiac tissue. Also, if you look, unlike glibenclamide and glimepiride, modern gliclazide XR selectively block only SUR1 of the pancreatic beta cells, and it is the only sulfonylurea which does not bind to the EPAC2 receptor, which is a stimulating factor for insulin exocytosis, and this may also confer a lower risk of hypoglycemia. So when a sulfonylurea like gliclazide is given, you can say that it does not cause persistent release of insulin from the beta cell. Also, if you look at the mortality data with the modern sulfonylureas, we found that the mortality was lower in patients who were previously treated with sulfonylureas versus any other oral medication or no medication or even on insulin. And among sulfonylurea treated patients, in hospital mortality was lower in patients receiving beta cell specific sulfonylureas compared with the glibenclamide. And the arrhythmias and ischemic complications were also less frequent in patients receiving gliclazide and the glimepiride. We have seen that there are different sulfonylureas and severe risk of hypo, and a cohort study among patients with type 2 diabetes initiating monotherapy with sulfonylureas between 1998 and 2003, very long period. It compared use of pancreas as a non-specific long-acting sulfonylureas to pancreas-specific short-acting sulfonylureas like gliclazide, tolbutamide, and glipizide, and it found different sulfonylureas have different severe risks. So there is a non-specific long-acting sulfonylureas, glibenclamide and glimepiride, have an increased risk of severe hypoglycemia, and we know that hypoglycemia is a risk factor for increased cardiovascular mortality. If we look at the data from the advanced trial, you will find that this trial had 11,140 type 2 diabetes patients, and all these patients were subjected to the intensive glucose lowering with gliclazide XR, and it reduced, and we found that in advanced trial there was a reduction, reduced microvascular as well as the macrovascular events. Mortality and CV risk associated with different sulfonylureas versus metformin in patients pre and post MI. So this is a large Danish registry, and this Danish registry data has been is mentioned by Burnwan also in the textbook of Burnwan for the cardiology, and almost more than 1 lakh subjects who had previous MI, and up to 9-year follow-up was done with a median of 3.3 years. And comparison of glimi, glicla, glibenclamide, glipizide, torbutamide, ripaglinide versus metformin was done, and it was, you can clearly see in the graph, you will find that the gliclazide has the lowest risk than any other sulfonylurea in the Danish registry. If we talk about the cardiovascular safety of the gliclazide versus other sulfonylurea, gliclazide has been shown to have the least CV hazard ratio when compared to the other sulfonylureas, and also this may be because of its pancreatic beta cell affinity, which is independent of the cardiac potassium ATP channel. And this is what the Burnwan's textbook of cardiology also mentions, that and the Danish registry, and it mentions that the gliclazide appears to be associated with a lower CV risk than any other intermediate acting sulfonylurea. The gliclazide and LV mass in type 2 diabetes, as this is an association of cardiologists and diabetologists, and many eminent cardiologists are here, they understand the importance of the LV mass and the LV mass index. So it has been found that the use of glibenclamide increases the LV mass index, where the gliclazide was associated with the reduction of the LV mass index, and the gliclazide-induced cardioprotection may be related to the known blockade of the myocardial K potassium ATP channels, as discussed earlier. So gliclazide reduces the LV mass compared to the glibenclamide, which causes the increase in the LV mass index. So this again has a cardioprotective impact. If you look at the safety in comorbid conditions like CKD, you will find that the patients with diabetes, almost 39% of them are likely to develop chronic kidney disease. And we know that chronic kidney disease is likely to be more common in elderly people and those who have long-standing diabetes and uncontrolled hypertension. Diabetes causes damage to the microvasculature and leads to the dysfunctional kidneys. And we know that combination of diabetes and CKD can lead to a significant increase in mortality, and they have the highest risk of any cardiovascular event. And I will not go into the staging of the CKD, but we all know that in patients with CKD, we need to be very cautious when we are giving the drugs. And we know that the most of the oral anti-diabetic drugs, they are metabolized in the liver, and the long-standing active life of the drugs can worsen the condition. And a decline in renal function impairs the clearance and metabolism of any anti-diabetic drug, insulin, and this can lead to both hyper and hypoglycemia. We all know that metformin has to be discontinued, or it is contraindicated in patients when eGFR is less than 30. And we know that gliclazide, a majority, 96% of the gliclazide is metabolized by the liver. Only 4% of it is secreted through the kidneys. So gliclazide can be used effectively and safely in patients with CKD. And only in advanced patients with CKD, the dose reduction of the gliclazide will be required. So this is important, that it is an important drug that can be used in patients with CKD also. In advanced trial, if those almost 11,140 patients for 5 years, intensive glucose control was done with gliclazide MR, and it significantly reduced the risk of end-stage renal disease by 65%. There was a reduction in microalbuminuria by 9% and macroalbuminuria by 30%, and also the progression of the albuminuria was significantly reduced by 10%, and its regression significantly increased by 15%. Gliclazide has additional benefits, and in advanced study, it was shown that it causes no additional weight gain was seen because it does not lead to persistent hypoglycemia. While the other sulfonylureas like glibenclamide, there was an increase in weight of up to 1.7 kg, which has been seen. This is important to look at the data from the Diabetologists study, which is a real-world study in patients with type 2 diabetes. And these were treated with gliclazide modified release during fasting. And this was a prospective international observational study. And those patients more than 18 years of age with type 2 diabetes and they were examined at the inclusion visit and occurring 6 to 8 weeks before the start of the Ramadan. And patient received a diary to report treatment changes, hypoglycemic events, and other events. It was, and glycoside MR was taken once daily for 14 to 18 weeks. A second visit was conducted 4 to 6 weeks after the end of Ramadan. So what the study found that the patients with type 2 diabetes, when treated with glycoside MR during Ramadan, have a low risk of hypoglycemia and maintain glycemic control and weight while fasting. And this is the first real-world study to show that patients with type 2 diabetes treated with glycoside without dose adjustment during Ramadan can fast safely with a low risk of hypoglycemia, with no risk of severe hypoglycemia, and even in prolonged fasting period while maintaining glycemic control and weight. So you can understand that the risk of hypoglycemia is extremely low if the patient takes all the precautions and takes the medications properly. There are many pleiotropic benefits which have been advocated with the use of glycoside. One is it has a free radical scavenging properties, and this may be having some benefit on lipid oxidation. Glycoside also helps in pleiotropically. It has certain mechanisms by which it can reduce the oxidative stress. So in summary, I would like to say that now we are in an era where we have the oral GLP-1, we have injectable GLP-1s, we have weekly GLP-1, we have a lot of SGLT2 inhibitors in our armamentarium, we have gliptins, and apart from that, we have our old friend like sulfonylurea. So where do we place our sulfonylurea? I believe sulfonylurea, despite all the advances, are going to be one of the mainstay in treatment of type 2 diabetes. And because we have a long safety data, they are being used for almost 4 decades. And various guidelines like ADA, ACE, NICE, IDF, and recent RSSDI guidelines also, they suggest that it is one of the cost-effective and one of the most effective medication. I still believe when we encounter a patient with a very high HbA1c, the clinician in every one of us still look up at a sulfonylurea as one of the most robust soldier who can effectively bring down the HbA1c. And within sulfonylureas, we need to understand that there is a class difference. All the sulfonylureas are not same. So if there are certain bad effects with some sulfonylureas, it cannot be labeled and pointed to all the classes. So we need to allay those apprehensions. And also the modern glycoside, it seems to have a beta cell protection. You may say it is because of good glucose control, you remove glucotoxicity. When the HbA1c is good, the patient is less likely to have microvascular complications, macrovascular complications. And CV safety, there is no concern regarding the CV safety with glycoside. It has shown to be safe and effective, and it can also be used in patients with CKD and the other chronic conditions. So with this, I would like to conclude here. I am very grateful again to this platform, that is the Abcdcon, the 7th conference. And it is really a pleasure for me to be here and to present in front of such a learned audience. Thank you very much.
Dr. Gupta, and I would like to invite audience for just 1 or 2 questions on
It's a wonderful molecule. It has got a lot of safety. It has less chance of hypoglycemia. Yet has got pleiotropic effect, whatnot. Yet
I'm not able to hear anything from the podium. Am I audible?
Yeah. Am I audible? No? Am I audible?
Yes, sir.
Am I audible? Am I audible, sir? Am I audible, Dr. Gupta?
Yes,
okay. So actually what Dr. T.N. Banerjee has asked in the question that glycoside and glycoside MR are a very robust sulfonylurea, modern sulfonylurea. It's present in the market as well as in various studies for over more than a decade. But still in the Indian market, it's glimepiride which is going well above glycoside, whether it is only the noise level and the dragging of the molecule. Why glycoside basically is not so much used in Indian market? That's how you have put the question, na? Yeah, that's his question.
You are absolutely right, and sometimes we also get carried away because something which is pushed more, we definitely hear more and more about those things. and somehow the glycoside got slipped under the carpet. So it is very important for us to understand as a scientific person, we should be looking at the data and doing our own self-critical analysis. If I look at my own clinical practice, I use almost 90% of the glycoside in my clinical practice and very less of the glimepiride maybe. So it is heavily towards the glycoside side only. And because the evidence is there and we have seen the benefits also.
Okay, one more question.
Am I audible to you?
Yes, sir.
Okay, actually now some company is coming with the escalating dose of the glycoside, that is 90 or 120. You have any emphasis on this matter?
I think, sir, one thing we need to understand that incremental doses of sulfonylurea, almost 95% of the result you can achieve even with the lowest possible dose. Adding more and more and increasing the dose is not going to make much of a difference. This is my self-belief. And this is very true. You all know that glimepiride is also available in strength of 1 milligram, 2 milligram, then 4 milligram, and many people they use 4 milligram BD also. But if you look at the data, then you will find that there is no use of using 4 milligram twice a day. So again, I believe that a sulfonylurea, if it is going to work, it can work very well within a limited dose of 60 milligram or maybe 90 milligram. But incremental doses of sulfonylurea is not going to make much of the difference in the clinical practice.
No, actually, the question, so far I could understand that sustained release 30 milligram, they claim that is equivalent to instant release 80 milligram. Probably you wanted. No, sustained release. They claim that 30 milligram sustained release is equivalent to instant release 80 milligram. Sometimes this leads to confusion among clinicians.
Yes, sir. That is fine. If you are using a sustained release, then it is definitely the equivalent. We understand. So equivalence is different. So if you are not using a sustained release preparation, then we have to equate it.
Hello. One more question. Is there any use of this glycoside in pregnancy recommended?
As of now, sir, glycoside is not recommended in pregnancy.
Okay. No more question now from the audience, and I would like to tell the audience that there is always a live chat box, so you can put your questions and Dr. Gupta will be happy to answer. So thank you, Dr. Gupta, for your nice deliberation, and in Abcdcon we will expect, as per your time, year after year participation, and we will be very happy again to invite you into our this conference in the city of Bardhaman next year. Thank you very much.
Thank you.
সুজন,
So dear colleagues and senior colleagues, we are in the fag end of our program today. So before getting much tired, I would welcome Dr. K.K. Ganguly, Kullan Kumar Ganguly, endocrinologist, and he will be speaking about advances in diabetes. Dr. Ganguly should have been come here and delivered the lecture. It would be much better for us because we love this person like anything. And to introduce the topic and speaker, I would request none other than Dr. Sujan Sarkar, who is known to be a friend and roommate of Dr. K.K. Ganguly. Dr. Sarkar, please.
Good evening, everybody. So we have come to the fag end of this 7th Abcdcon, and what would be more pleasant than to end this academic session with a speaker of the stature of Dr. K.K. Ganguly, who has always been a constant companion of our Abcdcon from the very first year. He happens to be one of the foremost diabetologists of India today, both from professional and academic point of view. He has been the driving force behind Abcdcon and many other such academic ventures. Dr. Ganguly did his MBBS from Calcutta Medical College in the year 1990, did his MD in the year 1996 from Indore. He did MRCP in 2000 and CCST in endocrinology in UK in the year 2007. From 2007 to 2009, he was a consultant in diabetes in the University Hospital of Birmingham, UK. He has been an investigator in several clinical trials at the national level. He won several prizes in UK like Stephen Whitaker Prize, Wayne Wade Prize, Endocrine Society Prize, NASE Prize, etc. He has got 20 publications in international journals, 19 publications in national journals so far, 15 abstract publications in international journals, and he has contributed to 4 book chapters so far. Currently, he is a consultant in endocrinology in the CK Birla Hospitals and PLS Hospitals, Calcutta. So without wasting any more time, I call upon Dr. Ganguly to present his lecture. Dr. Ganguly.
Thank you, Shujan. Thank you very much, and good evening, everybody. And I'm very sorry I could not be there. So as punishment, I have done the experiment on myself, which I'm going to show you. Because sometimes during live recordings, there are a lot of disturbances. So I have recorded my talk, and I think somebody will play my recording. So over to you for starting the recording.
Ready, sir.
Ready, sir?
Yes, sir.
Okay, so let me start coaching. Good evening, everybody. I wish I could be there physically in Burdwan, as I've been every year, to see a lot of my friends there. But anyway, circumstances are different, so we have to adopt. Similarly, the thing I'm going to say is the same, that we have to adapt to the new circumstances in diabetes. And I'm going to talk about advances in diabetes, ambulatory glucose monitoring. It's not just advances in diabetes. I've been asked to specifically talk on ambulatory glucose monitoring or continuous glucose monitoring. So whether we like it or not, the advances has been there in continuous glucose monitoring, and in the future, more and more and more of our patients are going to come back with these continuous glucose monitoring or CGM result sheets, and we cannot tell them that I don't know what this is, or just go and do a fasting PP or do SMBG and tell me the report. We have to know about this. Just like I had was grown up in an era where there was only landline. Then came the mobile phone. We have got used to the mobile phone. Similarly, we have all have to get used to the CGM, which is going to gain more and more ground in the near future. So I'm just going to show you some 3 cases, and I'll tell you how the CGM has helped. So first one, I've just kept it simple. The numbers aren't exactly, but it's just from memory. So 56-year-old female, type 2 diabetes for 8 years, on maximal sulfonylurea, metformin and DPP4, fasting sugar of 200 and PP of 245, HbA1c 9.3. What should be the next step? Now see here, looking at this, it is pretty clear that, oh, for this lady, we should really start basal insulin. Ideal candidate for basal insulin. But no, and I will tell you why not. So second case, 46-year-old female on maximal oral hypoglycemic agents and basal insulin. Her fasting keeps coming back below 150, but her HbA1c is 12%. So her question is, doctor, why is my HbA1c high although my sugar levels are fine? But I could not see much in way of any PP sugars at all at home, glucose, the capillary glucose monitoring, SMBG. Only the fasting sugars were all around 150 or less. So why is it 12%? And the third case, a 55-year-old male who, because he had high fasting sugar, he was given SGLT2 inhibitor in the before breakfast and glimepiride metformin combination before dinner, because his PP wasn't that great, but fasting used to be higher. we all know there are certain groups of patients who have this. So his fasting came back as 120 and HbA1c is 7%. He complained of some disturbed sleep and nightmares, which have become more frequent recently. So I'll come back to these cases and I'll tell you the applicability, how the SMBG has helped these cases. So it is rapidly gaining ground, and there are multiple devices which are now slowly coming into the market. In the future, I can foresee the prices might come down as well. So more and more people are going to use it. I can foresee that this is going to be used in the hospital setup, inpatient setup as well. So the update regarding this is really the need of the hour, not just for diabetologists, but also for non-diabetes, non-diabetology physicians as well. The ADA has clearly said in their 2022 guideline that real-time continuous glucose monitoring should be offered for diabetes management in adults with diabetes on multiple insulin injections or continuous insulin infusion that is pumped. The choice of device should be made based on patient circumstances, and they have clearly said that when used as an adjunct to pre- and postprandial glucose monitoring, the continuous glucose monitoring can help to achieve HbA1c targets in diabetes and pregnancy. So the august bodies are beginning to endorse this CGMS and realizing the importance of this. So you see here, this is the traditional blood glucose testing, and we can see here there's only one reading which is above target, and the blue zone is the region between 90 to 180, so within target. Most of the readings are within target. But if you do a continuous glucose monitoring, you will see there are quite a few peaks above target and quite a few drops in the danger area, hypoglycemia. This is more dangerous. So that is how, in a nutshell, the continuous glucose monitoring is. It tells you just that bit more than the SMBG. And I can tell you from my experience, my friends, that whenever I've asked for a continuous glucose monitoring to be done for a patient, it has taught me. It has taught me more than it has than anything. So it didn't gain ground at all. So after that, there has been now a flood of them. As I said, a flood of them. So in the last 4 or 5 years, a flood of them which has come up in the market. So actually live demonstration for you. So these are the three basic things. So we all know about this, but continuous glucose monitoring is one and flash glucose monitoring is another. Flash means in a flash you can check and tell what the sugar level is. So out of these agents, the continuous glucose monitoring, 2 are available in India. I was told that the Dexcom was available, but I don't think it really has made any grounds. And definitely in our eastern region, only 2 are available. One is the Guardian Connect, which is the Medtronic, the pump makers, and Abbott Diabetes Freestyle Libre. So the Guardian Connect is the one I told you here, the continuous glucose monitoring. It will not tell you the sugar readings then and there, but it will tell you after 7 days when you take out the device, and the flash glucose monitoring, which it will tell you then and there what the sugar levels are. And later on, it will also give you the last 8 hours sugar readings, sugar graph. So this is the Freestyle Libre, which I told you about. You can wear it up to 14 days. It doesn't need fignostic calibration. You need 1 hour for warming up. It doesn't have any, although it says active alarm, but actually it doesn't have it. It cannot connect with the insulin pump. The overall accuracy, MARD. So MARD, the mean amplitude, it should be the lower the better, is 9.3 and 10.4. So pretty much the same as compared to the Medtronic Guardian Connect. These are the chemical substances which interferes with, and there is some interference with X-ray and CT, MRI, X-ray machines. CT or MRI did not impact the data recorded by LibriPro in 10 sensors. However, that Medtronic suggests that we remove the sensor in presence of X-ray, CT, MRI, PET, or airport scanners. So Medtronic Guardian Connect, that is usually worn for 7 days only. Again, you need 2 hours of warm-up period. So again, I'll go back again. Freestyle Libre is flash. That means it tells you then and there plus 8 hours graph, and this doesn't tell you then and there, it gives you 7-day data. So this is the Medtronic Guardian, which gives you the second 7-day data. The transmitter is somewhat like this. There is a very small needle which goes just under the skin in the interstitial fluid, and the glucose comes out, and then you know what the glucose levels are. So how do you put it? It's pretty simple, really. It's very, very easy to put. So you just put this device on your body. It's all inside. You just press the button and the device gets automatically attached to your body. It is not that painful, that much I can tell you. So it looks like this, and you wear it for about 7 days. After 7 days, you take it out. It will give you a curve, and then you put it connected to the computer. It will give you the data for every 5-minute sugar readings for the entire 7 days, including time in range, time above range, hypoglycemic readings, hyperglycemic readings, daily graphs, everything. So the data will be somewhat like this. So the green is the correct sugar level, the desired sugar level, and these are all above. So that's what the Guardian Connect will give you. Now, how about the flash glucose monitoring? The flash glucose monitoring, again, the device transmitter will be here, very thin sensor filament, less than 0.4 millimeters. It will go 0.5 millimeter under the skin surface. Again, it measures the interstitial fluid. Remember, the glucose diffusion between capillary vessel and intercellular fluid has a delay of approximately 5 to 10 minutes. So the blood glucose level in the blood will be transmitted about 5-10 minutes later in the flash glucose monitoring. And the flash glucose monitoring looks somewhat like this. So you put it on here. There is a scanner. You just put it in front of the machine and it will give you. Now, ladies and gentlemen, let me surprise you a little bit. So, as I told you, I'm going to give you live demonstration. I think for the purpose of this presentation also, I put in a flash glucose monitor on myself. Now watch here. So you see, this is what it is. I put it here. And I can tell you that it is absolutely painless to put. And I have put it for the last 5-7 days, nothing, no pain, nothing. I don't even feel it. You can have your shower, you can swim, you can do whatever you want. And this is the device, okay? This is the device. Now I need to just give me a second. Okay, so this is the device. Now this is the device. I will put the device close to, and this is the reading. Can you see? 114. Okay? So all I've done is, I've just pressed one button here, I put it here, and that gives you this result. So fraction of a second, you get the result. So this is what flash glucose monitoring is. And I wanted to put it on myself, really, because I thought before, we keep our patients to do it. We should know in and out of to how you feel about it. Is there any pain? What are the teething problems you have when you put this on? And I can tell you, it's absolutely painless to put in, absolutely painless when it stays in. And it has told me so many things that for me, the best time of walking is after dinner. Because in the morning, when I do walking, it doesn't make much difference to the blood sugar. But after dinner, my sugar level goes up. I'm not a diabetic, but after dinner, my sugar level goes up. And when I walk after dinner for 10-15 minutes, very nicely, it comes right down. So it teaches everybody, including doctors and the patients. So I'm getting more and more enthused about this. So when you put this sensor here, just like I showed you, it will show you the reading. This arrow means it is slowly going up. This arrow means it is remaining the same. Again, if it is this arrow is this way, it is going down. Straight arrow means rapidly going down. Straight arrow up means rapidly going up. It will give you a graph like this. So, this is midnight. This is 2 o'clock in the morning, 8 o'clock in the morning. So this is the 70 to 180 is the desired area, and the graph will be a graph you will get like this. So anytime you want, say, so for my machine, anytime I want, I will just connect this to my computer and it will give the graph like this. And if I want to know at this particular time how much it is, I will just press this button and I will just put it here over my shirt actually, and this will give you the result. So it will give you time in range. That green is 70 to 180. So for this particular reading, it says that most of the time, 98% of the time, reading is between 70 to 180. 2% of the time, it is less than 70. So is there any evidence that this makes any difference as far as HbA1c reduction is concerned? So there is growing evidence. So this is for type 1 diabetes using the Freestyle Libre flash glucose monitoring. The time in hypoglycemia was reduced by 38%. Nocturnal and serious hypoglycemia reduced by 40 and 50%. Both were statistically significant. This was in type 1 diabetes. In type 2 diabetes, more than 200 patients. Again, time in hypoglycemia was reduced by 43%. Time in serious hypoglycemia reduced by 53%, all statistically significant, and nocturnal hypoglycemia reduced by 54%. So this is what it shows graphically. So you have got data for type 1, you have got data for type 2 as well. There's another data I'm showing for type 2 diabetes, that reduction of HbA1c by more than 0.5%. You get in 70% of the patients, as opposed to 30% in placebo arm, and more than 1%, about 40% of the patients. In this study, however, there was no difference in the hypoglycemia, but the perceived frequency of hypoglycemia improved. So overall, there seems to be definitely a drop in the HbA1c with use of these devices. But some studies show improvement and marked improvement in hypoglycemia. Some doesn't show improvement in hypoglycemia, but none of them show increase in hypoglycemia definitely, but definitely drop in HbA1c. So at this meta-analysis tells you here, it shows you clearly that there is about 0.55 or almost like a drug, 0.55 percentage drop in HbA1c, almost like one drug working on it. So this is the meta-analysis again, which shows that the HbA1c, moment you start using it, the HbA1c begins to drop, and it reduces each month to approximately 2 months. After that, the drop is maintained. So as I said, after 2 weeks, I have to take this out because it will not work after 2 weeks. So you cannot keep checking it, because this transmitter is about 4,500, and this reader is about 4,500. So this reader you can keep. This also doubles up as a glucometer, because you can use a glucometer strip here. It will work as a glucometer. So, but this you have to buy again if you have to do it again. But if you do it for 2 weeks, that will give you a good idea as to where things were going wrong and how you can adjust. So that is enough, I think, just having it for 2 weeks. So another FLAIR study which suggested improvement in quality of life. So 95% report a better understanding of the glucose fluctuations. And this I can tell you, this definitely happens. It gives you a better understanding. Whenever I get the CGM report, what I do is I have a look at it. I get a fair idea what is happening. Now I turn the report over to the patient and I tell the patient, this is the time of the day, this is the blood sugar level which is occurring. Now you tell me why it has gone up here, why it has gone down here. What do you think has happened here? And 9 times out of them, the patient themselves will tell you the answer. If they themselves tell you the answer, job done, because they understand why their glucose fluctuations are there. So that will help improve the swings and therefore the hypoglycemia and eventually HbA1c. So 92% find it easier to regulate their glucose around a meal, 80% adjust insulin dose more frequently, 37% report engaging in physical activity more frequently. Now there is emerging importance of in pregnancy, because you see in pregnancy, the patients have to check the CBS so frequently. It's very, very tiresome, painful, and they can get away with this. Why not? So this is one study, 12-month RCT, 325 women with type 1 diabetes who were pregnant or planning pregnancy. use of continuous glucose monitoring versus SMBG, it improved TIR, time in range, shorter hospital stays, few neonatal ICU, few neonatal hypoglycemia, and lower incidence of large for gestational days. So that's very impressive. So although they were not approved for use in USA, but they are approved for use in many European countries. Now, this is the future, I think, in inpatient use. So growing evidence in inpatient. So one study, use of glucose monitoring, flash glucose monitoring, the one I have used in hospitalized patient, was associated with higher rate of detection of hypoglycemic events. Few studies with Dexcom reduced both hypo and hyperglycemia. Very important, it reduces both staff exposure to infection and utilization. The COVID has woken us up. So actually in United States, during the COVID pandemic, the FDA had said, yes, you can use the flash glucose monitoring for patients because that will reduce your contact with the patient and therefore the infections. Because as I showed you, you can put the reader, just like I did, put the reader on top of your cloth, on top of your shirt, and it will give you the reading. So this is one good way of, and you know, many patients need quite frequent blood sugar monitoring, and altogether the bill might amount to much more than the bill which I told you for the sensor and the reader. Because this reader you can keep, all you have to do is keep changing the sensor. So I perceive that in the future that there will be more of it in inpatient use. And actually in one or two of my cardiology ward patients had actually had this, and we all will use this instead of capillary glucose monitoring because he won't allow us to do it. He said, I've got this, why do you want to unnecessarily finger prick my finger? So fair enough. So I perceive that in the future, we will see more and more of this. So we need to get updated about this. So there was a data in critical care, critically ill patients. Therein, you see the control group and the CGMS group. The patients in the target range, those who use the CGMS group, they had more patients were in target as opposed to the control group. So that brings us to the time in range. So we need more in time in range rather than time above range. The international consensus in 2019 elaborated on it further. Roughly more than 70% of our time, we should be in time in range between 70 to 180, and rest more than 180, less than 25%, more than 250, less than 5%, less than 70, 4%, less than 4%, less than 54, less than 1%. This changes when it's older, it should have 0, less than 54. In pregnancy, you should have 0, more than 250. So its time in range is in this consensus defined what it should be. And what is the significance? So for every 10% reduction in time in range, that the sugar readings are not in range, 10%, for every 10% reduction in time in range, you get 64% increase in retinopathy and 40% increase in nephropathy. And in the international consensus, from this flash glucose monitoring itself, you can find out if the patients are in time in range, what percentage of the time, and what would be roughly their HbA1c. There are two tables side by side, which is a little bit confusing. This one is for patients with type 1 diabetes. This one is for patients with type 1 and type 2 diabetes. So that will apply to us. So if somebody has most of the readings, 80% of the readings between 70 to 180, their HbA1c is just less than 6%. 70, it will be less than 6.7%. So you can make a rough idea. So patients wherein we have difficulty in really, so the HbA1c is not adding up. The fasting in PP is showing something else, the HbA1c is showing something else. We can use this as well. Not that it is recommended, but I'm saying that this is one of the ways we can help the patient. So where should we use the CGMS? Patients who are on multiple insulin injections, patients who are at high risk of hypoglycemia, who have impaired hypoglycemic awareness, who have frequent nocturnal hypoglycemia and severe hypoglycemia. This one, marked discrepancy between fasting PP and HbA1c, pregnancy, increasing role in pregnancy now, and as an educational tool, definitely. So to end it, if I go back to our case, this first case, where I said that, oh, basal insulin is the answer, actually, the CGMS showed that the sugar levels were okay during the daytime or just about okay, but there is a sudden surge at night after dinner. So just basal won't do. It has to be basal plus a bolus here. That should be the answer, and that is what the CGMS have told, and perhaps a little bit of exercise after food. This patient fasting all the time normal, but HbA1c is up. Look, so fasting here between 8 to 9, it is coming down here to just touching the normal range. But then after that, it all takes up, and throughout the day, it stays up. And that's why the HbA1c is 12%. So this area needs to be addressed. And that clearly this SMBG shows. The last one, that the blood sugar levels getting disturbed, sleep and nightmares. And you can see here that at around 2 o'clock, almost every day, the blood sugar drops in the hypoglycemic range. So we should cut back on the sulfonylurea before dinner. So there are multiple CGMS devices which are there in the pipeline, some using skin, some using eyes, some using earlobes. So we will see. Now, the Essentia Diabetes Care has come up with a monitoring system for 6 months. And just 12 days ago, the FDA has given approval. So I think in the near future, we will see these devices come to India, the implantable device, which will tell you continuously for 6 months, just give under the skin and forget. So technology is never enough. We have to remember technology on one side, you have to consider the patient, financial aspect, educational aspect. Can the patient comprehend? Can the patient follow what you're saying when you ask this to the CGM? Does the patient need help from others? Using common sense, because a pump or the CGMS cannot adjust your doses for exercise, heat, or GI index of food, infection, circumstance, other circumstances. So CGM is not the all and end all. It is just something to help you, something to help patients who are more acclimatized to using technology. And this group of patients is increasing day by day. And we should also warm up to that and help them, because as I've shown you, there is enough data to suggest that it does help in improving the HbA1c and reducing the hypoglycemia. With that, I end. Thank you very much. And I'll stop sharing now.
Question.
Thanks, Dr. Ganguly. Now we invite 2 or 3 questions from the audience.
From where we can get this flash glucose monitor?
Oh, it is now, I hope I'm audible now.
Yeah, you are very much audible.
Okay. So I think you can get both the devices, the Guardian Connect from Medtronic and the Freestyle Libre, which is from Abbott. It is now available. Although I think the company, they don't have that many representatives yet to have very quick or good service yet, but it is now easily available.
What's the price?
And the company representatives go and put it on the patients. You know, there are clear guidelines, clear booklets available. Patients can put it on themselves, but I think the company representatives can go and put it on the patients. For me, the representative came and put it on myself because I needed to know exactly what the process is.
Any more question to Dr. Ganguly? One more question, okay.
Thank you, Dr. Ganguly, for your wonderful presentation. It's always fascinating to listen to you, even at the fag end of our day. My question is that, what is your prediction? Is it going to elbow out HbA1c in coming 5 to 7 years? With collective data, it may replace HbA1c. And what is the guideline of RSSDI?
Yes, thank you very much for your very, very warm comments. So I think I don't see that it will go out. So you see, A lot of things have happened since HbA1c has been there. We have got, SMBG, capillary glucose has been there. So many CGMS devices have come up. So I think HbA1c will still say it will remain the gold standard. This will just be an additional tool to help. That's all I feel in the future. And I see in the future increasing role of this in inpatient care, in patients who need frequent checking of the blood sugars because they don't do the frequent checking. And it is vital for them to do the frequent checking, particularly those who are at very high risk of having hypoglycemia. So I see in the future more and more increasing role. So hopefully when this uses amounts goes up, these things will be a bit cheaper to go up. But I don't think it will elbow out HbA1c. HbA1c I feel will remain.
So, if any more question, you can always put it in the chat box. And should we conclude?
I think we can conclude now.
Okay. Yeah. So, a big thanks to Dr. Ganguly. He used to come in Abcdcon every year, and though this year you were present virtually, and we actually invite you to come physically in the next Abcdcon. We hope that the conditions will prevail at that time so that you can come. We really miss your lecture half in Bengali for as easily understandable to all the audience. And your lecture today is the last sweetening agent to the academic coffee we have delivered for the whole day. Thank you. Thank you. স্যারের কমেন্টটা ও লিংক কেটে দিয়েছো ও ওকে So we have come to end of our 7th Abcdcon. Every beautiful event has to come to an end, and it is more like that. But in the end, I conclude with giving thanks to all the participants, speakers, delegates. They are actually the crown jewel of any conference. The chairpersons who have participated, the pharma houses, namely many divisions of Cipla, Boehringer, Torrent, Vitabolics, Lupin, Ipca, Radicals, Fortis Hospital, Zabron Remedies, Sun Pharma, so on and so forth. And I would request everyone to come here. Before we conclude, I must give on behalf of the organizing committee, I must mention the name of Anirban from Boehringer Ingelheim, who actually in tandem with the organizing committee of ABCD worked relentlessly, and along with Shamol of the Zoom team, both of them actually made this event possible so smoothly. So a big thanks to them. And along with that, we also thank Mr. Dipankar Hajra of Bardhaman Bhawan with all his team. They work from breakfast to dinner. So a big thanks to them also. And all the technical hands who have worked for day long. So a big thanks to them also. And before conclusion, it is customary of ABCD from the beginning that we sing our national anthem with the whole organizing committee in the dais, and I would request everyone present in the room just to stand and put your voice in the national anthem, which will be shortly played. Please towards the audience.
जनगण मन अधिनायक जय हे भारत भाग्य
Thank you. And we are concluding our academic session now. And please join us for dinner at 7:30 onwards. Thank you.